Sound check. Sound check. Sound check. Sound check. Sound check. Sound check.
Yeah, for sure.
I'll go next. Good morning, everyone, and welcome. For those of you that don't know me, I'm Dr. Rupali. I'm a consultant neonatologist here at Mediclinic Parkview. And it gives me great pleasure today to be welcoming all of you to our first International Pediatric Hemodynamic and Pocus Conference. A lot of effort has gone into the making of this conference. And I've got my organizing team to really thank. Dr. Mohit Sahni, Dr. Kiran More, Dr. Monica, and Dr. Rajesh. Dr. Patrick and Dr. Daniel De Luca have, been a great help in guiding us through this and organizing our agenda and speakers. So a special thanks to them. Not to mention the PEMS team, who are the Pearl event managers, especially Mr. Danny and Mr. Salman, for all their efforts. And of course, the sponsors for our event, without whom we definitely could not have done this. We have an amazing set of speakers for you today, some of whom have been actually my teachers, my mentors, and dear friends. So I'm very, very happy that we're all here today to learn from them. We have quite a few talks today. It's a tight schedule. We start with delayed cord clamping. We have sessions on PPHN, PDA, and a variety of speakers doing these talks for us. I would request you all to put your phones on silent, please. If you haven't already been to the washrooms, they're actually across from this hall, across on the other side. We have the sponsor stalls in the room next door, and also tea and coffee available throughout the day. But please do visit our sponsors as and when you can. Now, without much further ado, I will leave you all to enjoy the day. And I hope that we all leave this hall and your Zoom links, if for those who are online, with a wealth of knowledge on neonatal hemodynamics, and hopefully a lot more questions than you have even now, because all these questions that we have actually help to generate future research, and very important to keep asking questions and learning. Thank you all.
To start with, I welcome Dr. Sohrab. He's a dear friend and president of well-known Dubai Pediatric Club, known for his conferences and CMEs. And he's a consultant pediatrician, very meticulous and very professional. Welcome, Dr. Sohrab.
Good morning, ladies and gentlemen. First of all, I would like to thank Dr. Monica, Dr. Upali, for inviting me here. Sessions are about neonatology. I want to give, just before introducing the speaker, just 1 minute, how the neonatology started. See, before 1889, there was nothing like neonatology. It was called neonatology. It means no neonatology. Were Stéphane Tarnier and Pierre Boudin in France. They started actually the neonatology. Stéphane Tarnier is known as father of incubator. He's a student. Coney went to America and started Coney Islands there. Pierre Rabin is known as father of perinatology. Today, our first speaker is going to talk about cord clamping. He was the first who did the major cord clamping research, and that time found that delayed clamping is better for the neonates. Who made neonatology? Anybody? Alexander Sheffer in 1960 in America called it neonatology. And when in the early 60s, when son of John F. Kennedy, Patrick Kennedy, died of respiratory disease, 34 weeks infant, Then they started doing research on neonatology. I'm not going to let, just remember Dr. Baku, Dr. Mehban Singh, Dr. D.K. Ward, Dr. Santosh Bhargav, the pioneers in India, just to remember. Well, it gives me a pleasure to introduce the first speaker, Dr. Anup Kataria. Dr. Anup Kataria is the director of the Neonatal Research Institute at Sharp Mary Birch Hospital and an adjunct associate professor at UCSD. His research focuses on delivery room intervention, particularly in umbilical cord management. He is a leading expert in neonatal echocardiography and point-of-the-care ultrasound. Dr. Kataria has led multi-center trials and contributes to the International Liaison Committee on Resuscitation. Outside his work, he is passionate about fitness, maintaining a regular Orange Theory routine. I would like to request him at the end to show us one slide about what is this Orange Theory. He's going to talk about hemodynamics of delayed cold clamping. Delayed cold clamping. Dr. Anu, please.
Hello, everybody. Sorry, again, I could not be there in person with you all, but I just want to thank the organizers, Dr. Moore, who invited me, and the other organizers, Dr. Sahan, Dr. DeLuca, and Dr. McNamara, for just organizing such a great meeting. And I do look forward to hearing about the other talks. I was asked to speak on hemodynamics of cord clamping, and looking at the agenda, you'll have somebody else talking a little bit about intact cord resuscitation. So I've sort of broadened it a little bit just to give you an overview of some of the physiology, and including some things on cord milking as well. So just briefly, I have no conflicts, but we'll be presenting a number of the trials that I'm involved in currently, as well as previously, all on cord management, but I don't think they will present any conflicts for this presentation. Now, just briefly, when we think about delayed cord clamping, I think before getting into the physiology, well, why does it work? And what's the evidence for how it works? And so there's obviously very good large RCT data suggesting benefits in both term babies for improving long-term outcomes, and in preterm babies reducing mortality. And by the mechanisms of improving blood volume, iron stores, reducing anemia, and obviously the avoidance of early cord clamping that plays into this. When many of us think about the concerns, though, about doing delayed cord clamping, it's usually one of these four categories here, whether it's placental insufficiency, whether DIMO twins or multiple gestation deliveries, the concerns for polycythemia and jaundice. But the big one is obviously delaying resuscitation. And so I usually spend a lot of time talking about alternatives for that group. But for those of you just wanting to read about some of the evidence why delayed cord clamping helps these other groups, you can read some of these other papers that I've cited down here below. Now, we'll focus mostly about the whole concept of babies that need resuscitation. And this gets into the mechanism of how placental transfusion works. When we think about blood moving from the placenta towards the infant, how does that happen after delivery? Whereas in utero, the blood was just moving back and forth. And really, there are four factors that play into this. Looking over in the top left, when you have an intact uterus, that's squeezing down on that placenta, it's providing 100 millimeters mercury of pressure with a nice tightly contracted uterus on the placenta that's going to drive blood forward through the umbilical vein. Conversely, the umbilical artery initially may be pulsating, but over time will start to spasm. And as we know, the artery is blood going away from the baby towards the placenta, and you want a net flow of blood going to the infant. Up on the top right, when we think of negative intrathoracic pressure with spontaneous respirations, breathing and lung aeration has been shown in epidemiological animal data, and now in some trials, that are breathing infants more likely to have the benefits of delayed cord clamping because you're lowering pulmonary vascular resistance, allowing pulmonary blood flow to increase in these infants and fill their lungs circulation with blood. And then probably most importantly, you need to have intrinsic cardiac activity that propels blood from the umbilical venous circulation into the pulmonary circulation. So a nice, healthy term vaginal delivered infants, you get a nice peak infant. And this is what we see in the majority of babies born every day globally that receive delayed cord clamping and healthy pregnancies. But what do we do in situations where the babies needs resuscitation, or the baby might need an emergent, be delivered by emergency section? Now the priority of the obstetric team is to give us, the neonatologists, these babies as soon as possible. And now what you're doing is you're truncating that normal redistribution of blood that should occur really soon after birth. In the first few minutes, it's being altered. And now you're not getting the same amount of placental transfusion because these 4 factors are being affected. So as we go through them, we think about the top left, a C-section. You've now cut through that uterus. In many cases, uterus may not even be contracted because the mother might have had preeclampsia and never even went through labor. We know that the extremely preterm babies, it's much more common. Nearly 2/3 of babies born under 28 weeks are going to have a cesarean section. That's not opposite, obviously, for term babies. We also know that spasming in the umbilical arteries in situations where you have a tight nuchal cord. Remember, the nuchal cord is not choking on the baby's neck or impeding breathing. What it's doing, it's pinching off that thin-walled umbilical vein, while those thick muscular arteries remain open. So now blood is essentially pouring out of the infant towards the placenta rather than going into the baby. On the top right, when we think about babies that have apnea, respiratory depression, or extremely preterm babies that have RDS, they're not going to fully aerate their lungs before the cord is clamped, and that's going to affect how well delayed cord clamping works in these infants. And then lastly, like as we highlighted before, in really severe situations where you have bradycardia or even asystole, it's unclear whether delayed cord clamping can do anything because you don't have that intrinsic cardiac pump. And so now you may get this baby very quickly from your obstetricians and allow yourself to resuscitate this baby, but now they have relative hypovolemia. And so we need alternatives. And that's where most of my work and many of us that have tried to focus on these scenarios is how do we provide a placental transfusion to these babies? And there really are only 3 sort of methods. One had been sort of grouped together for a long time, which was just cord milking. But we really know these are 2 separate entities where you either have cut cord milking or intact cord milking. And then you can ventilate the baby while the baby's attached to the mother, which is called resuscitation with an intact cord. And so first, I want to get into some of the other terms that we hear a lot about. We hear this term of physiological-based cord clamping. Well, what is that? It's really based originally on some animal data led by the group in Australia that said, well, in preterm lambs that are anesthetized and intubated, if you ventilate them while the cord is connected, you get a nice stable pattern of heart rate. You can see the same thing for cardiac output. But when you clamp the cord right away and then don't ventilate for a period of time, up to 2 minutes or so, and then ventilate, you see a bradycardia, you see a fall in left ventricular output, right ventricular output, everything goes down. And then it comes back up when you start to ventilate that preterm lamb. Now the question is, how applicable is this to the human preterm experience? And a recent trial then done by another group in Australia, Joe Smolik, show that if you shorten the duration where the preterm lambs, again, that are anesthetized, don't get a period of ventilation that's sooner, or sorry, the shorter time before the cord is clamped, now these preterm lambs are more likely to start to breathe and not have this drop in their heart rate. And the same thing was shown in the other parameters of cardiac output. So you now, in fact, see a stable heart rate or even a higher heart rate in those preterm lambs that have early cord clamping compared to those that get this, quote, physiological-based cord clamping. And so part of this is to think about how do we translate the animal data into human data. And in fact, when they get other sort of subsequent studies done by this group, is that breathing actually did not promote a placental transfusion in preterm lambs. So a lamb might be different than a human in terms of the actual breathing or whether they're going to see improvements in them. And so, in fact, venous flow actually slowed or stopped when the lambs were breathing, and there was no change in weight gain or no net placental transfusion. And so now they've taken this further and done the studies in babies while they're attached to the cord and doing ultrasounds on the ductus venosus and lymphatic vein. And interestingly, what they found is most of the blood going anterograde, that's towards the right atrium through the ductus venosus, happens during inspiration. And so as these babies are inhaling, they're pulling blood through the ductus venosus into the right atrium and providing a net placental transfusion. And so one of the things they noted anatomically in babies versus lambs is that the inferior vena cava collapse on inspiration happens caudal to the ductus venosus. So that collapsing that was impeding blood flow in lambs, actually in humans is caudal to it. So you're still getting flow going into those babies that you wouldn't see in a lamb. And so that's important because a lot of the hemodynamic research that we're going to be looking at really initially starts from the animal data, and then we have to extrapolate that into humans. Similarly, just thinking about the sheep placenta and looking at how placental transfusion works or doesn't work in this case is that a lamb placenta is many tiny placentas or cotyledons that fuse together into one short umbilical cord that has two veins, two arteries, and minimal Wharton's jelly. So it's a very different setup. And in fact, there is no placental transfusion that occurs in lambs. So when a lamb delivers, the cord just snaps and breaks. There's no period where the lamb is connected to the mother ewe. And so we're not normally seeing this in terms of what happens in nature. And then what we end up doing is in these preterm lambs is we drain their lung fluid, we instrument them, intubate them, and anesthetize before resuscitation occurs. So we have to try to say, well, yeah, this doesn't happen in our preterm babies, but what can we sort of understand in that physiology that it helps us to better determine what to do with delayed cord clamping? And then on the bottom right here, I showed you when you look at the net flow going into the preterm lamb, umbilical vein minus umbilical artery, the net flow is essentially close to zero. So there's no increase as you would see in a human where this curve should be going up because you're getting more net flow through the umbilical vein. Okay, so let's see what we can understand in humans regarding hemodynamics. And fortunately, we've had some good studies that have been done just in the last several years. A great study where they did cardiac ultrasounds during delayed cord clamping at cesarean section by the group in Cork. One of the first author was a fellow from Italy, and what he did was perform an ultrasound during delayed cord clamping as soon as the cord was cut, and then 5 minutes after. And he looked at a number of parameters, not just left ventricular output, but right ventricular output measures of diastolic function, and essentially showed that cardiac output improved with delayed cord clamping. It wasn't flat or stable. And again, there was no control group, but you can see here it's going up over time. We did a similar study of doing a 5-minute delay in healthy vaginal delivered infants using electrical cardiometry. And yes, this device has limitations, but you can see the trend of it going upwards from baseline, where for every minute that baby was on the cord, cardiac output and stroke volume went up by about 16%. And another similar study out of Turkey that looked at a much longer duration of hemodynamics after the cord was cut and clamped out to 24 hours, showing by the dotted line here, both stroke volume and cardiac output were higher compared to early cord clamping. So when we sort of go back again, thinking about how to apply this in studies, let's talk a little bit about resuscitation with an intact cord. Where are we at currently with this area? And you're going to hear about this in the next talk. Really 3 large RCTs in preterm babies that has been conducted: the VENT first trial in the US, the PCI trial in Italy, and the ABC, actually this is not right, 3 trial, ABC 3 done in Europe. All of them did not show any difference with intact cord resuscitation, whether it was from 2, 3, or even up to 4 to 7 minutes using a physiological based approach. And the control group was either a short delay or even cord milking. Well, what do we see in terms of term infants? These are term infants that needed resuscitation. So one big distinction is in the preterm trials, they just got CPAP right away because all preterm babies, particularly our extremely preterm babies, need some CPAP and some support at birth. This situation are term babies who are deemed to be depressed or asphyxiated, and you comparing giving them some amount of support, 3 to 5 minutes of delayed cord clamping or physiological based cord clamping compared to an early control group of clamping right away. And all of these studies did have some signal that the babies seemed to do better in terms of APGAR scores, oxygen saturation. interestingly, and I think this, as you're sort of hearing this talk, it might make sense, is they had lower heart rates. I just showed you some slides of improved stroke volume, improved cardiac output. Well, what do you think the heart rate should do? It should drop because you're basically giving these babies more preload, and therefore their heart rate does not need to go up as high compared to an early cord clamping group, which really could be substituted with an early hypovolemia group that would have more tachycardia. Unfortunately, the reason we're not doing this, at least in my opinion, we're not doing this because we're not seeing any clinical outcome differences between these groups. And so that's the piece that we're trying to sort of figure out is how do we make these babies actually do clinically better? The RENA study, just to be totally transparent, did show a reduction in babies admitted to the ICU, but they didn't show any differences in things like HIE, et cetera, that might be really clinically relevant for people to adopt this practice. So that's sort of where we're at currently. Okay, what about delayed cord clamping and placental? The big questions I get a lot of is duration and timing. And so when we think about the fetus and or the neonate compared to the amount of blood in the placenta, this is one of the best earliest studies done in the late 60s by Alice Yao, who coined the term placental transfusion. And what she showed here is that if you looked at the amount of blood left over the placenta over time, compared to what was sort of in the fetus, you could sort of have a good estimate as the amount of placental transfusion occurring in these babies. And really, it's important to look at the axis here, whereby close to 60 to 120 seconds, most of the placental transfusion that has really occurred. You've really emptied most of that placenta out. And really, the net gain you're going to get going out past 2 to 3 minutes is going to be minimal compared to the most of it happening in the first 2 minutes or so. And so that's one important point when we think about intact cord resuscitation, which is how long do we need to go to sort of get the benefit of blood moving into the infant. Now, the next point is how long is too long? And so, sorry, it's got to cut up on top here, but what I meant to reference here is another animal study by that same group I showed you earlier, by Smolik, that showed that, in fact, if you ventilate these lambs longer than 2 minutes, and so this went out to 5 minutes or so, in the first 2 minutes, you see this nice bidirectional shunting at the ductus level. You see some right to left shunting across the foramen ovale. And really, the whole idea of having some of this sort of elevated pressure sort of on the right side or in the lung allows you to have this sort of stable amount of blood flow that's going to be perfusing essentially the brain and sending enough blood down the aorta that's going to be coming out of the left side of the heart. If you ventilate the lungs for a long period of time, out to 5 minutes, or really after that 2-minute mark, what you end up doing, at least in the animal model, is you start not really over-ventilating the lungs, but you increase the amount of pulmonary blood flow because you drop the pulmonary resistance so far low that you have complete shunting at the atrial level, all left to right, completely left to right shunting across the ductal level. And unfortunately, what they showed was that they showed a drop then in cerebral perfusion, which sort of makes sense, right? If you have a huge ductal steal, we clinically worry about babies having brain hypoperfusion. And so is there a level, again, this is very speculative because again, we've just talked about the limitations in the animal model. Is there a point where too much ventilation, is particularly in an intubated situation where you're really ventilating the lungs, could be detrimental? And again, we have to contrast this. Is this the same thing as a baby spontaneously breathing? Probably not. You're probably not going to be overventilating in that point, but it's something for us to consider when we look at these longer durations of cord clamping. Again, well, here's another way to sort of look at it. If 120 seconds of delayed cord clamping with PPV, at 30 seconds, you're going to be seeing some nice, bidirectional shunting at the ductal level, and you're starting PPV, and umbilical venous return is going to continue in that infant. Then pulmonary blood flow will slowly start to increase, right? So now we get to the point where we go out to 1 minute and 30 seconds. We're starting to ventilate these babies, and we're going to see some slowing of umbilical venous return, but pulmonary blood flow is going to continue to increase. And so to sort of highlight that in that third situation, where now the duct is, instead of being bidirectional, by 5 minutes or so of life, these babies are now nice and pink, ventilated. We're continuing to give them PPV. Now we're getting minimal umbilical venous pressure, decrease afterload. And the big concern is here now, we have so much pulmonary blood flow in these infants, and the ductus is now all left to right. And we're worried about how much cerebral blood flow is happening in this situation. So I think this is the part we need to sort of figure out once you've cut and clamped the cord. In these situations, are these babies worse off? Are we not seeing the benefits that we should have seen in these studies, and especially in preterm babies that were getting long durations of intact cord resuscitation? Okay, so again, to sort of drive that graph home, seeing the decreases in blood flow going downwards when you get 5 minutes of life and clamping and cutting the cord, you've now dropped your systemic blood flow by continued ventilation in that subgroup. So looking at all these things together, is prolonged delayed cord clamping beneficial in the preterm in terms of the hemodynamics? One of the concerns is obviously maternal hemorrhage. If you go longer in these babies, are you having more maternal bleeding? I didn't spend a lot of time in this talk talking about it, but it's an important consideration when we're starting to look at longer durations in these infants. The other big thing, though, I think is in these trials, which I didn't talk about, is 2 of those 3 studies showed that the babies that had longer durations of delayed cord clamping with intact cord and ventilation had lower temperature in the NICU. And remember, we have good data from the neonatal network, as well as other data from Stephen Miller's group, saying that for every degree centigrade that the emission temperature is lower, you're increasing the risk of sepsis and death. And we know that moderate hypothermia even increases the risk of severe IVH. Now, none of these studies, to be very clear, showed an increase in any of these morbidities. In fact, they were either trending to be slightly better or they were neutral. But could we have seen better outcomes if these babies weren't hypothermic, or some of them weren't hypothermic? And this is something we need to optimize if we're going to do intact cord resuscitation. The other piece, as I showed you earlier, is most of the placental transfusion happens in the first 2 minutes. Is there any benefit of going longer if you're not getting more blood flow in these babies? And then I showed you earlier that the animal data is something we need to think about, which is cerebral blood flow might decrease if we continue to ventilate babies with the cord intact after 2 minutes. So I know I'm talking a lot about the whole placental transfusion, but this comes up all the time. Everybody wants to say, let's do physiological based cord clamping. And again, I think there's pros and cons of each, and I want to be completely neutral here. Time-based cord clamping, the advantages are that it's easier for providers to follow. And we've seen studies that show compliance with duration and improved outcomes. So the longer you go, you're improving outcomes from 30 seconds to 60 seconds, et cetera. We've seen that already. Now, too long might be a different story, but at least it allows you to have a starting point for these infants. What it doesn't account for, though, is that some babies who are really sick probably need to be on the cord longer, because what we do is the opposite. If they're too sick, we stop doing delayed cord clamping. But that really sick baby, as I showed you earlier, that nuchal cord infant, that if you could reduce the cord, or even a cord prolapse, those are babies that really need to be on the cord even longer, but we cut their cords right away. And this doesn't account for long aeration. A baby who's not breathing might just need more time to start breathing and then get the benefits of delayed cord clamping. On the flip side, there are advantages of physiological based cord clamping because you're trying to base it on the baby's physiology. You're not focused on the time. You say, okay, when that baby looks good and ready, I will clamp the cord, and it's focusing on lung aeration. Again, the downside is that we don't sometimes know what that means. We don't know how to implement this at every hospital that may not have the ability to bring CPAP or positive pressure ventilation to the mother, or doing it in a method that doesn't increase infection. The definition anything could be crying, breathing, an oxygen saturation above 80% at 5 minutes. We don't have a good definition of lung aeration. We don't have the ability to look in the lung, at least currently with during intact cord resuscitation, to see how well it's aerated. And we don't have good evidence. We don't have any trials that are showing that this is in fact beneficial. And so I think that's where the jury's still out. Okay, so for the last part, I just wanted to talk a little bit about cord milking. I'm not going to spend much time on cut cord milking. It's really just milking the cord once while it's cut. But I only had a 30-minute talk here, so I wanted to talk about some of the studies we've done with intact cord milking. So let's just get into the physiology. I don't need to get too much into all the different trials, but most of you know we did publish this trial of harm showing that milking the cord in small babies under 28 weeks show increased IVH. It also increased it only in the babies born by C-section. It increased the babies in the presence of chorioamnionitis. And so these are some of the factors. When you put them all together in this nice cartoon by Satyan, you can see here that when you milk the cord in a setting of a vaginal birth, where the placenta is being squeezed on by the uterus, right? We talked about that earlier. You're now increasing a lot of flow to that baby. A lot of blood is getting to that baby already at vaginal birth. And so now you milk that cord, and you're going to milk not only the artery, but the vein. So as you milk the vein, what you're going to see is that blood is going to skip across the foramen of a valley, because these babies have poor respiratory efforts and having high right-sided pressures. What that does is that increases the amount of left ventricular preload in this setting. And at the same time, you are also going to be increasing the amount of blood going into the aorta, because you're squeezing the umbilical artery. They're both in that cord. And that's going to increase the amount of blood in the descending aorta and the pressure in the descending aorta. As you have these two things sort of converge in the carotid artery, that increases carotid artery blood flow. And now what we found was babies who had chorioamnionitis did have severe IVH. The ones who did not have IVH. So you have now this inflammatory storm with this increased amount of blood flow. You're adding that the tiniest babies, the 23, 24 weekers, have really fragile germinal matrices. They're more likely to rupture, and they're getting all this extra blood flow. And putting all that together, sending that to the brain, is probably what we think causes severe IVH, which is why it's important to look at the nuances, which babies are at high risk and which babies might not be at any risk and actually can benefit from that extra blood flow. The breathing piece is also a huge part of cord milking, right? If they're not breathing well, that's likely going to cause more blood in that left side of the heart. So let's look at that in terms of what the animal studies have shown. This is a nice study by Praveen Buffalo, who looked at ventilating these preterm lambs versus not. And you can see the percentage of fluctuation from baseline was dramatically increased in the carotid artery as well as the pulmonary artery versus when they were ventilated. So you didn't see that same amount of harm. And that's an important point to think about. We looked at the clinical outcomes now in babies above 27 weeks, so 28 to 32 weeks. In fact, showed no differences in any of the outcomes of severe IVH, any grade IVH, or death. These were all identical. And that's important when we look at good population data. This is over 1,000 babies now where there's no increase in IVH rates. And then this was 28 to 32 weeks. What about in older babies? So our MINV trial looked at non-vigorous babies who were above 35 weeks and up, who were depressed at birth, not breathing at birth. And we showed a reduction in the number of these outcomes, such as HIE, the need for cooling, had better 1-minute APGAR scores, needed less resuscitation in the delivery room. So all of these things really highlight that in some groups, particularly older babies, milking might be preferred over early cord clamping. To sort of talk about, since this is a hemodynamics talk, we did an echo sub-study, and we showed improvements in left and right ventricular output, improvements in their overall function, slightly worse TAPSE, so maybe some right diastolic dysfunction because you're stretching that RV, but every other parameter was essentially improved. And then even more recently, we just showed that their 2-year outcomes by ASQ scores. We did the same thing for MCHAT scores, were all essentially the same, whether you had your cord milked or your cord clamped early. And so putting all these together, looking at the hemodynamics and the short-term benefits, right? We showed better improvements in outcomes. And now in the hospital, and then long-term, it doesn't seem like these kids who are getting cord milking are having strokes or emboli or things that are causing problems with development. It's likely to be safe. And so that's sort of our take on where cord milking lies in terms of an alternative when babies can't get delayed cord clamping. And so to sort of sum all this up together, when we look at cord management, really only rare situations where immediate cord clamping needs to happen, when you have a tight nuchal cord that you can't reduce, a cord avulsion. But as I showed you way back earlier on the first slide, even thinking about situations with twins and other situations where this actually could be done. And then again, milking can be an alternative, particularly above 28 weeks, where we haven't seen any harm whatsoever, and definitely in the term non-vigorous baby. In the future, maybe intact cord resuscitation will become standard of care, but I think at this point it still needs further study. And I just want to highlight two studies that I'm really honored to be a part of. Carl Box at Nationwide Hospital, we are doing a study with Kevin Hill and looking at over 500 babies who have critical congenital heart disease. These are babies with transposition who need surgery right away after birth, and looking at giving them extra placental transfusion compared to early cord clamping. How does that improve their post-op outcomes using a global rank score? And then really happy to work with Zubair Guy in a study out of India, where we are going to look at HIE, right? Because in India, the incidence of HIE is 10-fold higher. And so can we prove that milking has a benefit in this population, particularly with the controversies with cooling, et cetera, could be a nice tool for low middle income countries as well. So thank you very much. I'm just really grateful for all my collaborators, neonatologists. This was our group meeting for the Minvi trial. And then our trial we are doing out of India with all the Indian investigators came down to the US for a recent meeting a few weeks ago. So thank you for
very much,
collaborating.
Dr.
Thank you for your
this
time.
excellent, informative talk, which was illustrative also. Now, I would like, since we have online questions also, we would like to request you to questions are after. Okay, so it gives me a great pleasure to introduce the second speaker. But before that, at one point, I would like to. We'll take question later on. Just, remember Hippocrates 2,500 years back said, first do no harm. First thing, don't do harm if you're not doing something good. One thing Dr. Anup mentioned about Apgar, Virginia Apgar in 1948, she was anesthesiologist. She described it later on in 1953, published in Anesthesia and Analgesia. She did on this called clamping. I'm not going to detail of that. It started there. Now, at one point, I will say, then I'll introduce next. Dr. Anup is the ultrasound, point of care. Ian Donald is the father of ultrasound in obstetrics. He said, my first patient was in labor for 5 days, and I too. So remember that. So it gives me a great pleasure to introduce the second speaker, Dr. Chakrapani. Fellowship from McMaster University. My voice is very loud. With the fellowship from McMaster University and University of Toronto, he specializes in neonatal neurocritical care and hemodynamics. At CIDRA, he has been instrumental in developing neonatal neurocritical care program. His research, including major projects like ETHOS and DEFINE, has significantly advanced neonatal medicine. Dr. Chakrapani is going to talk about hemodynamics during transitional circulation and physiological cold cramping. Please welcome Dr. Chakrapani.
Thank you, everyone. Thank you, organizers, for inviting me to give this interesting topic. And I think I have only 15 minutes. I will straight away go to the topic. I don't have anything to disclose. So I'm going to briefly talk about the fetal circulation and the transition circulation so that we can see the difference between the fetal circulation and transition circulation. And after moving from transition circulation, I will talk about briefly about how we can able to hemodynamically monitor the babies during transition circulation. And then I will talk about the physiological cord clamping, which is mainly about the livestock trolley. So transition circulation is normally a brief period when babies are born, either preterm baby or term babies. So they're going to change completely from in utero environment to ex utero environment. So what are all the changes going to happen on those babies? It's very critical, right? So some babies can kind of transition smoothly. You don't have to do anything. In some babies, you need to do, you need to help the babies to move from the in utero environment to the ex utero environment. So, yeah. Okay. So I think we have seen in Anup Kataria's talk about placental circulation, but I will briefly go through the fetal circulation first. So three things we need to know about hemodynamics is: one is preload, other one is the myocardial contractility, and the third one is the afterload. So if you see here, the preload for the fetal circulation is mainly comes from placenta, right? That's umbilical vein. That gives the preload, and most of the preload. Can I get So if you see the preload, I think most of the preload goes to the left atrium through the pattern foramen ovale, and then that's how we can maintain the left ventricular cardiac output in fetal circulation. And the major problem for fetal circulation is the PVR, because the lungs are collapsed. So we have an increased PVR. So because of the increased PVR, so the right ventricle could not able to pump against the afterload. So most of the blood comes from the right ventricle, as will be shunted through the ductus arteriosus, and it goes to the descending aorta. So upper part of the body will get most of the oxygenated blood, and the lower part of the body is going to get most of the mixed blood or less oxygenated blood. And you can see that the umbilical arteries are going to get the blood again to the placenta so that it gets oxygenated, and then the cycle goes on, goes on. So changing into transition circulation. So you can going to clamp the umbilical cord. So when you clamp the umbilical cord, you're doing two things. One is you're clamping the umbilical vein, which is providing the preload, which was happening before in utero circulation. And then you're clamping the umbilical arteries, which is going to increase the systemic vascular resistance, because that was the drainage channel from the baby to the placenta. So because if you remember from Anup's talk that the arteries have thick walls and the vein is the kind of thin wall structure. So when you clamp, so obviously you're cutting the preload first. So cutting the preload is going to cause change in hemodynamics. And that's the reason that most of the babies who are not transition smoothly, they do increase the heart rate, to compensate the cardiac output. If your stroke volume is going down, you need to increase the heart rate to compensate the cardiac output. But if you maintain the stroke volume, then the heart rate automatically drops down. So, so once the umbilical vein is kind of clamped, so you have a decreased preload. At the same time, if your lung is not oxygenated properly, the transition doesn't happen, baby is not crying, then it means that the pulmonary vascular resistance is not going to decrease. Pulmonary vasodilation doesn't happen. Then imagine this, there is a decreased preload here, and then at the same time, baby is going to pump against the increased afterload because of the poor transition. That is going to be a problem for the baby. So if there is an increased RV afterload, then the blood comes from the lung to the LA. That is the main preload for the left side of the heart is going to be decreased. So overall, what it means is if the transition circulation doesn't change smoothly from fetal circulation, then baby is going to expose to decreased preload. That's what we said here, and then increased RV afterload. And because of that, you're going to have a LV decreased preload, and essentially baby is going to have a severe compromise on the hemodynamics. So let's see on term babies what happens. So as I mentioned that you need to be significantly concerned about the preload changes, myocardial contractility, and afterload changes. So the term myocardium is completely different from the preterm myocardium. If you see the myocardial contractile elements of the preterm baby, which is like more water molecule and less contractile elements, so that they could not able to adapt as good as the term cardiac myocardium. So so the term myocardium is better than the preterm myocardiums in terms of adaptation for the increased systemic vascular resistance, which is the LV afterload. So if there is any abrupt change in the preload because of the transition, and it can be kind of compensated by increasing the heart rate in the term babies. So in preterm babies, So the main problem in preterm babies, as I said that, so the lung is not actually completely developed like a term baby. So you are going to have a concern about the increased afterload from the RV. At the same time, if your preload is also compromised, so the baby is going to have a poor right ventricular output, which is going to cause the preload issue for the left ventricle. And essentially, if you have more and more extreme preterm babies, they have a fragile blood vessels in the brain, and along with the changes in the hemodynamics, that is going to cause a bleed in the cerebral circulation. And the other problem for preterm babies is they do have a persistent fetal shunts. There are two shunts that we always concern about. One is the patent femoral ovale, other one is the patent ductus arteriosus. So if you see, depends upon the pressure difference between the right atrium and left atrium, the shunting is going to be different. If you have a complete right to left shunt across the atriums, that is also abnormal. And if you have a too much amount of left to right shunt across the patent femoral ovale, that is also a problem. So if you see any babies who are on complete right to left shunt across the PFO, so think about like something grossly wrong on these babies, and you need to kind of dig for more investigations like kind of congenital cyanotic cord disease and other things. So we're moving into the hemodynamic monitoring in transition circulation. So we do have, functional echo. Obviously, this is a kind of most common one. Then we all use it during the transition circulation. But the point is, you can't do functional echo, every hour or every minute for the baby, right? During the transition, it's very difficult. So even the studies, when people do, they can do it like 2 point of time, and our maximum, I think in one study, I think people did it like 0 hours, 6 hours, 12 hours, and 24 hours. So that's a limitation of the functional echo. But other monitoring devices, like one is the electrical cardiometry, and so electrical cardiometry will provide multiple parameters. You can measure the flow, you can measure resistance, you can measure the systemic fluid status and myocardial contractility, and you can see the various changes. But the point is, it's still in the research environment. It's not for the clinical use yet, because we're still validating the findings of electrical cardiometry's results for the clinical use. And the other device commonly used in studies is near infrared spectroscopy. So let's see about echo first. So for the echocardiography, as I said, that it's definitely an excellent device, but and non-invasive device. But the problem is you cannot do it like continuously. That's the only problem. And so the key areas that we usually see in echo is, one is about the shunting, what's happening across the PDA and PFO. Other one is like how is the pulmonary pressure and how is the cardiac function. So when you look at the pulmonary hypertension, so I think this table is like very interesting. You can see that. This is the normal transition, right? So you have a left atrium, left ventricle, right ventricle. And in normal transition, babies having a normal parenchyma, lung parenchyma without pulmonary hypertension, and they do have good recruitment if it is a preterm babies with surfactants and adequate PEEP. So you can see this is a normal hemodynamics. So you don't have, so the shunting is left to right across the PFO, and in PDA left to right shunting, right? And I'm going to move from here to here, I think, pulmonary hypertension. So you can see the pulmonary hypertension one. So obviously here, so you have abnormal lung or abnormal transition. It can be a pre-capillary pulmonary hypertension, or it can be a pre-capillary and capillary combination, or pre-capillary, capillary, and post-capillary pulmonary hypertension. Depends upon your baby's underlying lung disease, right? So the hemodynamics changes. Yes, heart is having high afterload because of the increased PVR. So you're going to get a back pressure from pulmonary vascular circulation. So you're going to have a TR, and then the right to left shunt across the PFO, and you can see the right to left shunt across the PDA, right? And so moving from here, which is pulmonary hypertension, to duct-dependent circulation. As I said before, if you see a complete right to left shunt, see, compared to the PPHN, you might have a predominant right to left, but unlike here, it's going to be 100% right to left shunting. Yeah. So if you see a 100% right to left shunt across the PFO, you need to think that, okay, something wrong here or here, right? So here means it would be a tricuspid atresia, or here it might be a pulmonary atresia. or critical pulmonary stenosis. That's the only reason that the blood is not flowing down here or out of RV. So that's why you see the 100% right to left shunt. So that is a critical condition. So you're going to start prostin. That's going to be a duct-dependent pulmonary circulation. And moving from there to this area, so you can see this is very interesting, right? Because we commonly think that the left right shunt across the left atrium to right atrium is normal, but you always think that if you have a predominant left right shunt and you need to see how the LV is doing, right? If LV is not working well, and LV dysfunction, especially diastolic dysfunction, so there's going to be an increased end diastolic volume in LV. That's going to give you a back pressure, so you're going to have a left right shunt, right? So always think if you have a left right shunt across in between the atrium and the right to left shunt across in between the atrium, so think carefully and rule out underlying physiology. So in this one, I think many of the pulmonary hypertension parameters that we see in echocardiography. So as I said before that you do use the continuous wave Doppler. We're going to see in tomorrow's echo workshop to see the elevated pressure across this. This is a kind of indirect marker. So you cannot do a cath to monitor the exact precapillary pulmonary pressures. So that's why we are using the echocardiographic non-invasive method to see what is the tricuspid regurgitation. So I'm going to calculate with the Bernoulli's equation 4V squared to get the right ventricular systolic pressure, RVSP. And also you see the septal position, how the septal position, that is going to again indirectly tell you how is the pressure on this side compared to this side. Yeah. And the shunting across the PDA. So other important area is, other important area is HAE and therapeutic hypothermia in terms of term babies. So you look at the baby's myocardial function, especially in HAE, because there is an oxygen deprivation and blood flow deprivation in HAE babies. So you measure the cardiac function. So there are various parameters that you can measure it in HAE by using echocardiography to understand the hemodynamic, what's going on. So you can measure the left ventricular output, and then you see what is the cardiac function in terms of modified Simpson's calculation, and you see how is the TAPC right ventricular function, because most of the HAE babies do have associated pulmonary hypertension because of the increased PVR, and they do have hypotension. So you're going to deal with myocardial dysfunction plus pulmonary hypertension plus hypotension. So it's going to be a kind of how you balance the hemodynamic circulation. So you need to understand the physiology. I think the management is not a one-word answer for all these babies. So you understand one physiology and then go back to the cause. What is the basic underlying cause? And then you move one step forward to treat them, because if you treat exactly what is the problem, then you may not have to you will not reach the goal. So these are the advanced measures that we do, the tissue Dopplers and deformation imaging, like global longitudinal strain and the strain rate analysis. And as I said, that I have a very brief slides about ICON. So this is one of the devices that we use in our institution to understand. So we still as I said, that in the research environment, it's not for the clinical use. So you do see various parameters using this electrical cardiometry. And we do have multiple devices, and we are doing a lot of research with this device now. So this is from one of the unpublished data from our studies. As I said, that it's like CRP, right? So if you do one value, then it's no use. If you need to have a longitudinal trend of this data to understand what is happening on various physiology. Again, you don't have a gold standard measure to validate this data for each and everything. For example, a lot of studies you can find, then they would have cardiac output to compare with the echocardiograph cardiac output to compare this one. But I think recently people are interested into measuring the systemic vascular resistance for preterm babies using this electrical cardiometry. I think there's a paper published last week. So as I said, that still in research area, this is a systematic view says the same thing. And then this paper came last month. Again, same thing is what is the recommendation? So it's still not recommended for the clinical use because it's not accurate determinant of cardiac output. Moving into another machine to understand the transitional hemodynamics is the near infrared spectroscopy, and we've been using this device for last 60 years, but still we are trying to understand how effectively we can use. This is one of the study from Anup, neoprom trial, I think in 2017 or something, and they try to use the machine to see what is the benefit. So they thought that it may be possible to use the NIRS in delivery room to predict the severe IVH and early death. This is an observational study, obviously. So from there, I think we have a recent, last year, I think there was a paper published, I think COSCOD-3 trial. So the COSCOD-3 trial is mainly about, how NIRS is going to be useful in delivery room, mainly for preterm babies during the transition circulation. And obviously, I think the study kind of concluded that there is no kind of a difference as of now. So the other trial, I think published again in 2023, it's a Safe Boost 3 trial. This is for first 72 hours of life. I think they use the NIRS device to see the difference in outcome. Again, there is kind of no obvious difference in outcome, but as of now, we can decrease the hypoxic period by using the NIRS, but is there any clinically meaningful outcome? So as of with the COSCOD-3 and Safe Boost 3, so we don't have any kind of big data on this part. So moving to physiological cord clamping briefly, I think mainly we are going to talk about the livestock trolley here. This slide is kind of another presentation what Anup said in the last talk. So you have immediate cord clamping and then umbilical cord milking and physiological cord, delayed cord clamping. So obviously you have a lot of benefits in delayed cord clamping. We've seen the multiple benefits. So umbilical cord milking. So not all the institutions are doing, but delayed cord clamping is widely adopted by ILCOR, and this is the kind of standard of practice now. So we are doing at least 1 minute of delayed cord clamping for all the vigorous term and preterm babies. So I think this is the group. I think they started doing a lot of research on the physiological cord clamp. Mainly, I think Stuart Hooper started in Australia in 2013 with the animal model, and then Ajahn Tepos. So basically what we think is like, or what the authors think is that if you aerate the lung, the transition happens smoothly, then everything kind of the systemic hemodynamics is going to transition smoothly from fetal environment into the ex vitro environment. But does this happen clinically? Let's see. So this is the kind of first ABC trial, I think was conducted in published in 2018, 2019 in ADC. So in this one, I think they use the Concord machine, and this is a kind of modified version of the livestock trolley. So what did they found? I think this was a feasibility study mainly. So just kind of, can we use this machine, to do the airway breathing circulation kind of trial. So yes, they said that yes, we can use it, but what they find interestingly is they did observe some hypothermia, especially because these babies are kind of brought into this Concord machine, so that they have a higher chance for hypothermia. So moving into so what about the next steps, right? So how are you going to kind of say that this is going to be clinically useful? So, but first thing, I think they only recruited 37 babies in this preterm babies, and they are between the gestation age group is around 30 weeks. So with the feasibility trial, they moved into the second study. So to see the effectiveness, right? So the ABC2 study. So in the effectiveness, they kind of targeted less than 32 weeks mainly. So what happens? So they find like there's no difference in the any of the basic parameters. And this is the conclusion. So stabilization of preterm infants with physical cord clamping is at least as effective as a standard delayed cord clamping. So with the ABC2, they moved into the ABC3. So this is a kind of larger RCT to see what is the effect of a physiological based cord clamping in a multi-center trial. And again, they don't find any kind of clinically meaningful outcome between the two groups. I'll just kind of move into the final part. Sorry. Yeah. So the when first study has been published this year. So again, when first study, I just want to kind of highlight that this is the same thing, physiological bed cord clamping. They did not show any kind of clinically meaningful outcome for providing assisted ventilation before cord clamping in extremely preterm infants reduces IVH or early death. So with that, I think I would say that as this stage, I think physiological cord clamping, yes, physiologically, theoretically speaking, that you breathe the, aerate the lung and you can transition from in utero to ex utero environment and everything goes smooth. You can kind of reduce the IVH and, improve the outcomes. But is it kind of represented in the randomized control trial? Not yet. So each institution should have their own protocol for physiological cord clamping. And we need to be kind of open to the parents about the benefit and all, because I think all this studies done in especially in European studies, if you have a Concord or lifestyle trolley, parents are willing to use this one. So they said like, no, if you have that one, let's do the resuscitation next to me, so that will improve the outcome. But the studies are not yet kind of given the complete change. So we just need to be open and you need to have an institutional guideline for that. Thank you.
Okay, thank you. Thank you, everyone. I think the forum is open for question. Even the online people can put their questions in the chat box. We have Anup online and Arvanan here. So I know. Any questions? So this was the starting session for transition physiology. The idea, most of us have moved toward delayed cord clamping, and the aspiration is to move towards physiological cord clamping, which needs a lot of effort. Despite having trolley in-house, I think we had a difficulty, especially in the Middle East. I think that's something very far-fetched to achieve, to go near the mother to resuscitate. So one question.
Thanks, Anup and Arvanan, for your excellent presentations. Lot of work on the delayed cord clamping is happening on the research front, and it's been done well. I just want to know on a practical point, for example, in the UAE, how do you all do your delayed cord clamping in the preterm babies? How do you maintain the temperature of the babies? What sort of do you use a livestock trolley? What do you all use? Is any of you from the bigger units here want to make a comment? Because we find it difficult in this Sidra, because we are unable to use livestock despite being there for 5 to 6 years for a variety of reasons. It's not just one reason.
Anyone want to answer? Okay.
So Alok Sharma, I work at the Cornish. Hi, Anup, how are you? It's a challenge. I think, we've got to acknowledge that there are cultural considerations that need to be respected over here as a first. I think the second aspect to it is naturally there's an infrastructure element to it that's required. The investment, just to give you an example, Ronnie Knowles trolley, it's 53,000 euros. So, one trolley for a unit as large as ours, which kind of delivers and has about 75 babies on the unit, there are going to be challenges around it. So in terms of practicing physiology-based cord clamping, that is a challenge. Time-based cord clamping within remits, done sensibly, in a breathing preterm baby, is something that is practiced. And again, then there are the challenges around maintaining normothermia in that environment. I think I would say we do it, as good a job as we can. And yeah, we'd like to aspire towards moving towards physiology-based cord clamping. But those cultural considerations, we have to kind of overcome some of these barriers before we can make that jump.
Maybe Anup, you can comment how is it happening and taking up in US about physiological cord clamping?
Yeah, no, I think this is great. And sorry, again, I couldn't be with all of you in person. But one important thing is a lifestyle trolley actually doesn't provide sufficient heat. For those of you that have used it, you actually have to add a chemical mattress just to provide some warmth to the baby. In the US, most of our centers are targeting getting close to 1 minute. Although I will say many small babies, particularly at that 22, 23-week gestation, aren't even getting it. And so this is why I find such a fascination with the term, let's all do physiological base cord clamping and go to 4 or 5 minutes when most of our babies aren't even getting that first minute. And so I most of the time focus on talks of just doing everything else you would have done. Even before putting a face mask on the baby, you try to provide some support for the baby, getting the baby wrapped up, warmed with some mattress or something below. And most importantly, having a neonatologist near the obstetrician to be able to provide some support. And I would tell you, most of you, that before you're looking to buy one of these trolleys, just focusing on improving your rates of delayed cord clamping by implementing some of these things with your obstetricians, by being present, I think will do so much. I think you get such benefit of just getting to 60 seconds, provided sorry, I had a very short time slot, but we've shown in a previous study that 90% of babies will start to breathe by 60 seconds, but around 30 to 40 seconds, only 40% of babies are even breathing at that point. You need to give these preterm babies time to start to aerate their lung. And so I am still biased that we still need to focus on getting to that first minute. I think the physiological based cord clamping really is just an approach that the sicker babies need more time on the cord. So that's just, sorry, more than you were asking. You were asking what the US is typically doing, but I give you a little bit more there.
Sure. Thank you. Any questions in the audience? We are not able to see any online questions yet. Maybe people should start putting on the chat box. Anyone in the audience have any questions before we move to the next?
Arvind, an excellent presentation. Just wanted to ask one question about the hemodynamic assessment of such babies. In the first hour of life, there are so many changes happening minute by minute and hour by hour. And obviously in the research protocol, you do it at set times, but what you do at 15 minutes of age may not be relevant at 1 hour of age. How do you address that question in a clinical practice about the management and the treatment?
Thank you, Dr. Soni. I think at this stage, I think we are trying to understand what is happening on in the transition. I think I don't think we can work on any management changes as of now. So all this kind of echo and the monitors and all is to understand that what is happening on that one. I think the transition, if you do a delayed cord clamping or if you don't cut the cord, like what is happening, that's all we are trying to understand. I don't think we can change anything as of now by providing any treatment measures. But as I said, like I think 15 minutes, I think you do have echo, and then you see this is a kind of left ventricular output, and also 1 hour you're repeating the echo. Obviously, you see the changes. So we just kind of able to understand that it's okay. It's kind of increasing the left ventricular output, and those are the understandings only. I don't think we'll change anything on the management aspect as of now. But if the baby is kind of intubated, so you need to see this surrounding management strategies, what is happening on the baby, that is going to affect the hemodynamics, like how is the kind of oxygen requirement, are we given the surfactant to reduce the pulmonary vascular resistance, and how's the temperature management of this baby. So those are the things, because most of the units do have a golden hour program. Within 1 hour they try to kind of settle the babies in. So you might be doing the lines for this baby, so you might be covering the babies with the so that increases the risk for hypothermia. So each and everything that we do on the baby, not only the lung aeration, that's going to affect the hemodynamics. So we need to be kind of careful about hemodynamics, not only giving the CPAP and then or intubated the baby, that's going to settle the hemodynamics. Everything surrounding the baby, that what we are doing is going to affect the hemodynamics.
Okay, well said. I think rather than what not to do is more important. I think we overdo. Like in saturation monitoring, now we wait, right? NRP says wait for 7-8 minutes till you reach 90% saturation. Similarly, blood pressures, cardiac output take time in transition circulation. You don't have to jump on to fix the number. I think it's backing off is more important in such situation. And studies like this and presentations like these are basically addressing that. Okay, you need to understand there's a physiological change which is happening and allow that baby to go through that change and then jump. I think that's more important. So yeah, sir.
Conclusion, if there is no question to, yeah, please. Yes, Doctor.
Just a comment, not a question. I just want to say that actually doing delayed cord clamping requires a lot of coordination with the obstetrician, and even more than cultural problems, I think that's one of the things that we have to overcome in most situations. Having the obstetrician have a bit of confidence in what you're doing and to coordinate with them prior to the delivery. So that was just one of my comments. Thank you.
So before ending, I would like to give a comment. Dr. Monica and Dr. Upadhyay said we'll ask one question in order to keep you awake and not to look at your mobile. The question: this umbilical artery, we know arteries they carry oxygenated blood. Why it is called artery, and where else is the second one? This question, Freud say Freud is the father of psychology. It has no mother. But pediatric cardiology has a mother. What is the name of that father? To remember Perloff as the father of cardiology, and in India, Tandon, in All India, father of pediatrics. Now, one thing I want to say, Hippocrates 2,500 years back said, nature is the best physician. To do nothing sometimes is the best treatment. Now, Dr. Chakrabarti mentioned about heart, the capital of India. Where is capital of India? Delhi. It is called after the heart. When I ask people why it is called Delhi, they don't know. Delhi has 4 chambers. Heart has 4 chambers. Auricles, ventricle. Auricles in Urdu called Dehlis. People could not pronounce Dehlis. Dehlis, Dehlis, Delhi, Delhi, Delhi. It became Delhi. When you ask people why it is called Delhi, they say Dilwale. But they don't know why it is Dilwale. Thank you very much. If you answer my question, at the end you will get prize. Dr. Monica, thank you.
It was enlightening
Thank
for
you.
the Indians also. We didn't know this.
Thank you so much. So I would invite the next chairperson, Dr. Shiva. He's a good friend, heading the big public unit, Latifa Hospital, and tied up with Jalila Hospital, Dr. Shiva.
Thank you, Monica. The next session is about hemodynamics in the care of extreme preterm babies. As a neonatologist, the hemodynamic changes in an extreme preterm baby troubles most of our neonatal population. Neonatologists are always, we have a lot of questions, and there's no better person to answer these questions than Dr. Patrick McNamara, who is a global authority in neonatal hemodynamics. He is the director of neonatology at the University of Iowa, and he has published over 350 peer-reviewed articles and chairs multiple international collaborations. His work on neonatal cardiovascular care and targeted echocardiography has significantly advanced the field. Dr. Patrick McNamara, the field is yours, the stage is yours. Thank you.
Good evening. Can you guys see the slides? Okay. Yes. No.
Yes.
Okay, perfect. Okay. So it's almost 1 a.m. here, kind of in the Midwest of the United States. It's a real pleasure. I want to thank everyone on the organizing committee and commend them on their kind of diligence in actually proceeding with this event. It is not easy to host a conference and to put things together. So well done. Second, apologies for not being able to be there in person. This particular month is I'm just inundated. I just got back from the UK and Poland, and I'm heading off to South America in a week's time. So it's just been a bit chaotic for me. I'm delighted to share the stage, at least virtually, with my good friend Samir Gupta. And kind of, I think, hopefully by the end of the next kind of hour and a half or so, kind of we will have certainly shared additional insights into, how the field of neonatology and neonatal hemodynamics certainly needs to evolve. And, in a nutshell, the simplicity of what we have tried to provide neonatal care has not led us to the place we want to get to. And I think what's probably going to be most clear, and I've heard several times in the last talk, physiology, dynamic nature of physiology, if we don't pay attention to this, we're never going to move forward. And that's certainly most applicable in the most extremely preterm babies. So if you look kind of over the last 20 to 30 odd years, kind of we have made progress, particularly at the limits of viability. More babies are surviving than 10 years ago, 20 years ago, and so forth. Yet, despite enhancing survival, there continue to be challenges with major morbidities. Intraventricular hemorrhage, necrotizing enterocolitis, bronchopulmonary dysplasia continue to happen at a fairly significant rate. This is a slide I put together which looks at two very different approaches to the care of extremely preterm babies. The data on the left-hand side is survival rate in Sweden. And in Sweden, it's a very non-interventional approach. Try to avoid intubating the babies, a very non-aggressive approach to the PDA. And then you go to Japan, and this is mortality, and a very different approach. These tiny babies, and I've been to Japan, are put on ventilators, stay on ventilators for weeks to months, empirically started on vasopressors, dopamine, dobutamine, and some other agents. A very aggressive approach starting off with prophylactic indomethacin. What's most interesting is that survival rate at 22 weeks gestation is the same. So how do you reconcile completely polar opposite approaches to care, yet a similar survival rate? So I think the paradigm in neonatal care and also hemodynamics needs to really move towards more focus on diagnostic precision. And if you look at this very simple kind of picture at the top, when you have a high degree of diagnostic precision and you have a treatment that appears to make sense, the balance is likely to weigh towards treatment efficacy. On the contrary, if you've got very low diagnostic precision, the balance is likely to weigh towards the adverse effects of therapy. So if we apply this principle to the babies in Japan and Sweden, in the Japanese centers, patients who actually received empiric therapy potentially have treatment-related harm. On the contrary, babies in Sweden may have unrecognized physiologic states or disease states which remain untreated, and you may have disease-related harm. Common to both approaches is diagnostic and therapeutic imprecision. So if we think of the two most common problems we think and talk about in contemporary neonatology, treatment of hypotension, treatment of PDA, the evidence to date has shown that treatment does not make a difference. And this may make you think, okay, these things are not important or treatment is not important. But the most fundamental question to be asked is, have we appraised these clinical entities in a way that makes biological sense? If you look at, and this is an interesting paper from the pediatric database, in which they've reported treatments prescribed to infants at 22 and 23 weeks gestation, what you will see is that dopamine is the fourth most common medication given in the first postnatal week, almost as common as antibiotics and surfactant. And that would lead you to believe that hypotension is a very important and common problem. On the contrary, we have observational data like the study from Bo Batten, which demonstrates that infants who receive treatment for hypotension are more likely to die or have abnormal neurodevelopmental outcome. Many individuals have interpreted this to mean that we should not treat babies who have low blood pressure. The counter approach is that perhaps we have oversimplified something that's much more complex, and perhaps we need to think of blood pressure in a very different manner. This is an algorithm that was published around 20 years now ago, which suggests that the approach to cardiovascular care in preterm babies should focus on mean arterial pressure and trying to reach these thresholds. And the algorithm suggests a very rigorous, draconian approach with one medication, typically dopamine, followed by dobutamine and so forth, in a very imprecise type of manner. Sadly, this is still practiced in many countries. One of the fundamental issues, however, is when we look at how often do people perform an echocardiography for hypotension, it is pretty rarely. This would lead you to believe that we are interpreting low blood pressure as a disease. And there lies one of the first and important challenges. Is low blood pressure a disease or is it a physiologic state? And if the paradigm that you want to embrace is treating low blood pressure, then a medication like dopamine will make the blood pressure increase. You fix the blood pressure, but do you fix the patient? This is a nice example. These are two babies in our center, both of whom were incredibly sick with septic shock or significant heart dysfunction, but neither had low blood pressure. So concept number one, mean blood pressure does not predict cardiac output. They are two separate but related entities. And as you can see from these graphs, there are infants with low blood pressure that have preserved cardiac output, and vice versa. There are infants with normal blood pressure who may be in a low cardiac output state. And these are commonly missed in NICUs because we're not necessarily appraising flow. Here's a very simple, realistic kind of case to emphasize the challenges. Does resolution of blood pressure mean pathophysiologic recovery? This was a baby in our center several years ago who became hypotensive in the middle of the night, was given hydrocortisone, which made the blood pressure number go up, but the baby continued to have lactic acidosis. This is the RV 3-chamber view, and you do not need to be an expert in echocardiography to recognize that the right ventricle is profoundly dysfunctional. The objective measures of RV systolic performance were all objectively low, and this infant was in a profoundly low cardiac output state with abnormal blood supply to the brain. So fixing the blood pressure does not necessarily mean that you've actually fixed the problem. And what may be the unintended effects of giving a medication that actually hasn't led to resolution of the underlying problem. When we switched this baby to milrinone and low-dose epinephrine, his heart function recovered, his lactate normalized. So we constantly try to dumb it down, to simplify something that's incredibly complex. And if we think of, the important physiologic parameters that influence cerebral perfusion, they include blood pressure, cardiac output, and vascular resistance, of which there are different states. Yet most of our research has only focused on low blood pressure without considering the other factors. This work from Frank Van Del's group really alludes to the fact that this is much more complex. What you can see here at 2 years of age, hypotensive babies in gray had no difference in neurodevelopmental outcomes to patients who were not hypotensive. However, infants in both groups who had low cerebral oxygen saturation were more likely to have an impairment in neurodevelopmental outcome, suggesting that we need to think beyond blood pressure. This is the case I like to present, which really emphasizes the challenges we face. So we're a high-performing center with a very high survival rate at 22 weeks gestational age. This was an outborn infant who actually was in very poor condition at birth. There was head entrapment with an abruption. The infant was intubated, given surfactant, and as you can see from the chest x-ray, his lungs initially looked fairly good. It was on low ventilator settings, but very early on became hypotensive, not by mean blood pressure, but his systolic blood pressure was below the 3rd percentile. The infant was anemic, and on arrival to our center, had significant evidence of lactic acidosis. So if we stop thinking about mean blood pressure and think about the components of blood pressure, what you can see is that systolic blood pressure is influenced by the adequacy of cardiac output. Can the blood get into the left ventricle? Is the intrinsic contractility of the left ventricle normal? And is the left ventricle compromised by increased afterload? And as you can see from this graph here, there are many, many diseases that may influence why systolic blood pressure may be low. And to try to tease this out by just looking at the baby from the outside is impossible. So on this first echocardiogram, what we actually identified, and again, the data is not relevant, but the predominant finding was this infant's left ventricle was profoundly dysfunctional, both in terms of ejection fraction and LV strain. The RV was normal, and the baby was in a low cardiac output state. So we made a diagnosis of moderate LV systolic dysfunction, and we transitioned the baby from dobutamine to epinephrine. And this is something we typically do if 7.5 to 10 micrograms of dobutamine don't work, or the echo shows very severe heart dysfunction, we will transition to low-dose epinephrine. Over the next 3 hours, the baby's blood pressure recovered, but unfortunately, due to the perinatal hypoxia ischemia, the baby started to become encephalopathic and at the same time developed hypoxemic respiratory failure. So we went back and re-echoed, and at this point in time, the LV systolic function had normalized, but we now have a second physiology. The RV contractility is severely reduced, both in terms of fractional area change and TAPSE. This infant was in a low cardiac output state. And as you can see from the top right picture, the flow across the ductus was almost exclusively right to left. So we now have a second physiology, moderate to severe RV systolic dysfunction with severe pulmonary hypertension. And in our center, if we have echo-confirmed pulmonary hypertension, we will treat these babies with nitric oxide, but we classically start off with low dose. The rationale for this is, in our experience, many of these tiny babies respond very quickly to very low doses of nitric oxide. And again, recognizing that changes in physiology that occur rapidly may have very significant effects on cerebral perfusion, we advise the team that if the baby responded to nitric oxide and the postductal blood pressure fell, which would reflect the flow across the ductus, to wean the nitric oxide. So the issue of nitric oxide in preterm babies is incredibly controversial. And there are many individuals who would stand here and say, you should never use nitric oxide. It's a dangerous drug in preterm babies. But also, it's actually a drug that doesn't work. This is Satyan's study from when he was in Buffalo, where if you look at the black box, which reflects the likelihood of a response, appears to be much less in infants under 28 weeks gestation age. The critical question, though, is why do you give nitric oxide? And in this study here, it was exclusively given based on oxygen requirement, rather than a diagnosis of resistance-mediated pulmonary arterial hypertension. This prompted us to actually look at the same question when I was at Thicket, and we looked at a cohort of infants who had echo either immediately prior to or within 2 hours of the receipt of nitric oxide. And what we demonstrated was that if you had a diagnosis of pulmonary hypertension on echo, the likelihood of a positive response to nitric oxide was much higher, with an odds ratio of close to 8, particularly if you use it in the early transitional period. When I moved to Iowa, we looked again at this question in infants between 22 to 26 weeks gestation, who represent the highest risk population, and again showed a fairly high nitric oxide response rate. So what happened after we gave nitric oxide? The baby responded very well, weaned to room air with a dose of 5. As we predicted, the blood pressure fell postductally as the left to right shunt across it increased. So they weaned the nitric oxide. So by 12 hours, so now we are 9 hours after the initial presentation, this baby has a recovered blood pressure, but a low diastolic pressure. And the repeat echo shows a third physiology, a large PDA with a high volume left to right shunt, with all the markers being significant. So this is an important case because it demonstrates that our initial clinical impression may lead us down one pathway, but we need to be very cognizant of the major changes physiologically that may occur and the vulnerability of these tiny babies, in particular their pulmonary vascular bed. So this is not easy, this is complicated, and to manage and provide the best care, we need to move beyond the status quo and recognize that cardiovascular physiology is complex and dynamic, and that perhaps lack of our treatment benefit may relate to diagnostic and therapeutic imprecision. Unfortunately, in many places, people will practice in a symptom-based approach. The challenge is that all of these symptoms in isolation, you can give medications to increase the blood pressure, give things to improve the oxygen saturations. However, if you think of them as a constellation, all of these diseases may give you the same symptom complex. So what is our goal as neonatal intensivists is to optimize cellular metabolism, which is optimizing the balance between oxygen delivery and oxygen consumption. Recognizing the importance of blood, we just heard about delayed cord clamping, the adequacy of lung recruitment. But when we think of the cardiovascular system, the ultimate determinant of oxygen delivery is cardiac output, which is influenced by heart rate, preload, afterload, and contractility. Blood pressure is an important determinant of the adequacy of cardiac output, but it is no longer the endpoint of interest. It is a symptom of cardiovascular well-being, and this is how we need to think about blood pressure. When you think about tiny babies, there are important physiologic concepts, and this is a whole talk in itself. But very simply, the neonatal Frank-Starling law is very different to the adult Frank-Starling law. Across a range of normal filling pressures, increases in preload lead to really no improvement in contractility. It's only if you drop to very low filling pressures that you will have an improvement in contractility. The exceptions to the rules would be if you had a hypertrophic cardiomyopathy or you have congenital heart disease, surgical patients, such as the Fontan circulation. The most important law governing neonatal hemodynamics is the stress-velocity relationship, which is what you do when you go to the gym. You bench press if you squat. As you can see from the graph on the left-hand side, in which on the x-axis is wall stress, afterload, on the y-axis is contractility, the slope of the line for the neonate is much steeper, meaning that for the same change in afterload, there's a much bigger reduction in contractility. And in the bottom right, on the left-hand side is the RV versus the LV, and you can see that the RV is potentially even more vulnerable to afterload than the LV. When is this important? After birth, in acute pulmonary hypertension, or if you surgically or cath close the ductus. So taking all these things, in 2018, I crossed the divide from Canada into the United States and was recruited to be the division director at the University of Iowa, which was a program that already had an exceptional reputation in the care of extremely preterm babies, with survival rates that far superseded the other 700 sites across the Vermont-Oxford network, particularly at the lower limits of gestational age. Tara Khaleesi had just published her paper demonstrating that infants at 22 to 23 weeks had outcomes that were comparable with those at 24 to 25 weeks in terms of morbidities, although survival was lower. However, when you looked at this population, there still was a fairly significant risk of severe IVH, necrotizing enterocolitis, and need for surgical ligation. Some of the unique aspects of Iowa, and this is again is a talk in itself, and I don't have details, is the culture, the standardization of the care, the teamwork, for me, are the most important elements. However, on top of that, precision in respiratory care, using first intention high-frequency jet ventilation. We don't extubate these tiny babies. And very strict approach to fluid balance, nutrition, and probiotics were the sentinel things that were in practice at that point in time. However, the approach to hemodynamic care was, like many other centers across the United States, very simplistic, symptom-based approach. So the University of Iowa Hemodynamics program, we have 6 faculty. We would have had 7 were it not for the loss of Reagan Giesinger. We perform up to 2,000 consults per year, and we have a 1-year fellowship. Kind of Reagan and I, when we moved to Iowa, wanted to ask the question, is there a benefit to early hemodynamic screening? Recognizes the significant vulnerability of these extremely tiny babies and the potential dangers of abnormal blood flow. Secondly, if you're going to screen these babies, what do you do with the PDA? This is Jan Middleton's study using non-invasive cardiac output monitoring, which demonstrated very nicely that infants in orange who had a transition from very low cardiac output to much higher cardiac output over the first 48 hours appeared to have a higher rate of morbidity. And this is interesting because blood flow is a sentinel element in the etiology of PVL or NEC, low flow states, intraventricular hemorrhage, or pulmonary hypertension in high flow states. So the fundamental question is, are there derangements going on that we're not aware of? Jean-Christophe Rosé had published this paper about 10 years ago, demonstrating in French centers early screening on day 3 for PDA appeared to be associated with a reduction in mortality. However, we have data from the TIP trial, which demonstrates very clearly that despite the benefit in reducing severe IVH and the need for PDA ligation, there was no improvement in long-term neurodevelopmental outcome. And as a result of this, prophylactic indomethacin has fallen out of favor. However, the fundamental question that was not asked is something as bad as grade 3-4 IVH, which we sit and talk to families and withdraw intensive care, reducing this, why did it not translate into a benefit? And that's an unanswered question at this point in time. So in the early days after the implementation of screening, and we screen infants under 27 weeks gestation, between 12 and 18 hours. One of the first studies that Reagan presented at PAS was that up to 60% of these tiny babies have evidence subclinically of an abnormal cardiovascular state with similar rates between the 22 to 23 weekers and the 24 to 26 weekers. The most common of which was PDA in about 1/3 of cases. However, importantly, up to 30% of babies had physiologies where you don't want to close the duct, heart dysfunction, pulmonary hypertension, and so forth. So is one of the reasons that prophylactic endomethacin didn't work is actually we were giving a therapy that harmed some patients and actually was not needed in others. So recognizing that if you're going to think about the ductus in the first 72 hours, it's important to recognize the variable role of the ductus from the pathologic role, which is why you might want to think of treating it, to those situations in which is supportive because there are duct-dependent circulations. To add to the argument, this is Shahab Nouri's study where he, again, using non-invasive cardiac output monitoring, looked in these infants in the first 72 hours of life. And this work was based on the fact that Mark and Clucka had reported in the early 2000s that infants with very low cardiac output in the first 6 hours were more likely to develop IVH. What you have demonstrated is that infants who did not develop IVH had a very stable cardiac output for the first 76 hours. It was those babies, like Jan Middleton's study, which started off lower and that increased significantly, appeared to be the ones that developed IVH. So why might there be fairly significant changes in blood flow? Well, it makes total sense. After elimination of the placenta, we have an increase in afterload to the left ventricle, which may potentially mean that cardiac output is lower and cerebral perfusion is lower. In a normal transition, we give surfactant, we give oxygen, we improve the ventilation, the CO2 falls, the PO2 increases, and all of these things will influence pulmonary vascular resistance. And as PVR falls, there's a significant increase in the left to right shunt across the ductus. All that blood returns to the left side of the heart, which will augment the preductal cardiac output, meaning higher blood flow to the brain. So are we witnessing a phase of ischemia reperfusion as one of the elements that may contribute to IVH? This is interesting because if you go back and look at the early trials of both high-frequency ventilation and inhaled nitric oxide, both of which lead to fairly significant reductions in PVR, particularly if used non-judiciously, both are associated with an increase in grade 3/4 IVH. So what other evidence do we have of the potential impact of early therapy? Well, this started to gain traction initially with Mark and Clucka's DETECT trial. Unfortunately, a small and underpowered study, but did still demonstrate that in the indomethacin treated group, although the numbers are very low, the rate of significant IVH was lower. But key to this study was this is very early therapy. This is in the first 6 to 12 hours after birth. So Samir will probably talk about his study and other studies of early PD intervention. And these trials are very clear, both very similar inclusion criteria, randomized to ibuprofen or placebo, demonstrating that there is no change in the composite outcome of death or BPD and potentially an increase in BPD. The fundamental question is how do we interpret the results of these data? Either ibuprofen is ineffective or potentially harmful, or perhaps we are still randomizing babies in a manner that perhaps is still too imprecise. So, the fundamental questions for me is, do the patients actually have a disease? Okay. And did the disease persist for a reasonable duration of time? Did the treatment cure the disease? And then finally is the outcome, meaning BPD, a reliable and trustworthy outcome. This very nice phrase from Albert Einstein really emphasizes the challenge that we have faced and continue to face in PDA research, in that we've spent the last 30 years performing trials without defining and characterizing the population of interest. So if we think of both of these trials, okay, again, the patients have been randomized based on kind of diameter, the directionality of PDA shunt. We have uncertainty around the rate of PDA closure. And certainly PDA elimination was not universal. And these are some of the questions that have been raised. For me, what was most interesting is actually if you go back and look at the TIP trial, in the subgroup of infants without a diagnosis of PDA, infants who received prophylactic indomethacin were also more likely to develop PPD. So the fundamental question is, if we don't select the right patients and we enroll babies who are more likely to close spontaneously, are we potentially increasing the risk of harm? This is a recent case we had. This is not an extremely preterm baby. It's a 30-week infant who was born pretty sick, had hemodynamic instability and hypoxemic respiratory failure. And we were asked to scan because this infant was in high oxygen requirement. So this is, I'm just going to show you just a glimpse of one image. This is an infant that has a large 3mm ductus with an unrestricted left to right shunt across the PDA. Would you treat this or would you randomize this patient? And that's one of the challenges when we enroll babies based on a limited assessment of PDA evaluation. If we now go on and look at the rest of the echo, and we now look at the flow in the right ventricle and the right ventricular output, you can see there's almost no blood exiting the right ventricle. The right ventricular output was only 28 mils per kilo per minute. This infant had fairly profound tricuspid valve regurgitation with a large right to left shunt across the ductus. Despite this infant had preserved cardiac output. And the reason for this is what we call functional pulmonary atresia. This left to right shunt across the ductus is life-saving in this situation. If we had treated this baby and closed this PDA, we would have had a very poor outcome for this infant. So we started the infant on low-dose nitric oxide, and you can see that immediately there's an improvement. His right ventricular output is now 106 mils per kilo per minute. The flow across the ductus is still left to right, but we've changed the physiology fairly radically. So after this, we weaned the nitric oxide, repeated the echo after 24 hours. By day 2, we had a fairly pathologic shunt. We treated him with some acetaminophen, extubated day 3, and so forth. So again, the hazards of actually perhaps having limited information. So we've talked about this for a long time. The ductus is a 3-dimensional structure that comes in all sorts of shapes and sizes. Okay, if you're going to try to assess the ductus based on diameter, you have to recognize that the PDA is a 3-dimensional structure that, depending on the line of incination, you may overestimate or underestimate the diameter of the ductus. This is emphasized quite nicely in this study here, in which we actually compared 2D echo-derived estimates of diameter versus what you can actually measure with angio in the cath lab. And what you can see from the data is a fairly wide scatter of diameter, but in essence, the bias is up to 0.5 millimeters at the pulmonary end and 1.7 at the aortic end. So going back to the point I made earlier, if we don't enroll the right patients and we enroll babies that have a high likelihood of spontaneous PDA closure, okay, therein lies one of our challenges. And this is some work that Ron Kleiman shared with me from the PDA Tolerate trial. Across the 18 centers, the rate of spontaneous closure ranged from 10 to 20% up to almost 80%, suggesting that this is indeed a potential problem. So to solve this issue, and I'm sure Samir will also agree with me, if we're to find a population of benefit, it'll only likely to be efficacious if we enroll babies who have shunts that are truly hemodynamically significant and they persist in the control group and remain pathologic. I think that will be the next phase of PDA research. So how do we do that? There have been a number of scores that have been developed. Much of them have been adapted from a Thief Al-Kafash's natural history study. Why might it be important to characterize, the significance of the shunt? This is a study we presented at PAS this year, in which we identified infants who had PDAs that were persistent, but based on our score, remained low volume. And these infants were enrolled if they had more than 2 weeks exposure to a shunt that persisted but remained low volume. And what we did was compare them to infants that never had a diagnosis of PDA. And what you can see is that the morbidities that you would adjudicate that may be related to PDA really were no different between groups. So to wrap up, so where are we at this point in time and what we learned? Okay, so this is our approach to screening as mentioned. If we have a significant shunt, we will treat these babies with acetaminophen for 3 days and potentially up to 7 days. If the physiology is heart dysfunction or pulmonary hypertension, we will manage them accordingly. The approach to PDA, and we can talk about this in the debate session afterwards. You know, again, it's acetaminophen, followed by indomethacin, followed by percutaneous device closure, and these are the components of the Iowa PDS score that we would use. So, what was the impact of introducing this program now 5.5 years ago? This is Reagan Giesinger's Blue Journal paper from last year. And what you can see, there were some key sentinel factors, you know, in the change in the modern epochs when screening was introduced in 2018-19. There were more babies born less than 23 weeks. It increased from 32% to 44% of the population under 27 weeks gestation. A higher use of antenatal steroids and delayed cord clamping, but a higher likelihood of more sicker babies. As we got better at resuscitating 22-weekers and 23-weekers, the more higher risk ones got resuscitated. So a higher rate of maternal drug use, higher rate of obesity, prolonged rupture of membranes, and so forth. In the modern era, the risk of the composite outcome of death or severe IVH was halved from 30% to 16%, with a reduction in the subcomponents. But even more striking was the reduction in the rate of NEC from 6% to 1%. When we adjusted for the protective factors and the risk factors, screening remained independently associated with a reduction in the primary outcome. This is the time series graph, and each box reflects a 3-month time period. And what you can see from 2008 to 2018, it didn't change a lot, but maybe a marginal increase. And that probably reflects more small babies are being resuscitated. But once we got to 2018, following the introduction of the screening program, you can see a fairly significant and profound reduction. And I can tell you, you know, anecdotally, just looking at our rates of severe IVH, they have continued to fall over the last 2 years or so. So when Reagan presented this at PAS, I think it was Willem asked the question, well, how much of this is PDA? So Reagan went back and, you know, looked only at infants with the diagnosis of PDA. The prior approach in Iowa was to not treat for the first 7 days, indomethacin following surgery. The maternal and risk profiles were identical. We don't need to go into details about that. But what did we find? We found a reduction in the primary outcome of death or severe death or severe BPD, grade 3 BPD, predominantly in the 22 to 23 week population, less so, although there was a marginal reduction, less so in the 24 to 27 week population. The reduction in severe IVH, however, occurred in both subgroups, as did the reduction of NEC. And here, if you look at, you know, of the 73 patients, 1 infant had NEC in the 22 to 23 week population. When we performed the logistic regression analysis, again, adjusting for all factors, screening and early treatment of PDA in our cohort in Iowa was associated with benefits. These findings of early screening and hemodynamic consultation are not just in Iowa. This is some work from the Toronto group, which again found, you know, that screening and managing critically ill babies in centers that use targeted needle echo were associated with a reduction in mortality. So to wrap up, you know, I think hopefully I'll have shared with you that extremely preterm babies are a population of high risk, but standardization of the care, introduction of hemodynamics, potentially can mitigate the risk of major morbidities. This is a picture of our first 21-weeker who survived. Our recent data shows that we've actually had 5 survivors at 21 weeks gestation over the last 18 months, none of whom have had IVH, none of whom have NEC. And there's one little baby who was born at 230 grams. So I am going to stop and thank you very much for your attention. Samir, maybe I'm going to introduce you, am I? My good friend, Samir.
Thank you, Dr. McNamara, for the excellent talk. You beautifully explained the challenges to the hemodynamic management. And it's much more nuanced than a simple algorithm of the blood pressure is low and you start dopamine. Thank you very much. Any questions from the audience to Dr. McNamara?
Thank you so much, Ahmed Dan from Al Qasim Children's Hospital. Thank you so much, Dr. McNamara. Really, it was really impressive talk. Regarding the use of acetaminophen, is there an association between this medicine and, as a side effect, increased pulmonary pressure? So in a way, you are trying to treat the PDA, but the problem which happens later on is related to acetaminophen itself, not from the baby's physiology. What do you think?
Okay. Yeah, so we've looked very, very carefully at this, and it's actually quite interesting. Stephanie Cavallaro published a kind of a case series of the first 100 babies that were treated with acetaminophen. And what was most interesting in that cohort was that the infants who had the highest likelihood of response to acetaminophen were infants who were growth restricted, who might actually be the patient you would be most worried about from a pulmonary vascular disease. In the 6 years that I've been at Iowa, I've only seen us need to stop acetaminophen in one baby. Okay. Theoretically, it is the medication that is a vasoconstrictor, and that theoretically can affect pulmonary vascular resistance. And that was one of our worries with using it kind of early on. But certainly in the data to date, that has not borne out as a major issue. And obviously something to keep a close eye on. And some of our patients will have up to 7 days of this medication without really any major impact kind of on pulmonary vascular resistance. Now, what's more interesting, when I was in Toronto, where we used it late, and one could conceptualize in late use of acetaminophen in patients who have, say, had failed non-steroidals, had weeks of exposure to PDA. These babies may have already abnormal pulmonary blood vessels that have remodeled, and then given a medication like kind of acetaminophen may have much more of a potentiating effect on the pulmonary vascular bed. It's a medication that could have effects, but certainly early on, we honestly have not seen them.
Thanks,
Soni.
Professor Patrick McNamara. Soni from Sidra Medicine. We have a Samir on the ibuprofen group, and you on the acetaminophen. All your talk, I only heard acetaminophen. Can you give me 3 good reasons why first choice would be acetaminophen in the early treatment at this current, with the current evidence?
Okay. So the reason we use acetaminophen is based on the fact that, at least in our center, and when we started off building the program in Iowa, early hydrocortisone, particularly in the transitional period, was used commonly as a therapy for low blood pressure or worry about chorioamnionitis inflammation. So for that reason alone, we have moved towards giving acetaminophen as the first line therapy. That's the predominantly reason. In terms of, do we have data in the population I'm talking about, meaning 21, 22, 23 weeks, looking at whether acetaminophen or ibuprofen is more effective? The answer is no. Got no data in such a high-risk population. Our theory is that acetaminophen works by modulating pulmonary vascular resistance. And again, our goal in the transitional period is not to close the duct, but to minimize major reductions in PVR that lead to an augmentation in the left-right shunt and preductal cardiac output. So it's an IVH prevention strategy. We actually don't know that indomethacin or ibuprofen doesn't do the same thing. They also are vasoconstrictors. So we've always thought that it works directly on the ductus. I'm not so sure. If you go back to the Gournay trial, we saw a very similar kind of, concern about pulmonary hypertension. There were 4 deaths kind of early use of ibuprofen kind of in that study. So, yes, I mentioned kind of all about acetaminophen, but you would have seen our second line approach is indomethacin. But the other key piece to our approach to PDA is that if we give a medication, whether it's acetaminophen or indomethacin, if a single course doesn't change the physiology based on the score, we don't repeat it. we'll move on to the next thing. Giving repeat courses of any medication that's not doing anything. Go back to my first slide. If you give a therapy that's not having benefit, you're guaranteeing side effects. And I honestly, truly believe that any of these medications, if you give them and you don't need them, or if you give them and they don't work, there's potentially going to be side effects of the drugs. And, the trials are telling us that. And one of my big concerns now is that we are moving into an era of synergistic or dual therapy. If you now take 2 drugs and none of them are efficacious, and you don't need the PDA doesn't need to be treated, or they don't work, you potentially are going to even further maximize the harm to the lung and the pulmonary vascular bed. So I think we have to be very careful.
Thank you, Dr. McNamara. In order to keep up with the time, I would have to move on to the next session.
Absolutely.
We really look forward to your input during the debate later on, Dr. McNamara. Thank you.
Okay.
Our next session, next topic is on the physiology and the hemodynamics on PDA. And Professor Samir Gupta is a consultant neonatologist and a professor of neonatology at Durham University and also Sidra Medicine in Qatar. He founded the Neonatal Cardiology and Hemodynamics Conference in UK and has authored over 150 publications. His leadership in clinical skills like Baby Oscar trial has shaped the management of PDA in neonates, making him a key figure in the neonatal research. Dr. Samir, the stage is yours. Thank you.
Well, thank you so much for a kind introduction. I hope you can see my slide and you can hear me. Can somebody confirm?
Yes, we
I
can.
can see it, Samir.
Okay, great. Thank you. Well, also thanks to the organizers, specifically my good friend Rupali, for inviting me to this prestigious hemodynamic meeting in the Middle East. And my sincere apologies that despite I wanted to be there in person, I could not be there for the concurrent commitments that came up in the UK. Now, you would agree that it is a hard act. It is practically walking on a live wire when you have asked to speak after Patrick. He's a good friend, but clearly it was a fabulous talk, Patrick. I really enjoyed it. I have no disclosures or any research-related presentation in this particular talk. Now, I've been given the topic of the hemodynamics and physiology. So I'll try and stay away from the clinical trials because that is a complete separate talk in itself, but we'll touch base on it at points where it is necessary. Now, I don't need to remind this august audience about the fetal circulation routes, and that is from right atrium to tricuspid wall to right ventricle, pulmonary semilunar wall, pulmonary artery, ductus arteriosus, and to aorta. But more importantly, it is about what proportion of the blood is flowing from various vessels and the chambers. So if you looked at 69% of the blood comes from through the ductus venosus and IVC, 19% from the superior vena cava. They come to the right ventricle, and the majority of blood is shunted through the foramen ovale. That is 48% coming from the lower part of the body. That is oxygenated blood from the placenta, and that goes to the left ventricle, where preliminary it is perfusing the vital organs like heart and brain, and getting a return of the pulmonary veins about 12%. The right ventricle, it pumps about 40% blood, and then 28% of it goes through ductus arteriosus to the descending aorta from both the sides. And as I said, that's the circulation that goes back to the umbilical arteries, gets the oxygen and comes back. Only 23% goes to the lower limbs. Now, this gives that it is not 100% blood flow, but it is a proportion of the blood that is flowing through various channels and routes in the ductus arteriosus. Only takes about a quarter of the flow from the entire volume. Now, Patrick very elegantly mentioned about the different shapes and sizes of the ducts, and I think it is a very important thing to understand, because if you would look at the preterm ductus is type F mainly, and if you look at the type F duct, it is quite long and it is tortuous. And the point that Patrick made is important, that it quite depends on where you measure. And I think the nomenclature that has been so far being followed for the measurement is towards the pulmonary end or the point of maximal constriction. And that is still being followed up and is been guiding through the literature. Now the question comes is the measurement of diameter enough? If you look at Martin Clicquot's initial paper from 90s, it has been said that the measurement of the ductus itself can have about 70 to 80% sensitivity. But however, this had been put to question. And subsequently, it has been suggested that adding a flow pattern, and that was again the published literature, which suggested that it has a positive predictive value of over 75%. And if you combine the dimension with a flow pattern, then the Harling had reported that it is same in the region of about 70 to 75%. So what it says is that it is not a magic bullet to identify which ducts are significant, but adding more parameter is equally important, rather very important, to further narrow down your search for a hemodynamically significant duct. However, I'd like to mention one thing. It is about pragmatism versus idealism. And the pragmatism is when you introduce a particular assessment technique, how many centers around the world or the centers in the whole country, they can measure it appropriately. And I think this is one of the contexts why I'm saying so in the baby Oscar trial, that rather than going for a detailed assessment of the duct, where the margin of error and inter-observer variability could be pretty high, we limited to the duct dimension and the flow pattern, which was independently audited for quality control by the pediatric cardiology team and was found to be highly congregant, and it was no margins for error found in. And hence, there's a difference between a multi-center study and a single center experience, where one would find that a particular practice can be implemented like what has been mentioned, as compared to a pragmatic trial, which is in like baby Oscar in about 32 centers. Now, one need to think about the changes around birth. Before birth, we know that ductus arteriosus wall is more muscular. It is less sensitive to dilating effects of the prostaglandins and more sensitive to vasoconstricting effect of oxygen. After birth, as it has already been mentioned, the right heart pressure drops, PaO2 rises, so ductus arteriosus wall constricts. There is intimal ischemia, and in preterm babies below 30-week pressure, the high pulmonary pressure is maintained. Now, that's quite an important slide in my view. Prematurity and immaturity of organs we cannot change. The PDA shunt and the volume which is passing through it, it varies depending on multitude of hemodynamic factors. But one thing which makes and possibly makes a difference is about heart function and adaptation. That is the value where there is a lack of evidence whether assessment of heart function in addition to the shunt volume and significance makes a difference to the treatment outcomes. And this is an area which is, as from the Iowa experience you have seen, a single center experience suggests that probably integrating more parameters could have some benefit, but it is an observation at the moment rather than evidence. Now, I will take you back to the shunt volume and Poisson's law. And I think it is important because what we know that the flow is a difference in the pressures, which is systemic to pulmonary pressures, divided by the resistance. And hence the shunt volume, if you look at, is a product of the difference in the pressure, the value of pi, then the fourth power of the radius, divided by 8 upon the viscosity and the length of the ductus. Now, all these factors are important for the shunt volume, and hence, when we are assessing, if we can take account of it, where the various views have come up in terms of the preterm ductus being very long and narrow, that is inversely proportional to the shunt volume, probably a degree of protection. A high viscosity is a protection, and hence anemia and low platelet counts have been accounted for delayed closure. And the radius is important so that the larger the radius, the higher the shunt volume, and the difference in the pressure that has also been mentioned. So I think remembering the Poisson's law, it helps in understanding the hemodynamic changes around birth and how the transitional circulation could have an impact on the outcomes. Now, this is the physiological contributors to the PDA shunt. And if you look at the 3 modulators, which are reducing the pulmonary vascular resistance, increasing the systemic vascular resistance, and other modulators. So what causes all these things? we know that the oxygen, hypocarbia, inhaled nitric oxide, and surfactant, they reduce the PVR, and that leads to increased left to right shunt and hence flooding of the lungs. If you look at the increasing SVR, the use of the drugs which for whatever reasons are used, that will cause it, and other modulators such as ductal diameter, decreased viscosity, and thrombocytopenia, they also account for it. But how can we mitigate that? Are the following: keep avoiding the saturations which are very high, avoid the low CO2, and give adequate PEEP. With regards to the SVR, I think low dose dobutamine could have a dual effect by improving the cardiac outputs and also reducing the SVR, which could ultimately reduce the left to right shunt. Critically low diastolic pressures, people have also used the dopamine to use it. We don't tend to do that. And the ductal closure strategies, which have been talked about, and we will discuss a bit more now and in the debate. Now, if you look at the PD prematurity and transition, there are a few things which are important. And that is, the premature infants have different response to left to right shunt in comparison to term infants. There is a faster development of the pulmonary overcirculation that we know is at 2 to 3 weeks compared to the term infants, that is 3 to 6 weeks. There is delayed pulmonary vascular maturation and differential perfusion, and obviously there is the risk of BPD because of the equalization of the aortopulmonary pressures in a large hemodynamically significant PDA. Now, if you look at what is the ratio of the pulmonary to the systemic flow, clearly the pulmonary flow is mainly for the lungs. Systemic flow is a systemic steal which can affect the downstream organs, which includes the intestines, the kidneys, and also the effect on the brain early on, but that is really not post-ductal, but it can be the effect of ductus due to retrograde flow. When it is the duct diameter more than 1.5, the QPQS ratio is already 1.5. So I think the diameter does have effect, and people have questioned about the diameter. Then what is 1.5 is the easy cutoff, and yes, it is small, but we can still see changes in the QPQS ratio. How much significant they are is a question that still need to be answered. But clearly, when it crosses 2, the flow in the pulmonary bed is twice of that is the systemic circulation. We have already said about the various QP and QS, how they affect and where it can have the complications too. But more importantly, it is the cartoon which is showing that at what point of time a PDA could cause a complication. So early on in the first 12 to 48 hours, it causes mainly the pulmonary hemorrhage and IVH, as it has been very elegantly shown by Patrick, about the perfusion and the decreased perfusion and a reperfusion injury, which probably is the hallmark for the development of the IVH. Beyond the first week, if the PDA persists, we are talking about other complications, which is including the necrotizing enterocolitis, which includes the chronic lung disease and mortality. The majority of trials that have been done to date, they have more or less assessed the short-term outcomes, and only few trials have looked at the long-term outcome. That includes the TIP trial on prophylactic treatment and the Baby Oscar trial, which has presented the data at the PAS and is due to go into the publication soon. So this is where the evidence is in our domain. It's about the short-term outcome that we know of, but the gaps are in the long-term outcome, because that is what the parents and the community are more interested in. Now, if you look at the PD and cardiopulmonary physiology, this is modified from Martin and Becklari's publication. If you look at the increased pulmonary flow, it affects the left heart overload, ultimately leading to increased ventilator settings. And also, it increases pulmonary capillary pressures, which affects the capillary endothelial damage and the lung inflammation, and leading to capillary and alveoli formation, which is decreased and a hallmark for the bronchopulmonary dysplasia. In addition, there is leakage of plasma proteins and inhibition of surfactant production, and I'm going to talk more about it for the persistent PDAs. Now, echocardiographically, so far, the 3 areas which have been very widely used for assessment of the ductus of hemodynamic significance are primary ductal characteristics, which are of value in the first 72 hours. But beyond that, we need to also look at the evidence of the pulmonary hyperperfusion, and evaluation of systemic hypoperfusion. And I must admit here that the assessment of the heart function is probably missing in majority of the centers, or rather widely, except for few. If you look at physiologically, it makes sense because a ductus of the same size, say 2 millimeters, which is having double the pulmonary flow, if the heart function was normal. But if the heart function was subnormal, that flow might not be double, but it could be causing the back pressure leading to diastolic dysfunction with more significant effects in terms of complications. And that is one area where I think the evidence coming up from Iowa is going to help in probably going to add one more dimension to the assessment if we are going to integrate that, and that is about appropriate tools for heart function assessment, including systolic and the diastolic function. One small point that we need to be careful about is the shunts which are there. A large interatrial shunt accounts for a large left atrial to right atrial flow, and hence, in addition, a ductal flow left to right, which is after the semilunar walls. If we are measuring the output, the RV output is mainly what is the systemic flow, and the LV output is mainly what is the pulmonary flow. And I think when we are measuring the systemic perfusion, we need to be looking at appropriate output to account for how much blood is flowing. I don't need to, again, go back into details of it, but we know that prenatally, the ductus arteriosus is kept open with the effects of the prostaglandins, high pulmonary pressures, and the nitric oxide. However, these things are diminished after birth, and hence, this leads to the contracted situation of the ductus, and hence, it closes on its own. Now, I'm going to slightly transition onto the PDA and excess fluid clearance and how it is going to affect on a persistent ductus. So we have talked about the immediate transition, what is being there, but what is important is leaving the duct on its own as it has been growing very widely. About no treatment is probably the better approach. It probably comes from the uncertainty rather than evidence. And the persistence of duct has its own complications. And in the next 10-15 minutes, I'm going to touch on this particular area. If you look at the ductus, there is increased fluid and protein filtration in the lungs interstitium. This is the increase in the lung lymph flow and is called the edema safety factor. It inhibits the fluid accumulation in the lungs and changes in the pulmonary mechanics. If the baby is ventilated, it causes the pulmonary interstitial fibrosis, which is a negative impact on the edema safety factor. And if ventilation continued for beyond 7 to 10 days, it increases the fluid and protein filtration, which further increases the lymph flow. And with the negative effect of the pulmonary interstitial fibrosis, this causes the hallmark for the long-term damage through the hydraulic pulmonary edema accounted to the persistent PDA. This is a very, very important concept because this hydraulic pulmonary edema, it could be twofold, either due to the accumulation of the fluid, that is the lymph fluid in the lungs, or the backward pressure caused by a persistent PDA and a diastolic dysfunction. So the ductal patency in the lung lymph flow, there are three major ways by which the patency of duct may affect the lung lymph flow. Influencing the pulmonary microvascular pressure, altering the patency of the lung vascular bed, and disrupting the normal barrier function of the pulmonary vascular endothelium. Now, this is the study on about 6 lambs that was done by a long time ago, where it was reported that if the duct was open, the pulmonary flow was almost double of when the duct was closed. At the same time, the mean systemic pressure, here is the mean systemic pressure. This was much higher with the open ductus, and the left ventricular and diastolic pressure was also much higher with the ductus open. This was mainly accounted due to the increase in the lymph flow, there is a lung lymph flow, which was almost double of when duct was closed, and the protein in the lymph was much lower. And probably that accounts for that the lymph flow, low proteins, persistence of the filtration, it is the cascade that starts in early on in the first week of life, which can persist for longer to cause long-term damage. When an individual lamb was looked at, the blood flow decreased by 40% when the ductus was closed, and it decreased by 50% when it was the second time closed. And probably that is where the concept of the repeat courses comes in, where the advantage is about 10 to 15% of the duct closure that can come as a rebound closure if you are giving a second course of whichever medication you are giving. So impact of a hemodynamically significant PD on the pulmonary vasculature after birth, there is a normal physiologic fall in the pulmonary arterial pressure and thinning of the smooth muscle medial layer. With large PDA, the systemic pulmonary pressure equalization, there is a delay in the fall of the pulmonary artery pressure. With a high pressure, the pulmonary arteries do not mature. There is a slower lowering of the PVR in the first 3 to 4 months, changes in the vascular reactivity, changes in the blood flow, and the pulmonary artery pressure that remains high due to equalization pressures and high flow. Now, please spend some time on here. If you look at the normal flow in the arteriole, you can see that the fibroblast, the smooth muscle cell, and the endothelial cell are quite looking normal. However, with the increased flow, apart from the plexiform the development of the supernumerary arteries, you can see here, there is in a magnified view, there is a hypertrophy of each aspect, which is fibroblast, smooth muscle cell, and endothelial cell. So increased flow is not benign. It leads to certain changes in the vascular integrity, and that could be a hallmark for a long-term BPD. So the consequence of a prolonged patency of the PD on pulmonary vasculature is what I just mentioned about the tunica media of the pulmonary arteries is first to undergo changes. It leads to intimal thickening, and if it persists, this has suggested about 2 years, but the process starts way earlier, and I'm going to show you in the subsequent slides. In at least 50% of the patients with chronic, large, untreated hemodynamic significant PDA, the irreversible changes can set very early on, but definitely by 2 years of age. So if you look at that, what we saw was only increased pulmonary blood flow, we are causing media hypertrophy. But in babies, we know it is just not the increased blood flow through the ductus, but there is an additional hit. That could be infection, that could be the chronic systemic to pulmonary shunts, that could be other complications of surgery. And in these cases, which can be given by the MCT in vitro, you can see that the obliterative lesion or the neointima is far more pronounced as compared to just media hypertrophy. It is also seen that if this is prolonged, then it starts forming the plexiform lesions, and these plexiform lesions are irreversible. It has been reported that they definitely happen by 1 to 2 years of age, but in preterm babies as soon as 36 weeks of gestational age. And hence, what you see is a normal arteriole to media hypertrophy and additional hit with a neointimal lesion, with a plexiform lesion, and a concentric laminar intimal fibrosis. Now, these are not benign, as you would agree, and these are the ones which are worth preventing to improve the long-term outcomes. And there lies the value of the long-term outcome, why it is so important. Coming back to, again, the Poisson's law about the pressure flow resistance relationship, vessel 1 is a narrow vessel, vessel 2 is a larger vessel, and here I mean its ductus. We can see that the elevated pressure as seen in the large PDA, and it is systemic to the pulmonary equalization of pressures. It implies in a larger PDA a high flow large shunt as opposed to an increased resistance, and this leads to the flow related changes into the pulmonary vascular bed, which can be labeled as flow related BPD and pulmonary hypertension, which I'm going to allude in the subsequent slides. So in this study, the aim was that whether prolonged exposure to a moderate large PDA with the left direction increase the risk of a late pulmonary hypertension and pulmonary vascular disease during neonatal hospitalization in preterm infants which were below 28 weeks. So all infants who require respiratory support beyond 36 weeks were selected and had systemic echocardiographic evaluations for the BPD-PH. Here it is BPD pulmonary hypertension at planned intervals. Infants were classified as having either flow-associated BPD pulmonary hypertension or BPD-related pulmonary vascular disease. What you see here is that a moderate to large shunts increase the risk of the flow associated BPD pulmonary hypertension when present beyond 36 weeks of gestation. Additionally, although increasing duration of the moderate to large PDA left-right shunts are associated with an increased incidence of BPD, there is no association between increasing duration of exposure to a moderate large left-right shunt and the pulmonary vascular disease. What it says is that the pulmonary vascular disease could be set in much earlier without the evidence of a duct-dependent prolonged flow, which is a separate entity in itself. In this study, 9 of the 10 infants with the BPD pulmonary vascular disease already had an evidence of the vascular disease in the first week after birth. And hence the late PVD may be a manifestation of events that occur in utero rather than the duct-related pulmonary hypertension. So there are two different entities for a persistent duct. When a pulmonary hypertension develops secondary to the PDA, that is BPD related to the increased flow causing pulmonary hypertension, as opposed to the pulmonary vascular disease due to primary lung remodeling, which could have started due to things like chorioamnionitis, intrauterine, or soon after birth. Again, this is what is about the pulmonary hyperperfusion we have talked about, and this is Martin's study about the PDA size giving a sensitivity of 81% and the LAO ratio with a specificity of 91%. And I think combining these always improves the prediction for the pulmonary hyperperfusion. There are limitations of the echo in the pulmonary hypertension assessment, and that is that when we assess the pulmonary hypertension, though not part of this talk as a whole, but we know that the tricuspid regurgitation can be grossly underestimated, that because if the RV systolic dysfunction is there, we cannot assess that. And that was very beautifully alluded by Patrick in his talk. Also, the end systolic eccentricity index is dependent on the interventricular pressure gradient. And hence, in patients with systemic hypertension, which is common in patients with BPD, septum may remain round and the EIs could be less than 1.3. So there is a value of continuous echo assessment in addition, incorporating the cardiac function assessment, mainly the RV function in babies who have a PDA. So pulmonary hypertension with prolonged patency of PDA in extreme low birth weight infants, the incidence after 1 month of age is about 4 to 16%. And in infants having pulmonary artery hypertension with BPD, 40% mortality by 2 years. And there is an increased risk of developing early pulmonary artery hypertension in preterm infants with post-tricuspid shunts, such as additional AVSD, VSD, including PDA. Outcome after closure of these defects is dependent on the age at time of closure and presence of preoperative pulmonary vascular disease. Now, a point here that if you go back in the last 20, 25 years, the approach that was first tried was the prophylactic approach, thinking that if we close the duct very early in the first 24 hours, it might improve the outcomes. So there is a reduction in the symptomatic PDA, but no other benefits in terms of the treatment benefits in the short-term and long-term outcome after the TIP trial. Subsequently, it was felt that what Patrick mentioned, that while the prophylactic treatment did not work, and what was the reason? And I think 50% of the babies who could have otherwise closed the duct spontaneously did receive the treatment. And we know the negative effects of giving NSAIDs like indomethacin and ibuprofen or now paracetamol, which can have the effects on the baby and can mitigate or rather negate the advantages of the treatment. And that could be one of the reasons why it was thought that the benefits of prophylactic treatment were not seen. Based on that, in the last about 10 to 15 years, there was an increasing drive about echocardiographic screening of the ducts in the first 72 hours and targeting therapy to those who were found to be hemodynamically significant as per the criteria thought to be appropriate at the point of time. Utilizing that approach, you all are aware of the recent publications. There was no benefit in the short-term outcomes reported so far, and I have already presented this, and there was no benefit in the long-term outcomes until 2 years, which includes the respiratory morbidity or death. Now, there are various points which could be raised, and we can take it in the debate, that why we did not see the improvement in this. And one of the things for any a pragmatic trial is we cannot achieve 100% versus 0% comparison. What I mean to say here is that with a treatment 100% closure and in a or in a control arm 0% closure, that is an ideal trial to see the benefits of intervention. With the intervention trials, with all the drugs that are currently available, we have seen between about 55 to 70% closure rates after one course of treatment. Now, clearly, this is one of the limitations of the pragmatic trials, and this can only be overcome if a surgical or the device closure is used in the time frame with an appropriate device. And hence, these are the questions which cannot be answered now, because in a pragmatic trial, where particularly in a baby Oscar trial, there were more than 300 babies below 26 weeks, including more than 60 babies at 23 weeks, and there were no differences found based on the criteria used for the trial. So let's discuss more about it into the debate. Is there any questions that come up for that? So based on this, the effect of PDA size on severity pulmonary hypertension is also related. And moderate or large size duct tend to have a moderate and severe pulmonary hypertension, and hence size on its own is a good predictor for the future development of pulmonary hypertension. Now, if the duct is persistent, as I have shown you before, it can progress from the medial hypertrophy to by 3 months of age into plexiform lesions, and that is something we need to avoid. We also know that the rate of fall of PVR impacts the volume of the transductal shunt, which is very early on, and I think we all are aware of this beautiful study that the PVR takes 2 weeks to normalize and less sensitive to rising PaO2 in the normal range. And that is a window where we get to act on to block the future complications. Now, this has again been mentioned by Patrick about the premature myocardium, how it is different from the term or the adult myocardium, because it is very vulnerable with an impaired compliance, and the inotrope responsiveness is less, and there's a diastolic vulnerability which is very common with a prolonged standing PDA with a degree of cardiac dysfunction. And the immature myocardium is susceptible to afterload, which has already been shown by Patrick. So coming to the point, which is about the ductus arteriosus and RV function, I would like to stress it again, though it has already been done by Patrick, about if the PDA is closed or restrictive, then we know that if the RV function is coexistent, then it is a question about whether INO should be started or not started, and the experiences are quite mixed, with the early INNOVO trial that was done in the UK found to be detrimental. But a careful case selection has shown that in babies where there is an RV dysfunction, in addition with the milrinone and with the nitric, there could be some benefits, and hence the role of the bedside function echocardiography comes. So management of a large PDA with pulmonary hypertension, a word about it, that the PDA should not be closed when there is a right to left shunting secondary to suprasystemic pulmonary artery pressures. And we all have our experiences of losing such kids by going through a very, I would say, adventurous closures of these ducts. PDA is beneficial as a pop-off in providing cardiac output at the cost of arterial desaturation. To decrease the PVR, pulmonary vasodilator therapy can be used and could be tried to avoid the risk of worsening of this shunting. If the PVR shows reactivity and decreases, it may potentially allow for PDA closure in the future. Closing of PDA with severe pulmonary hypertension can cause pulmonary hypertensive crisis, and earlier stages of muscular hypertrophy are indeed reversible. So in conclusion, a large PDA, whether it is early or prolonged, it causes a delay in the normal physiological drop in the PVR and subsequent long-term effects of it. Prematurity and BPD further confound the effect of the PDA, and pulmonary hypertension is a late hemodynamic consequence of a large PDA, and one should not think that it only arises after 6 months or 1 year. It can arise, as I have already shown, as early as 36 weeks of corrected gestational age. And that is the reason why I would here like to say that leaving the ductus open, as was the practice before, until 6 months of age, expecting it to close at some point of time is not benign. And we have seen from the data which has been presented from Sweden, from and elsewhere, that the preterm ductus in below 26 weeks can stay open for up to 4 months of age. Hence, the management of PDA should be guided by a multitude of factors, and we still have not found a silver bullet to treat it. Thank you very much.
Thank you, Samir, for a wonderful presentation. Due to shortage of time, may I request if we can keep the questions after the next session when we have the question answer sessions. It's my pleasure to introduce the next chair for the next session, my colleague, Dr. Zahiruddin. He's a consultant neonatologist at Latifa Hospital and also is the program director for Neonatal Fellowship Program. Dr. Zahiruddin.
Good morning, everyone. Thank you very much, Dr. Shiva, for the introduction. So I'm just going to introduce you to the coming session, which is a debate about the management of PDA. I expect it to be a very, very interesting discussion, given the nature and the title of the discussion. The debate is going to run for just under 30 minutes, and then it will be followed by a brief session of question and answer. We are already about 20 minutes behind, so we'll try and wrap it up quickly. The two additional prominent and eminent speakers or participants in the debate, in addition to Professor Samir Gupta and Professor Patrick McNamara, it's Dr. Mohit Sahni, who is a leading neonatologist and director of NEFCO Academy in Surat, India. He's held significant leadership roles, including president of the NNF Gujarat State Branch, and he's an editor-in-chief of the Journal of Neonatology. Dr. Sahni is an expert in neonatal echocardiography and point-of-care ultrasound. His work on advancing neonatal care in India is widely recognized, and he has contributed to the national effort such as neonatal COVID task force. The other debate participant is Dr. Kieran Moore. Dr. Kieran Moore is an Australian board-certified neonatologist with nearly 20 years of global experience in neonatology. He has played a pivotal role in establishing one of the most advanced NICUs of MRCPCH, India, incorporating tele-monitoring and paperless system. Dr. Moore is a specialist in neonatology, neonatal hemodynamics, and targeted neonatal echocardiography. He is the founder of the Pocus, which is a training program for Pocus and functional echo, and has published over 40 research papers. I would like to welcome our 4 debate participants, and we're just going to start.
Thank you. Thank you for the kind introduction. So after the excellent, physiological based 2 talks, we thought we'll have a debate on lots of practical aspects related to the PDA. Exactly, knowing is PDA really a problem, when to screen, how to screen, when to treat, how to treat, when to ligate, all those questions. But I think we will start. I think we will keep this session as open. We have lots of questions from our side, but maybe we should just start with, I'll let Mohit start with the open questions first.
Good morning, everyone. Good morning. Good morning, Dr. Samir. And yes, morning for Dr. Patrick. So I would like to start with one analogy. Like PDA is something like snakes to Indians. Like we Indians, we worship snake. So if a poisonous snakes come in front of us, so we are like confused whether to leave it because it will be a curse if we kill the snake. And if we leave the snake will kill us. So PDA is something like that. And all these talks have come up with the same scenario. Somebody is saying, close it, treat it. Somebody is saying, leave it. And that's why there is a issue with the debate. And we will start with this. So I would like to start with one poll. If you are the treating neonatologist, irrespective of Dr. Sameer's talk, irrespective of Patrick McNamara's talk, I would like your inputs. If you are the treating neonatologist, you are heading the NICU or treating consultant, and if you get a PDA, how many of us would like to treat that PDA? Please raise your hands. Okay. Okay. Yeah. So it depends. That is one, but few hands I could see. And those who don't want to treat the drug at all, not it depends also, don't want to treat the duct. Then maybe, what is maybe? Yeah. Anybody wants to comment on this?
Yeah, it depends. I might go for a medical management, but I will think 100 times before even I consider any surgical ligation or any intervention. Yeah, I will consider giving medical management, especially if the duct is hemodynamically significant.
So I rephrase my question. I take out the surgical ligation. Medical management. Who wants to treat with the medical management? Please raise your hands. No, now.
Okay.
But the numbers of hands have increased.
Echo is done and cardiologist reported PDA 3 millimeter. That's all. You know that short. No. Okay. No, not Dr. Sony's echo. You got a report saying PDA patent 3 millimeter. That's all your report. And you have a baby who's supposed preterm. Will you treat or not treat? Okay. Okay. So he wants to know more about the clinical status. So, okay. So first question, is it a knee-jerk reaction? Whenever you see a PDA, do you get urged to treat? That's we're trying to. No. So everyone wants more information, clinical and so okay. So clinical questions, what's the status of respiratory condition, clinical
So
gestation?
invasive ventilation, non-invasive ventilator,
Right.
How much the oxygen requirement, how the baby is feeding or not, any problem with abdomen, there is NAC, any IVH previously or what, as a general condition.
Correct. So previous condition and the current status before deciding. So Patrick, any comments on this first question, PDA?
So Dr. Patrick, now here,
Yeah.
houses bit divided. But most of them, they are on the same page. They want some information. Then only they will decide whether they want to treat the drug, medical treatment, or whether they will leave it. So we want your expert comments on this.
So, I applaud Sameer, and I want to make this comment. Conducting a randomized controlled trial is a huge, big deal. Okay. And, my comments are very specific to, based on the information that most neonatologists get in most centers, which is the size of the duct, the direction of flow, and maybe the LAO ratio. If you look at the trial, which is a pragmatic trial, but that reflects the reality in most centers, there's no benefit to treatment and maybe harm. So, and that's my stance as well. A limited approach to adjudication of hemodynamic significance is not going to help you. Okay. The fundamental question is a more comprehensive appraisal. Does that make a difference? It's no different to subjective evaluation of heart function. We know it's highly unreliable. Okay. The kappa coefficient, if you take experts and get them to look at, does the heart function subjectively look abnormal, or does the septum look flat, which is qualitative evaluation? A kappa coefficient is 0.15 to 0.2. So you got a 20% chance of getting it right. So I think, what we need to take away from this at this point in time is that a simple way of assessing this problem doesn't work. Okay. And as Sameer has pointed out, this is why we have to be careful. The Iowa data suggests, the word is suggests, that a more comprehensive evaluation and a more discriminatory way of evaluating the shunt, at least in our center, appears to make a difference. And again, We are aggressive at the worst shunts. We ignore those that are pathologically kind of low volume, etc. And we don't see harm in the ones we ignore. And we potentially see, great benefit, in the ones that we treat aggressively, and like as I say to people, whatever the results of the trials are, you can't ignore a neck rate of less than 1% in more than 200 babies born at 22 to 23 weeks gestation. That has to mean something. Okay, it's not miraculous. Okay, so it means something. The question then becomes, how do you replicate that in a larger trial design? Okay, and here's the other thing to put into people's mind. As I said, I stand by Samir's trial. However, do we have evidence that there is no trial to date that has classified shunts into truly high volume, moderate to high volume? Does ignoring moderate to high volume shunts on a more comprehensive assessment mean that there's no benefit or there is benefit? And the answer to that, we don't know. Okay, so all I would say to people is a lot of people have incorrectly, and I think Samir would agree with me, incorrectly interpreted the results of baby Oscar and Benedictus to mean we don't need to worry about the PDA. It doesn't make a difference. Okay. We don't believe that. The quest now is, okay, the approach to evaluation is too simplistic. If that's what you're practicing, you're going to overtreat babies and you're going to undertreat babies. Okay. So, and I think that the picture in front of you also emphasizes there's some patients in whom their ductus is highly, highly beneficial. So it's not easy. This is not easy, and we can't get the answer. We can't make it easy.
So again, in PDA, probably we'll like to go to the individualized based approach. We'll talk about what trials are saying, but definitely we don't want to jump and treat the PDA. And we have to identify babies where it might be beneficial, or or it could be just a bystander. So don't have to jump in and expose with the side effects. That's the kind of message we want to get on.
Yeah. See, more we discuss, more confused we get. But the thing is, it all depends on number of people in the unit who are trained in doing TN echoes or F echo or whatever you say that. And then you keep on monitoring that. So one thing that I heard that term first time by Dr. Samir, PDA monitoring. So that is something which may help us in deciding whether we should go for the treatment or not. Dr. Samir is there? Dr. Samir?
Samir.
Yes, Mohit. Yeah.
What do you
yeah.
Yeah, so we were just discussing that I heard this terminology first time a few years back from you only, PDA monitoring. So we would like to have some thoughts on this PDA monitoring because we were discussing regarding closing of the PDA, whether we should treat or not.
Thank you, Mohit. I think going from the previous question, I'll just take a continuum there, what Patrick has mentioned. PDA is a continuum. And I think one of the things which unfortunately has got into our practices around the world is saying that a hemodynamically significant PDA, and we lay all the eggs in this basket to say whether the duct is significant or not, and focus on the duct. Duct is one of the jigsaw, as I showed in one of the slides, of three things. One is how premature the baby is and what we are really worried about. Second is what are the ductal characteristics and its effects. And third is how is the heart and the body coping with this. So when we have the three taken together, then we are able to define, are we really wanting to manage this problem in a very systematic way? Now, what have we done so far? And I'll come back to the question that you have posed. When we go back about 30 years, it was felt that any duct which is there, we close it, that is the right answer. Then comes early, before it is symptomatic, close all the ducts, prophylactic approach practiced until recently in many centers. We came to know that prophylactic approach is not the right way forward. We moved forward, we selected based on the ductal characteristics, we selected based on the appropriate gestation, not up to 34 weeks, but extreme preterm babies, and found that there's a potential for harm by even selecting the premature babies, by selecting the duct characteristics, but we have left out the cardiac function. Now we need to integrate the cardiac function into the jigsaw and see, does that make a difference from single center to a multi-center approach, and see what it makes a difference. Coming to your question about the continuous monitoring. So a point monitoring of the duct is dependent upon the unit practices. So if the unit believes that early intervention is the goal forward, then yes, you do the first echo in the first 12, 48, 72 hours and decide about the management. However, from the recent data which has come from the trials, and it is about the shunt volume and when does it cause a problem, it is now becoming clear from the post-hoc analysis from the TRIOCAPI trial and from the PDA audit trial, where they had the data on the assessments of the duct over a longitudinal period of time. They found that a duct which is open for 7 days, and between 7 and 14 days, the burden of the BPD in these patients increases tremendously. And is it the right point where we should be intervening is around 7 days of age, the duct is still open with the clinical symptoms and signs, and the cardiac function compromised. So should we be targeting these particular group of babies? We don't know the answer, but this is one of the proposals. Hence the reason why a longitudinal assessment of the duct, given the clinical scenario and the other factors with the heart function, is important in making the decision. So that is the reason why I have tried to mention that a longitudinal assessment is important, just not a point assessment.
Mohit, can I just make a couple of comments? Just I think that are also important, just to put into people's mind. I think the other fundamental question is, what are you trying to achieve? Okay, so what is your goal of care? If the goal of care is you're trying to mitigate the risk of pulmonary hemorrhage or IVH, the only way to mitigate those risks is early. Okay. If you're trying to mitigate the risk of neck or BPD, obviously you may have more time, but based on what Samir has said, 7 to 10 days exposure alone may actually be kind of enough to push you into kind of a category of more significant shunt. Now, again, we've not done that study, and there are, the challenge we face in looking at more longer term outcomes is, have we homogenized the population too much? How, what is the best metric to adjudicate kind of efficacy of more, delayed approach? And then of course you have the question of, treatment efficacy. The pivotal trial, which is currently being conducted in the United States, which is a trial of transcatheter closure versus conservative therapy, may at least offer the question of, you don't have to worry about kind of inefficacy in the treatment arm, because if you close the duct, you close the duct. The challenge with the pivotal trial is it's allowing enrollment up to kind of 4 to 5 weeks. So if the age of enrollment is very late, and based on what Samir has presented to you, the ability to mitigate the risks of BPD and pulmonary hypertension becomes, a lot less. So it really comes down to, at this point in time, the best advice we can give you is individualizing the care, based on the patient in front of you. The final question I would say is that, and this is a more controversial element, is what is the best way to study the efficacy of any therapy in a preterm population? Okay, and that's our biggest challenge. Randomized trials are the highest level of evidence. However, it's complicated. There's so many competing interests. There's so many morbidities that may be going on in these tiny babies that can independently affect particularly longer term outcomes and so forth. So many have suggested that perhaps not the classic kind of individual patient trials as a way to move forward, but perhaps cluster randomized trials, in which centers are randomized, maybe a better way to adjudicate, efficacy. And we didn't talk very much about, how is it possible to get the outcomes so good at a place like Iowa? And again, it may be that just adding in this approach is just another layer in a very well organized, well orchestrated system that has a high degree of standardization of care, minimizes variation between neonatologists. I think that to me is really, really important as well.
Mainly the important, as Dr. Soni was trying to highlight, is importance is how long the PD is open, what's the shunt volume, the duration of the exposure of that volume to the baby, what is the exact gestation. And then on top of that, I think the intention to treat. Okay, we are back. Important is to not allow open label treatment, because most of the trial had 20 to 25% open label treatment. And that is why, again, the two groups were quite mixed. So the trial should be designed factoring not only the diameters, but also the shunt volume, the end organ effect on the systemic circulation or the cerebral circulation, all those factors. And then you decide to treat based on the comprehensive assessment. And then you divide into two groups and then, sort of randomize. That's probably the way forward. That might be able to give us a clear-cut answer. We are back. Patrick, sorry, we lost you in between with some technical issue. So we were just discussing in between here.
Oh, I was just talking to myself, or maybe I was talking to Samir.
Sorry. Yeah, I think the online crowd, they were listening to you, but we couldn't.
But,
yeah, I
Patrick,
I
was having the joy of listening, so don't worry about it.
Arvanan
has a question.
Hi, Dr. Patrick. Hi, Dr. Samir. Thank you. As usual, very interesting discussion. I have one question for Dr. Patrick and one question for Dr. Samir. Dr. Patrick, I think recently I've seen this phenotype, is it PDA alone or PDA plus cardiac dysfunction or PDA plus pulmonary hypertension or PDA plus cardiac dysfunction plus pulmonary hypertension? I think in each and every area that we are moving towards a phenotype that is kind of giving us the clue about the individualized care for the patient. Similarly for the BPD as well. So where are we going on this with the phenotype classification? Because I think more and more, I think your recent article on the phenotype is also talking about the individualized care based on the phenotype of the baby. That's a question for you. And then I think the question for Dr. Samir is, we know about the functional echo or TN echo is very useful, but even the big institutions with a big team are trying to struggle with the consults. Dr. Patrick was mentioning about more than 2,000 consults in a year. He has a big team, and in Sidra, I think we have 7 people are doing the hemodynamic consult. We have more than 500 consults in a year. So how anyone who is interested to start their practice in their institution, and I think Dr. Mohit has 6 people in their team, how they are going to face the practical problem in order to start doing the functional echo for PDA monitoring. Because if they want to be successful on the monitoring, it is going to be a long-term one and multiple people need to be involved. It's not a single man army. Yeah, thank you.
See, I have 6 people in my team, but I am the only one who is doing it. Echo. Rest are not doing that. They are neonatologists. They have been treating, but they have not been trained in this. So there's the problem. And now, after so many years in the night, when they call me, I tell them you treat whatever you want. I don't want to get enough. So this is what is happening after 10 years of my persistent practice and monitoring. This is what happened to me. I tell them, do whatever you want. Dr. Patrick. So now this is the question. This is a very common scenario in countries like India, where in the units, you have only 1 or 2 person who is trained in that. And the team is not there. Big team is not there. Then the question.
Everywhere, I think.
Yes.
Many places is
in his unit, he must be you are the only one in the unit. Yes. So that is the problem for all of us. Practical problem for us.
Right. So I think I got asked the question about phenotypes, and then I'm happy to weigh in on kind of hemodynamic teams after Samir kind of comments on that. I just go back to something that Samir mentioned, which is, serial monitoring. So, the one thing that's become very, very clear to us, is that the answer is not always present on the single echo. Okay, so, oftentimes, whether it's PDA or heart function or whatever, we may decide, this is not clear. We need to go back and reevaluate in 4 hours and 6 hours. And then at least we have a better sense of trajectory of the physiology. And I think, the only way you can practice phenotype-based care is with comprehensive hemodynamics. You're never going to figure it out with one measurement. Okay. Then there's many examples of that. Infants with congenital diaphragmatic hernia. Okay, perfect example. A basic superficial echo. You may think they all have resistance-mediated pulmonary hypertension, and you won't recognize that some have left heart phenotype versus right heart phenotype. Infants with vein of Galen malformation, pulmonary hypertension, commonly seen, associated. Some are flow-driven, some are resistance-driven. If you don't look at flow and outputs, you're never going to be able to differentiate them. And then if you take it to the preterm population, or the extremely preterm baby, you have infants that have normal heart function with kind of large PDA shunts, and those that have abnormal heart function with high volume PDA shunts. Question then becomes, is the heart function a consequence or it's independent? And then trying to tease out, whether you treat the ductus or leave the ductus alone because it may be supportive, to these babies. And as I said, to figure out these phenotypes require kind of multiple time point evaluations. The other issue I think is important is that the physiology changes. Like the first case I presented to you, that infant went through 3 different physiologies over a period of 12 hours, and, if all you get is one echo, then you're never going to know that. And you may assume that the patient is getting worse because of the first disease you were treating. And then you go down the wrong pathway, if you don't recognize that actually something has changed, with the patients. To do that requires a team. It can't be done by one person. It requires more than one person, but you have to have consistency of the care and consistency of the training. So I'll let Samir take it from there.
Thanks, Patrick. I fully agree with you, and I think I would comment that with the introduction of the bedside echo and understanding of the physiology, we have got to a point of identifying the various phenotypes associated with the PDA. And I think that's a very, very important aspect now, that once you've identified the phenotypes, moving forward, if the stratification can be done based on the phenotypes, we would be able to answer question for individual phenotype in the large multi-center trials. However, that brings a question about the centers having the appropriate manpower, the expertise, and a uniform working strategy with high level of quality. Then we will be able to answer the questions. Now, the Aravna's question about that, is it feasible or not? I think that we have seen that it takes time. It is feasible. It is possible. It takes time. So first is about the drive and the funding and the aspirations. So I'll take here the example for Sidra. Sidra is a greenfield site, which is about just about 6 years old. So when we first wanted to start the functional bedside echo program, the pediatric cardiology team were not ready to support us because it is American based, and in Europe it was more integrated. However, we pursued, and now is a big team of about 7 people, and we've already trained about 7 fellows from there, and now expanding onto a perinatal cardiology and neonatal hemodynamic fellowship program of 2 years, rotating between CICU and cardiology. So there is a way of moving forward. Second is the time being productive. Now, clearly, when we started, there was no dedicated time allocated for the echo, and thanks to the team for taking on the efforts and the drive to do in the time on their own. But after moving forward, now every single consult that we get for the functional echo, there is a work review associated with that. And with the work review, the time is credited and the work is credited. So the question now for individuals or center like the CIDRA is not about are we able to commit to it or not? We can commit to it because it's a remuneration or a time that is identified and been governed for it. Not all centers will have that. And there comes the problem about developing the workforce and the time commitment. Unless and until these two things come together, it is not possible to sustain a program. And then we see a 1% fine. When you are young, you can drive it. But when you are done it for 10 years, you say, well, I don't have time to do that. I have other priorities. And then the program fails. So succession planning is very important so that the program can continue with appropriate funding. And I think more important work than this, which has been driven from the NPE in Europe and by Patrick in North America and NHRC globally, is developing the centers and the countries to undertake the training program. Because the training program, only until recently, even UK had not integrated. They have now started going for Pocus, which is a limited program with its own benefit, but not a full assessment program. So we have number of obstacles to cross, but at least we have started, and I think we are moving in the right direction. And the centers like I would say Iowa, like CIDRA, like many other centers, say for example in Toronto, Amish Center, Boston, and we can name that the centers have developed where it is guiding the way forward in developing the program. And I think that's the way forward to work together. And as Patrick, if you want to mention, Patrick, I'll leave it with you about developing the collaborative registry as you're working on it and put in the data and try to learn from that high quality data about the interventions, which are otherwise difficult from the well-designed trials with the good centers to participate into it without funding becomes a challenge, but there is an answer to that, what you were already mentioning. So I'll stop there. Thank you.
Thank you. Thank you, Patrick. And thank you, Samir, very much. I think that was, so monitoring comes with a responsibility to closely watch this baby and individualize the care. But training people is a big task and running the program is a big task. So till then, maybe I think treating might be an easier option. Okay, so we have only 5 minutes left now. We had lots of questions to answer, but now we'll do a rapid fire of some of the practical aspects of the PDA management. So first question, PDA is diagnosed day 3, day 4 of life. Would you restrict the fluid by 20 ml per kilo? How many of you would like to restrict straight away? Raise hands. Yeah. Very few hands. So that's, I think this is a practice, lot of, I think age old, like whenever the PDA is diagnosed, we tend to cut down on the fluids because everyone worried that it will make the PDA larger and it might cause pulmonary bleed. But contrary, actually, PDA is already compromising systemic circulation. So restricting probably might not be the good idea. It might just cause more of a systemic steal. But liberal use is what I think there is no evidence supporting restriction routinely is important. But yes, you don't want to go up very sort of rapidly to 150 or 180 in certain times in preterm babies, especially 23, 24, 26 weeker, they need a very high volumes. So there probably use of humidification and sort of judicious use of incubators. I think this is not working. So that probably might be the good idea. So use incubators. Sorry, the slides are not moving. So maybe use humidification and then try to don't liberalize too much, but maybe 140, 150 might be the way forward for the feeds, for the fluids. Next question is routine diuretics, PDA diagnosed. Would you start furosemide? No. Anyone? Okay.
Okay.
First week of life, furosemide you will treat, or second, third week? Do you have any reservations starting on early furosemide? Yeah.
Again, it depends. I think it depends as an answer will remain with us for the rest of our life. But again, it depends on the measurements, the assessment, the clinical condition.
Correct.
And I'll have a choice of using either a lower dose diuretic or a higher dose.
So we tend to write, but again, as sir said, basically you do an echo assessment, you see if there is signs of overload, and then only you treat it. Routinely probably jumping and it's not working again, but routine is not required. And maybe in late stages when there are signs of dilatation, cardiac dilatation, CCF, that time probably frusamides or routine diuretics required, but not routinely. Okay.
PDA, if you use the furosemide, there are a couple of publications on that. Using the furosemide itself leaves the PDA patent for longer.
Correct,
There have been a
correct.
couple of papers on that as well.
Correct. Through the
But again, it
prostaglandin
depends on the
pathways.
comprehensive assessment.
Correct, correct. It interferes with the prostaglandin release and all those things. So yes, only with evidence of cardiomegaly. Which drug to use? In how many of you in your unit, paracetamol is the first choice? Ibuprofen, IV, first choice. IV. Anyone has? Okay. Ibuprofen oral. Few hands. Okay. So I think again, really depends on what choice. The jury, we already discussed paracetamol versus brufen. Every drug has its own mechanism to work. Paracetamol seems to be very safer option at this stage. So many people are preferring towards paracetamol. But if it's not working, maybe with a second course, you might think about oral brufen because the evidence is still supporting that. And IV ibuprofen, if it's possible, if the baby is NPO, there that is where the problem comes, because IV paracetamol is probably routinely available, but not the IV brufen. At least in India, that is a problem we face. So we tend to choose IV paracetamol or oral. Monica, suppository of brufen. Okay. Again, there are no trials about it. The route of
Trials are less, but still this thing has been discussed in detail. Like Dr. Patrick has put
has
as
covered
a-
it about the.
Yeah, so we will just still.
When do we consider? You have any question? Sorry, or comment? Okay, comment about ligation. So again, how many of you will go for ligation, and when do you go for ligation? How do you decide about decision for ligation and device closure? Last question, I think, and we'll close. Decision for device closure. How many of you in your unit has device closure option available? Very few hands, only few units. And so again, the decision for ligation, maybe just one question.
I have a question on this.
Sure.
In our unit, we are gradually moving towards device closure, and people who want to propose and argue for closure of the PDA usually argue and propose that device closure is much safer and more efficient. I know that Dr. Patrick in his presentation mentioned that in his unit, they use the device closure as a routine. One of the questions I have is there any, what's the experience of comparison between the surgical ligation versus device closure in terms of safety and efficacy? And because some of the studies which have come out clearly shows that device closure, the average age was much later compared to the surgical ligation. So what's the current experience in terms of evidence? Because more and more people who argue would like to close the duct through the device even when it is not indicated. That's my concern.
Sure. Patrick, your take on this.
Yeah. So I think we're still in early days. It's kind of interesting. We've evolved, at least in North America and other parts of the world, that device closure has overtaken surgery as the gold standard. If you actually look at complication rates, at least mortality rates are similar between device closure and surgery. So there's really no benefit in terms of mortality reduction. I think most of the benefits probably are in the realms of avoiding, the direct complications, significant complications of surgery like pylothorax, kind of major hemorrhage, etc. But babies can die during cath closure. It is not completely benign. I think the recent study from the NRN I think highlighted, if you choose BPD as an outcome, and again, it's a highly questionable outcome, device closure didn't have any benefit in reducing BPD. And actually the device closure population were associated with a higher risk of neck. However, I think as someone in the audience pointed out, the age of device closure was about 20 to 30 days later than actually PDA surgery. So in kind of comparing and contrasting kind of these two modalities, controlling for age and intervention, I think is something really, really important. Now, there was another recent publication from the Vermont Oxford network, which did seem to suggest, I'm going to use the word suggest, that outcomes long term may be better after device closure. I would argue that if we're achieving comparableness at this point in time, where most centers are on the learning curve for device closure, that to me is reassuring. Okay, because we know that centers who perform more procedures have got much better complication rates. I think I figure if you're doing less than 10 device closures in your center per year, your likelihood of having significant procedural complications is much higher. Okay, so I think that my last comment would be that, there needs to be the establishment of centers of excellence for device closure. And I think places should not be doing this once or twice a year on their own.
Mohit, can I comment in there, or Kiran?
Yes, sir.
Sure, thank you. Well, and in response to the question that has just been posed, at Sidram we don't do surgical closure for since opening 6 years. It's all the device closure. We close as small as 700 grams and put in a device. The complication rates are low. However, this year at the NeoCard UK conference, we kept a controversial, which was the talk delivered by the interventional pediatric cardiologist from Birmingham about the device closure in under 1,000-gram babies. And that's where the problem is. Our focus now is growing below 28 weeks or more so below 26 weeks and early on. But are we safe to use a device closure in this group of babies early on? Previously, there was a problem that the Empressor or Piccolo was not available, and hence we were restricted to babies who were over 2 kgs, and hence we had to wait. Now, with the availability of Piccolo device, it can be placed in smaller babies, but the complication rates are still high and the confidence is still low. And in our center also, we are slightly cautious for babies below 1,000 grams as compared to over 1,000 grams, though the expertise available and the excellent techniques and the interventional pediatric cardiologist available, we are still cautious. So there are two things here. One is which group of babies we are wanting to close, when we are wanting to close, and is the device available. So the challenge is out there. Under 26 weeks, early on, we are not there yet, given the complications and the concerns about it.
Thank you, Dr. Sameer. So we already overshooted more than 18 minutes. So quick comment or question, then we have to stop, please.
Thank you. I mean, fantastic talk by Patrick and Sameer. Patrick, I mean, it's an amazing achievement to achieve an NEC rate of less than 1%. Two questions. I mean, the definition of NEC, does that include SIP in your kind of work? Now, my second question is obviously the timing of the intervention, if it includes SIP, because the duct has a different natural history as we treat. You aiming to decrease shunt volumes through treatment and monitoring that through the hemodynamic assessment while you're doing treatment, because the endpoint is not always closure. So I'm just curious.
Right. So we do have SIP. Okay. Our rates of SIP are also very low. And the practice in Iowa is if we have a SIP, we will place a drain, and then within 36 hours, we will do early surgical intervention. And almost 100% of those babies have inspissated meconium. That seems to be the most common entity associated with SIP in these babies. So that kind of clarification of the cause of SIP neck versus inspissated meconium, we have hardcore data on that from our surgical team. I think that the second part of your question was, how are we getting this? And I think, many people would say that a 6% neck rate previously was pretty good compared to many centers looking at 22 and 23 weeks. And I think the ethos or philosophy that we have in our center is our goal is not to get the baby to full feeds and get the lines out. Okay. We firmly believe, and I use this, and this may sound very controversial, breast milk should be treated as a drug. It is the best thing for these babies, but the fetus in utero does not have breast milk in the intestine. And we got to recognize that the ability to tolerate feeds is likely to be a lot less. The other thing that's important is, we don't necessarily know that, from an enzyme perspective, does the pancreas work the same way? Do we have enough lipase, et cetera, et cetera? So our approach to feeding is slow and cautious. Okay. The other question that we had kind of early on was about maybe 3 years prior to us introducing hemodynamics. Probiotics had been introduced to our center. So slow, cautious approach to feeding, and then we add in probiotics. So that was another, initial, could this be, kind of, probiotic related to the effect? We've now not given probiotics for 2 years because of the whole kind of US kind of concerns around the FDA and probiotic use. We haven't seen a relapse. So the neck rate hasn't changed at all. It's remained extremely low. So I personally, I think it's a very slow, cautious approach to feeding, and then combined with enhanced management of the hemodynamics seems to make a difference. Like we joke with our trainees, if you want to study neck, don't come to Iowa. We don't see it. Like it's crazy. Like we have up to now somewhere between 25 and 30 babies under 20 kind of 3 weeks and below gestation. So there's a lot of these babies and we don't see neck. So
they can all come to our unit if you want to see neck. Thank you, Dr. McNamara. Thank you, Dr. Gupta, for great insights we all had. We need to stop here because we have already overshooted by 20 minutes. So it was a great session and great discussion. And in the end, I again come to my same old analogy, that snake. If a snake is in your room, I remember my old teachings from my parent that if you have an outlet from where the snake can go out, fold your hands, pray, please go out. Don't make it aggressive. So if the PDA doesn't do anything, let the PDA go away by itself. And that is what we have. This is what we are at still. So that old teaching is still there. Thank you very much. Thank you everyone for the participation and discussion. Thank you, Dr. Samir. Thank you, Dr. Patrick.
Thank you.
Thank you, guys. Samir, pleasure to join the stage.
You can all go.
Thank you.
At the
Thank you very
Yes.
much.
Come back.
Thank you,
here.
sir.
For next 10 minutes, we'll start.
Online,
I'm going to
can you
bed. It's 3 o'clock.
take, 10 minutes break and you can log in again in 10 minutes.
When it goes in the tray, train
Hi, thanks, Monica. From PDA, now we move on to congenital heart disease. It's my pleasure to introduce the first speaker, dear colleague, Nishant Shah. So he's given a very brief CV here. He's much more than that. So Nishant actually trained, qualified from India, trained in the US, and completed his pediatric residency and fellowship at leading institutions in the US, and served as associate professor at Penn University before moving to Sheikh Khalifa Medical City in Abu Dhabi, where we work with very closely. He's involved in pediatric cardiology education and research and is a multi-award winning clinician. He's one of the team of 5 cardiologists at Sheikh Khalifa who support us at Cornish Hospital in dealing with our babies. We are, I think, the main source of patients. So in addition to supporting that, you also chair the department at the moment. So without much ado, I'll hand over to Nishant to talk about critical congenital heart disease. Thank you, Nishant.
Thank you. Thank you for introduction. Good afternoon, everybody. Thanks for this opportunity to present. Next 20 minutes, 25 minutes, we'll talk about congenital heart disease, fetal and neonatal perspective. Disclosure. We'll briefly touch about anatomy, physiology, cardiac disease classification, fetal echocardiography, counseling, ductal dependent lesions, cardiac emergencies, and few scenarios that we will go over. Whenever we talk about cardiology, we definitely, like to have some information about fetal circulation, transition after birth, what are the normal pressure and saturation in cardiac chamber, cardiac cycles, and follow blood flow segmental analysis. I think tomorrow in one of the session, we will discuss about segmental analysis when we talk about that. Fetal circulation, in the previous one of the speaker mentioned the ductus venosus, where the blood bypass and majority of the blood from ductus venosus, which carries saturated blood, go through foramen ovale and enter into the left ventricle, which supplies a vital organ. And therefore, now we can understand that pathologies such as hypoplastic left heart syndrome or complete transpiration of great arteries, babies, they have some brain abnormality even before any intervention, because they are not getting this saturated, more saturated blood to LV and not going to the brain. PDA, lot of talk about PDA, not going to talk about that, but PDA is one of the important structure in our congenital heart disease when we are talking about ductal dependent lesion, and we'll touch base over a few slides. After birth, the PVR drops within the pressure dropped to more than half within 24 hours after birth, and it continues to drop in next 6 to 8 weeks. And therefore, we know that VSD, when large VSD, when they are present at birth, they are not symptomatic, and over the next few weeks, they become symptomatic. So as PVR drop, the blood flow to the lungs increase, and then patient becomes symptomatic. Normal pressures and saturation to keep in mind. And last but not least, cardiac cycle. The cardiac disease, I simplify in the simple way: structural heart disease, functional heart disease, arrhythmia, and a coronary abnormality. And then structural heart disease include our, congenital heart disease. That's the main, patients in our NICU. When CHD presents or congenital heart disease present in the early infancy or neonatal life, we can divide those patients into 3 major categories as far as NICU concern or neonatal unit. One is a shock, when the baby is presenting with shock. These are mainly left-sided obstructive lesion, present within 1 month of life, present with hypotension. In that situation, saturation may be low or may be normal, depending on the lesion. On the other side, the babies who have a mixing lesion, they present with lower saturation, we call is a blue baby, and this may have increased or decreased blood flow, again, depending on the pulmonary blood flow, whether they have good pulmonary blood flow, restricted pulmonary blood flow, or over pulmonary blood flow. And the last is a acyanotic disease where the baby's saturation is normal, usually present as a pink baby. They have either right to left shunt, they have either afterload, so valvular pathology such as aortic stenosis, impaired myocardial function, or arrhythmia. So these are the three main categories that we will see in our NICU. Briefly, we talk about fetal echocardiography. We do fetal echocardiography at SKMC and at Cornish Hospital, Abu Dhabi. Definitely, it is very helpful in terms of parents' perspective. They have a time to understand what is a heart problem. When the heart disease or significant heart disease told after birth, mother may be in the hospital after cesarean section, not able to understand, not able to come to the meeting. So prenatal diagnosis definitely have adequate time for them to understand. Yes, when we break the news, they are denial or depressed, but eventually they recover. They come to understanding, and they are well prepared at the time of delivery and after delivery. We discuss about different treatment options. Prepare family for postnatal plan. They meet the doctors in NICU, they meet our surgeons, they visit our PICU. So all these procedures done before the baby is born. Then also, I mention to every family when I see significant heart disease, such as single ventricular pathology, I discuss that there is an option of not continuing pregnancy or not offering any treatment after birth, and we'll again briefly talk about it. Again, the normal fetal echocardiography, it gives reassurance to parents. Physician perspective, definitely it helps managing the baby. Most of our cardiac patients, they do not require any significant management antenatally other than arrhythmia or twin-to-twin transfusion or high drops, but otherwise we want them to continue pregnancy towards the end. At 9 months, we want baby to grow in mother's tummy, and then we determine the place where baby should be delivered, how baby should be delivered. If there is a heart block, we don't want baby to have a distress of labor, so we recommend C-section. Versus majority of heart conditions, we allow them to go for natural delivery, and then smooth transition from labor room to postnatal management to intervention if needed. That can happen in timely fashion. We all know that fetal echocardiography improves outcome, particularly when it comes to complex heart disease. It associated with decreased preoperative morbidity, less acidosis, and better end organ perfusion. Fetal echocardiography in utero, again, as I mentioned, that we don't have too many interventions. There are some interventions such as aortic or pulmonary balloon valvuloplasty, atrial septosplasty or septostomy. They are available only in few centers and they are investigational. We do not perform that in SKMC. However, centers such as Boston, few years back in Philadelphia, they were performing such intervention, but again, they are investigation, not standard of care. Again, in the antenatal time, twin transfusion or teratoma arising from cardiac treated antenatally successfully. Not everybody needs fetal echocardiogram. There are few indications where the maternal disease or maternal drug exposure, infection, or family history of heart disease. On the other side, whenever suspected cardiac anomaly on the routine scare. So these are the very important. Now, every center has a different way of examine a complete examination of fetus antenatally. That is done usually by OB, whether they include 4-chamber view, 4-chamber view, 3-vessel view, sagittal view. So based on that, some malformation can be picked up, some malformation can be easily missed. So suspected cardiac anomaly, extra cardiac malformation, such as patient has diaphragmatic hernia, definitely when there is a fetal arrhythmia is suspected, non-immune hydrops, increase in nuchal thickness, between gestation, IVF pregnancy, fetal echocardiography should be considered suspected chromosomal abnormality. And sometime I get referral that I cannot see the heart, where the images are very difficult to catch, and we do fetal echocardiogram on those patients. Once the fetal heart disease is identified, the detailed counseling happens. This usually takes around 1 hour. It requires antenatal planning during pregnancy, postnatal care, surgery, intervention. I talk about survival rate, short-term and long-term, what they do when they grow up, how is the school life, college life, life in adulthood. If the fetus is female, then briefly touch base about marriage, pregnancy, and the neurodevelopmental issues. So if let's say if I'm counseling mother who has a baby hypoplastic left heart syndrome, I usually mention that we will not do anything while mother is pregnant. We'll continue pregnancy up to 9 months of gestation age. Baby should be delivered in the center where pediatric cardiology service is available, and the NICU is capable of taking care. So if patient is coming to SKMC, I divert them to Cornish Hospital to be delivered. After birth, prostate should be started. The scan will be performed, the diagnosis will be confirmed, and then the surgical option, particularly Norwood stenosis surgery, will be done within first 1 week of life. Then I talk about that what is the survival rate of Norwood surgery, Glenn surgery, Fontan surgery, how will they do in the school. We know that single ventricle population, they have some neurological developmental issues, so I briefly touch with that. And then pregnancy and Fontan circulation, they don't go very well together, so I briefly touch as well. And the long-term outcome, how long they can live. So all this discussion happen in that 1 hour, and it is very important for family. In my records, I write that, okay, this patient should be, delivered at 9 months of pregnancy. Mode of delivery can be natural in case, most of our heart patients. Place of delivery, if it's a simple disease such as AV canal defect, I don't mind having delivery at their primary center, primary hospital. I don't want them to transfer to other hospital in the middle of a pregnancy. However, if there is a complex disease, when there is an intervention is needed, I usually request them to or recommend to transfer to the tertiary care. Whether prostatin should be used or not, expected saturation, whether use of oxygen is recommended or not, neonatal intervention will be needed or not, and then 2 possibility pathway from the NICU, either feed, observe, and discharge the baby, and we will follow in the clinic, versus manage preoperatively and transfer to tertiary care for further intervention. So these are the guidelines that I put in my report for the neonatologist when I see a patient with heart disease. Segmental analysis, whenever we do evaluation, a cardiac evaluation, segmental analysis is very important. Seno-atrial connection, atrioventricular connection, ventriculo-arterial connection, follow the blood flow, how the blood flow is going. That is very, very important to understand pathophysiology of any congenital heart disease. As an example, if we talk about this tricuspid atresia, and if we take this, this image on the left side, here we have the tricuspid atresia. So from FVC, IVC come to RA, tricuspid atresia, so cannot go to the right ventricle. It has to cross the foramen ovale or large atrial septal defect and come into the left atrium, mix with the blood coming from pulmonary artery, going to left ventricle. There is a VSD, so the blood will go through VSD into the right ventricle and go to the pulmonary artery, and the blood from LV also will go to the aorta. So here, this is a blood pathway. On the other side, tricuspid atresia with no ventricular septal defect, the blood will go from RA to LA, LA to LV, From LV, it will not go to RV because there is no VSD. So we'll go to aorta. So how the blood will go to the lungs, it has to go through PDA into the pulmonary arteries. So follow the blood flow. It is very important to understand the pathophysiology. To add more complexity into this lesion, what if there is a transposition of great arteries in addition to tricuspid atresia? So it will continue. So blood flow, following blood flow is very, very helpful. Management. Whenever the baby is suspected with a heart disease, we'll start with vitals, blood pressure. Now, blood pressure, at least 2 upper limb and 1 lower limb, very helpful. Think about that. If there is a right aortic arch, then the first branch will go to the left upper arm, and the last branch, subclavian, will go to the right arm. So the right arm will be postductal, and the left arm will be preductal. Think about that. If there is an aberrant subclavian artery, then everything can be the postductal. Both arms can be postductal. So it's important to take a blood pressure not only in one limb, but both limbs. Similarly, saturation in upper and lower extremity will be very helpful. Absent of murmur does not exclude or include cardiac heart disease, but murmur will be helpful to identify if there is a significant murmur. Check for rhythm. What is the rhythm? Is a sinus rhythm? Peripheral pulses? What is a perfusion? Chest X-ray, EKG should be part of initial evaluation. Blood gas, arterial as well as venous and lactate level, and the echocardiography again to complete the evaluation. Undiagnosed congenital heart disease presenting in neonatal period can be divided into ductal dependent systemic circulation, ductal dependent pulmonary circulation, and non-ductal dependent lesion. Again, not all cyanotic disease is present with cyanosis, so their saturation will be lower, but may not have a cyanosis. PDA dependent circulation, we have a systemic circulation, pulmonary PDA dependent pulmonary circulation. So few examples of this lesions. PDA dependent pulmonary circulation, the ductal shunting will be left to right versus systemic circulation in that ductal shunting will be right to left. This patients can present with shock if the ductus is closing. This present with severe cyanosis when the ductus is closing. And this patient, again, ductus post-prostate should be started as soon as possible. Ductal dependent pulmonary circulation, they are cyanotic, silent tachypnea, fail hyperoxia test compared to ductal dependent systemic circulation when they present with the gray baby, means hypotension, and shock-like stage. Management, usually if the ductus is closing, we start with the higher dose of prostatin, 50 to 100 nanogram, and then slowly cut down to 10. If the ductus is too large, sometimes I recommend to cut down to even 5 nanogram per kg per minute. We all need to know about side effect of prostatin, that includes apnea, temperature instability, and flushing. Diuretics and inotrop can be used depending on the symptoms and presentation. So ongoing evaluation will be very, very helpful. Okay. Hear about these patients. These are the emergencies for me. TAPVR, obstructed TAPVR, particularly infradiaphragmatic. You cannot do anything preoperatively. This patient needs surgery as soon as possible. Transposition of great arteries with intact ventricular septum or restrictive atrial septum. They are very blue. They need balloon septostomy. So first thing is to call cardiologist and activate the team. Hypoplastic left heart syndrome with restrictive or intact atrial septum. TET spell, patient is low birth weight, tetralogy fellow, staying in the NICU for longer duration, develop TET spell. Again, these are the emergencies. Truncus arteriosus can be, challenging to manage if we wait for longer duration without any intervention. I'll skip this. Couple of things about inotropes, which inotropes should be used. We have phosphodiesterase inhibitors, catecholamines, and calcium sensitizer. If you look at the study for low cardiac output, milrinone is the #1 drug used for low cardiac output syndrome, followed by low dose epi, dopamine, and dobutamine. So the recommendation and the guidelines that for low cardiac output syndrome, milrinone should be used to minimize occurrence and severity. IV fluids, we briefly touched base in the previous discussion when we should give IV or when we should restrict IV fluid. Whenever there is a hemodynamic, significant lesion, yes, IV fluid should be restricted. Few slides about HLHS, because these are the group of the patient, they are very delicate, very fragile. They can die or they can have, severe morbidity on us while we waiting. So few high risk HLHS, restrictive or intake atrial septum, significant tricuspid regurgitation, poor ventricular systolic function, very low birth weight, significant extra cardiac anomaly. Last month, we had a case where I was very surprised. So in UAE, we know that we cannot refuse for treatment or we cannot stop prostating. However, at SKMC and Cornish, we have developed protocol where we talk to parents. When the treatment is futile, we stop prostating. We send them home. We go for comfort care. So if not doing in Dubai or any center, please touch base with us. We can give our protocol and then discuss about that. Move on with this one. Okay, subambient oxygen. Now there is a controversy whether we need to use subambient oxygen or not. So the meta-analysis showed that it does not improve systemic perfusion, but it reduces saturation, and it can be used along with milrinone to increase systemic circulation. So some center use, some center don't use. I personally, if saturation is high, I request to use subambient oxygen or inspire carbon dioxide. We'll skip that Fontan palliation. I want to show you briefly, but we'll skip because of time. Okay.
Thank you, Nishant, for that illuminating talk on a cardiologist perspective. I'll now welcome my co-chair, Dr. Mudid, a fellow neonatologist who works at Mediclinic Parkview in Dubai, to introduce the next speaker who probably doesn't need much introduction.
Thank you. So you heard from the cardiologist. Now the next talk will be from the neonatologist perspective, and I gather most of the audience, people in the audience are neonatologists, so it's going to be interesting. So Dr. Mohit, who you already seen on this stage before, is going to talk about practical approaches for neonatologists in evaluation and diagnosis of critical congenital heart disease. Dr. Mohit.
Good afternoon, everyone. So I will be needing answers from you only. I will just show my slides and you will be talking. So now the thing is, why I've put this slide? You want to treat the congenital heart disease or critical heart diseases with an old approach, something like that with the X, or with a new approach. That means you want to assess and treat clinically along with the echo, or you just want to just push out the clinicals and all depends on the echo. Clinical, who is in favor of clinical? Okay, I will ask this question again. Which are more common, acyanotic or cyanotic heart disease? Acyanotic, cyanotic. Great. So my audience is learned. This is the first message which I have got. Let's start with one scenario. So this is 35 weeks, birth weight 2.5 kg. At birth, baby is having tachypnea and cyanosis. At 4 hours, tachypnea and cyanosis increased. Intubated FIO to 100% on ventilator. SpO2 has increased from 65% to 85% on the ventilator, and the X-ray is being done. Why it's not functioning? This is the X-ray. Everybody is able to see the X-ray clearly? Yes? I need to hear yes or no. Yes. So there was a diffuse haziness. Surfactant was given, but no improvement till 6 hours post surfactant. What's next? Second dose of surfactant, echo, and review after. So everybody has answered echo. Okay. Now we will go through the cases and we will see that without the echo also, even though I am harming my own profession, without echo also we can make the diagnosis. I know the cardiac diseases, they are really hard. They are very confusing. This video will show you how confusing the cardiac diseases are. So don't go for first sight, okay? Always evaluate, evaluate, and evaluate. So whom we need to, how we detect CHDs? Go with the simpler thing first. All the stable NICUs, we have the protocol all over now to do the SpO2 monitoring, pre-ductal and post-ductal. And if they are sick, again, we have to. So the only tool, which is a very basic tool and everybody has got it, is SpO2 monitoring. And this is all you must have been doing. I think so. Should I speak about it, or everybody knows about the SpO2 monitoring? Your pre-ductal, post-ductal difference of 5, what is the, when we need to reassess, when we say it is passed, and this is regularly we are doing. So that filters, that is the first screening tool, and it does not need an echo probe. It only needs SpO2 probe. Everybody agrees to this? Okay. So these 3 slides are done. Now I'm coming to another case scenario. This is a 30 years old primary rupture membranes 10 hours prior to delivery. Male baby weighing 2.8 kgs, cried immediately by normal vaginal delivery. Discharged second day to home. In India, it is like that. We discharge within normal delivery within 24 or 48 hours. We need to discharge because we are 140 million. So checkup, the baby came to us on day 4 of life, sitting in the OPD, not feeding well, lethargic and less urine output. This is very common thing we see in our country, in our part. So on examination, this baby is mottled, poor pulses, cyanosis, and gasping. So if this kind of, once in life, pediatrician, at least once in lifetime will see such kind of babies crashing in the OPD. So what you will do? Pardon? A, B, C, yes. So you will start resuscitation. But many times it happens when we are worried, we don't do anything. We tell them, take it to the higher center. Take it to the higher center. But the idea is, don't forget the basics. Start, whether it is cardiac or non-cardiac, the baby will require ABC only. So ABC you have to perform. Okay, fine. So we'll start the resuscitation. This is the message from this. So what are your differentials? Sepsis, yes. Cardiac, metabolic, yes. So these are the most common differential: sepsis, cardiac, hypoglycemia, seizures, IVH, metabolic. We have to differentiate one out of these. And then we have to treat. See, very simple. Let's see. So diagnostic approach will be, again, we should not forget history taking is very important. I will not go into detail on the history. You are much more expert in this. Vitals, appropriate vitals are important, not only vitals. If I say SpO2, does only SpO2 makes any sense? It should be preductal and postductal, isn't it? So then proper examination, in the end, you will get the option for echocardiography. So vitals, heart rate, just heart rate is not important. You should know the normal values. And if it is less, high, what does it mean? Preductal, postductal saturation, CFT, where you should take, on the foot or in the sternum? Sternum, nearer to the heart, better. Body temperature, pulses, perfusion index is now another. Blood sugars and perfusion index should be taken into account. We should never forget that. Hyperoxia test, though after the invention and usage of echo, it is an obsolete test now. But if you waiting for an echo, this is one thing which will help you in differentiating. So interpretation is like that. You look for you have to give oxygenation, 100% oxygenation. Don't go for SpO2. It is not there. It is always PaO2. So always do the preductal gas. Don't go for SpO2 probe. And then interpretation is by more than 150, 100 to 150 and less than 100. If it is less than 100, it is most likely a cyanotic heart disease, or it can be very severe PPHN, but it is rare. Perfusion index, all must be using. It gives you the trend. So it gives you whether the baby is going into shock or not. This is what it will give. So you should always initiate the screening of the infant if there is a persistent respiratory distress, persistent cyanosis. Murmurs are not the indication for the assessment. It is very vague and non-specific. And then if the baby fails the SpO2 screening test. Okay. So we will talk about one scenario and we will see that how we can make the diagnosis without getting an echo done. 22 years, gravida 2 para 1, fetal distress, male baby weighing 3.1 kg, cried immediately. Regular checkup on day 5, discharge on day 3rd to home, LSCS active, having central cyanosis. So how to approach? Vitals. History you have now you know the history. The next thing is vitals. Heart rate 126 normal. SpO2 83% preductal, 84% postductal. What does it mean? Yes. Respiratory rate 38 normal. Temperature 36.5 degrees normal. CFT less than 3 seconds normal. Pulses in all the 4 limbs same, well felt, normal. When we talk about blood pressure, it has always be upper limb and lower limb. Okay. And when you compare upper limb and lower limb blood pressures, always consider the systolic blood pressures. Don't compare the mean blood pressures because the diastolic blood pressure component is there. So that defeats your purpose of preductal upper limb and lower limb blood pressures. So my systolic upper limb is 48 and lower limb is being same. Perfusion index 0.9 normal. RBS 108 normal. So what is wrong? What is bad vital in out of all this? Systolic is okay. For a term baby, 48, 50 is fine. Saturations. So the only positive things out of vital is my preductal and postductal saturations. Okay, fine. So what action we have taken? We started with oxygen. And now after starting off the oxygen, these are the vitals. SpO2 is still 88 to 89%. Means preductal, postductal were almost same. 83 to 84 was the range. And now after oxygen, starting oxygen, it is 88 to 89%. Rest everything is same. So my differential will be most likely cardiac. Now we have ruled out everything else. All those differential sepsis and everything has been ruled out. Now we have pinpointed that this is a cardiac disease. Now I have to find what type of cardiac disease is this. And it is cyanotic, isn't it? It is not acyanotic. So I will not be talking about acyanotic. It is a cyanotic heart disease, okay? Fine. So now, first thing is, always you have to differentiate a respiratory from the cardiac. And this table explains that. If your saturation's better with crying, it is. If your saturation is better after giving oxygen, becomes normal, or when the baby is crying. So whether it is respiratory or cardiac, respiratory. If you have a tachypnea and distress, it is respiratory or cardiac, respiratory. In X-ray chest, if you have oligemic field, cardiac size, you have to see. So look for those. If those are abnormal, then you have to make diagnosis accordingly. And then comes the ECG. We have forgotten the ECGs is something which is considered to be the basic. Your cardiac monitors are there. Never forget that. It is very important. Okay, now this is the thing. This is the X-ray. So how is the X-ray? Oligemic lung fields. How is the heart size? Normal. Okay, and this is the heart rate 120 and this is the tracing. How are the tracing? So for my clinical vital diagnosis, I have got this is cyanotic heart disease. X-ray chest is oligemic. Heart shape is normal. ECG seems to be normal. Okay. Echo is being called for, but he's busy. He's not coming. So I have to make the diagnosis with X-ray chest and ECG. So in X-ray, always look for whether the blood pulmonary circulation means it is white. The pulmonary plethora is increased. It is black lung or it is normal. These three things you have to notice. Pulmonary circulation and increase, decrease, or normal. Look for the cardiac cell out, large, small, or normal, or anything specific is there. We will talk about that. But in newborn period, you won't go get those shapes of boot shape heart, egg on end appearance. You won't get that. It is always for the later in the life. They take time to develop. And then ECG. Don't put your brains much. Just learn how to see whether it is a left-sided axis deviation or right-sided, LVH or RVH. That will make the difference. Okay, we will see how it makes the difference. So in our case, vitals and clinically, we made the diagnosis that this is a cyanotic congenital heart disease. Everybody agrees to this? Then we did an X-ray. In X-ray, normal or slightly on the lower side, there is a pulmonary blood flow and the cardiac sellout is normal. Okay. On ECG, it is normal. There was no RVH or LVH. So we have made the diagnosis of cyanotic heart disease. X-ray, the pulmonary circulation neither decreased or increased. Cardiac shadow size is normal. And in ECG, everything is, there is no LVH and RVH. Okay. So most likely diagnosis is DTGA. How it is, we will see. So DTGA echo, but I will come to that. So this is we call this as a double barrel view. You see all this thing together along side by side. This is an echo view of typical TGA. Okay, so the pulmonary artery which is dividing is arising from LV and aorta is arising from RV. So I will skip this. See, normal pulmonary blood flow, normal cell out, normal ECG. It is TGA. Because until if it is an intact septum TGA, then the babies will be very sick and they will present within few hours of the birth. Our baby was not sick, was coming on day 4th, but was cyanotic. That means the baby was not sick, but only cyanotic. Okay. And the X-ray was not affected. ECG was not affected. So that means it is a cyanotic heart disease in which the baby is not. So the mixing is taking place somewhere. And good mixing is taking place. That's why the baby is not sick. Okay. Now, if increased pulmonary blood flow, small size heart, and ECG showing RVH, it is TAPVC. Increased blood flow, cardiac cell out is small. ECG is showing right-sided predominance, it is TAPVC. Normal blood flow in the X-ray, normal cardiac cell out, ECG normal, baby cyanotic. Most common diagnosis is TGA. And see, this is a table which tells you if you have a decreased pulmonary blood flow, decreased oligemic lung fields, normal heart size cell out, look for the ECG and small and normal. If it is RVH, it is TOF. If it is LVH, it is tricuspid atresia. And if you have a large heart, RBB pattern and LVHB, these are the differential diagnosis. So there are many other differential, but they are very rare. The common ones are like this. So on X-ray, you have to look for increased blood flow, decreased blood flow. And then you have to look for the cardiac size. Next thing is you have to look for the ECG. You will come down to the diagnosis. It may not be accurate, but that is most likely to be the diagnosis. So the congenital heart diseases that present with increased pulmonary vascularity on X-ray chest, these are the most 4 common ones. DTGA, TAPVR, secondary PPH, and DTGA only if there is a large VSD. Decreased pulmonary vascularity, TOF, Epstein, pulmonary atresia, all right-sided obstructive lesions in which the blood is not going into the lung will present with oligemic, and those in which the blood is going, flow is high, they will present with pulmonary whiteness, over circulation. So these are the babies, these are the things which are present within first week. These are the diseases that present in the first week of life, second week, third week. So you should know when the diseases are going to present. So this is our baby, 38 week, 3.5 kg, tachypnea cyanosis. This is all you know. So now we have to differentiate whether it is respiratory and cardiac, and we differentiated it. It was cardiac. So now, see, all these things made us to differentiate that this is a cyanotic heart disease. It may be very severe PPHN, but that baby will not be very stable, very sick. So if the baby is stable, it means it is not severe PPHN. So most likely it is a cyanotic heart disease. This was the X-ray. Increased pulmonary blood flow, cardiac cell out is large. Okay. So when I see the clinical and the cardiac X-ray, increased pulmonary blood flow, cardiac sellout is large. My differentials are DTGA, TAPVC, and PPHN secondary to left to right. This we take out. We look for the ECG. When we did an ECG, RA-RV was dilated, so right axis deviation. So that rules out your TGA. See, after the clinical thing, we had a diagnosis of cyanotic heart disease. When we did an X-ray, increased pulmonary blood flow with large cardiac. So our differentials was DTGA with and TAPVC and PPHN. So PPHN we have ruled because that baby would have been very sick. So we left with two diagnoses. That was DTG and TBPC. We did an ECG, and ECG clearly showed me that there is a right axis deviation. So my most likely diagnosis is see, clinically cyanotic, severe PPH, and no duct dependent. It is not a duct dependent lesion. So these were my differentials. After the X-ray, these two were my differentials. And after the ECG, this one was differential. So I can narrow down the diagnosis just on the basis of vitals, clinical, X-ray, ECG. What I need to see in vitals? Pre and postductal saturations, upper limb, lower limb blood pressure, CFT, respiratory rate, heart rate, and whether to see whether the baby is sick or stable. I will do an X-ray. In X-ray, what I need to see? Increased pulmonary blood flow, decreased pulmonary blood flow, and the size of the heart. And next I will do an ECG. In ECG, what I need to see? RVH, LVH, or normal. I will have my diagnosis. So that's how you can narrow down the diagnosis. Okay. And just if it is a left-sided obstructive lesion, duct-dependent lesion, it is the babies will present with shock first. And if it is right-sided obstructive lesions, the babies will present with cyanosis first. In whichever way they present, anytime if you perceive that it is a duct-dependent lesion, without getting an echo done, you can start with your prostaglandins that has already been told. So this was our scenario. So when I asked you, you told me that you want to do an echo done. After doing all this exercise, I was sitting in my chair, cardiologist came, or I did an echo after all this exercise. Okay. And this was a obstructive TAPVC. So what you think? The person who knows how to do the TN echoes or functional echo is a Superman. But Superman has got his own limitations. So always keep this in mind that you can be Superman, you are a Superman, but you have the limitations and go with that. Thank you very much. And if you want to become a Superman, and this I would say you can subscribe to this channel, NF Congenital Echoes. We put small videos, how to make diagnosis, how to do the views, different views and all that. And if you're interested, you can buy the books and you can email us if you have any queries. Thank you.
Thank you, Dr. Mudit. Right. Can you have slides, please? So after that very enlightening and very light mood talk of Dr. Mohit, I'll try to talk on something complex, but I'll begin with a story. If I can have a slides, please. Yeah. So basically, this is a story. This is a house belonged to Mr. Patrick's. The name is just coincidental, and it's outside India because in India we can't imagine even having a 3-story house. So now the Mr. Patrick has a house with a guest bedroom at the bottom, the master bedroom in the middle, and children's bedroom at the top. And he had a tank and the motor which is supplying the slides are moving faster than I think. Okay. So basically, to supply the house, he had a water tank with a pump and a nice system to supply all the chambers or all the bedrooms. And he also, used to face a lot of problems in water, especially in the top floors. That's why he installed a pressure gauge, which was telling him what's the pressure like in the water. And he thought that will help him to, monitor the water supply. Now, imagine this analogy, this house as your body, with top chamber as brain, the middle as the heart and lung, and the bottom as the liver, kidneys, and the other organs. And similar sort of the water chamber is the preload, the heart is the pump, and the arteries are the water pipes. Now, what used to happen many times, there used to be a leak in the house, leak in the water pipe. And none of the bedrooms used to get any supply. And he used to not realize this because the pressure gauge used to tell that pressures are okay. Still, the water is not coming. So this is a typical scenario happening in a kind of a hypovolemic shock, because your fluid is less. The water tank is actually half empty. So the water is not reaching in all the bedrooms. So in neonatal perspective, abruptions, cord events, severe diarrhea, sepsis can really, present like that. So he realized probably he needs something else to tell exactly what is the flow or the water content reaching in each bedroom or each floor. And he did not have a device for that. And similar things happens with us, that we have the blood pressure monitor, but we don't know exactly what's happening in each part of the body with the flows, what is the level of water levels, and what is the flow at each organ which is happening. Now, sometime what happens, some guest visit to Patrick's house, lots of guests coming and staying in the bottom guest bedrooms, and they start using a lot of water. The kid starts complaining they are not getting enough water supply because there's a consumption and an abnormal redistribution which has happened during this situation. And that's exactly happens during the disease state, right? In sepsis, in septic shock, any cause of systemic inflammatory response syndrome, you get the abnormal redistribution, and the vital organs like your brain and heart and everything get compromised. And that's why we need to do something to improve the flow and optimize the top bedrooms as well. Now, again, for that, you don't need only the monitors, but you also again need the device which tell you what is the flow in the upper chamber. You will probably need devices which will tell what's exactly the perfusion or the fluid or the water reaching in the top chamber. And there comes devices such as near infrared spectroscopy, which will tell you actually what's the perfusion at the level of brain and the important vital organs. And then sometime you might have a pump failure. The pump is not working at all. Nobody gets water. And that's probably easy to diagnose that, it's a heart problem, cardiomyopathies, HIE, metabolic congenital heart blocks, where there is an intrinsic problem with the output only. So the blood pressures are low and there is no water going anywhere in the body. Now, echo can help that, but again, to continuously monitor, you need devices like Icon, which can help you about the continuous cardiac output monitor. And last but not least, sometimes you might have the pipe block, which is the obstructive shock, where the water going to any of the chambers or any of the bedrooms is not there. So that's like cardiac tamponade, pneumothorax, and coarctation of aorta. Now, why I'm sort of telling this analogy is because we already in the previous talk we covered a lot of clinical science we rely on, like cap refill, mottling, peripheral pulses, core temperature to peripheral temperature difference, and cyanosis. But all this science may not come immediately, and there are a lot of limitations for it. If you look at the evidence, the cap refill time doesn't actually predict the cardiac output. So it will tell you there is some problem, but it will not tell you exactly what is the water, the fluid, or the blood reaching the important vital organs. So it has very limited accuracy. Second thing, we rely a lot on the blood pressure. Now, blood pressure, we feel happy when the blood pressure is actually good, but it may not be the case that the organs might be unhappy, because you might have a normal blood pressure in scenario like hemorrhagic shock or a cardiogenic shock, because your cardiac output might be low, but body is going to compensate by increasing the systemic vascular resistance. So your normal blood pressure doesn't mean anything in this situation. Your perfusion is still problem, and you will get acidosis and high lactate. Similarly, in sepsis also, in initial stages, there is a vasodilatation and the systemic vascular resistance will drop, but body will compensate with a high cardiac output. And your blood pressure will be okay, and you will not notice that his baby is going into the decompensation. And that's why blood pressure doesn't tell you the whole story. And cardiac output and this SVR is also important. And then urine output, lactate, pH, all these are important, but they are very late signs. And by the time you have a problem with this, the baby is already decompensated. So clinical signs of compromised clinical perfusion and the hemodynamic decompensation, the accuracy is only 50 to 70%, and it's often late. You missed the bus already. So that's the point we are trying to make here. That's why we need early prediction, early intervention, and ongoing monitoring. And that's where the role of, devices such as cardiac output monitors and other devices which I'll be talking about becomes important. So detecting the cardiac output flow, the blood flow, is very important to understand what's going on pathophysiologically, to monitor the treatment and modify and modulate the interventions. So yeah, echo is important. Again, this is a hemodynamic conference. Echo is an important tool which can tell you about what the function is and the cardiac output is. But we know that there is a limitation. Not every one of us is trained. The availability in the night time is difficult. It's a one-point assessment. You can't keep on doing echoes whole night. So you don't have the information for the baby who's actually quite dynamically deteriorating. And that's why we need certain parameters which are beyond echocardiography. And we have certain devices which can help you to give this information and help us in clinical decision making. And this is called as integrated hemodynamic monitor. First device I talk quickly about is the HERO monitor, or the heart rate variability monitor, which actually can pick up the problems very early on before the baby is entering sepsis. I mean, it has its own limitation, but basically the algorithm is it basically captures the heart rate from the monitor, and then the algorithm calculates whether there is a loss of variation in the heart rate, and then it gives a score. So normally the score is less than 2, you're happy. The moment the score starts going 2, then you probably think there's some problem. Then you obviously look at clinical examination, might do a CBC, CRP, and might pick up the baby early or in the sepsis. So there are studies showing that it might reduce mortality by almost 20%. But we see there are a lot of false positive. We had these devices in Sidra. Almost 25 beds had a HERO monitor, and some of the chronic lung disease, some persistent tachycardias can give false pickup. So you can't completely rely on them. But yes, it will alert the nurses and the doctors to pick up these babies early and intervene early. Then comes the sorry, they're just jumping too fast. Then comes the cardiac output monitoring device. There are broadly 3 types of devices available: Nikon, Icon, and the NICAS. So basically, again, the principles, I'm not going to go into the detail, but they based on the principle either as bioimpedance or bioreactance. And how it works is there are ECG electrodes, similar to ECG electrodes, which are used. There are 2 electrodes which are put at the top on the head and then the neck, which gives electrical signals, goes across the chest. And what is the impedance or the resistance offered to these signals? The algorithm will pick up that resistance and it will compute certain values, which will help us to decide what exactly happening in the each phase of cardiac cycle. And the machine nicely gives all these parameters which we're looking at. So Mr. Patrick will know not only the pump is the problem, but where the flow is, where exactly the problem is, what is the sort of pressure in the pipe. All these details will be assessed with this device. So it will tell you the flow. So it will tell us the stroke volume. That is what's the volume in each beat. It will calculate the cardiac output. So the cardiac output in the whole minute. It will give you the systemic vascular resistance, which normally which is a calculated value based on the blood pressure, systolic and diastolic, but none of the device tell us what's the SVR like. So this machine will tell you what the SVR is. It will tell us contractility. So there is something called as ICON, which is the same as the name of the device, index of contractility. So it will give you the contractility trend over time. And also it will tell you the fluid status, something called as thoracic fluid content, or something called a stroke volume variation, which will be increased in cases of fluid depleted status. So basically, whatever we need, this device gives a lot of information about the preload, the contractility, and the afterload. And that's why it is a kind of a surrogate for even the invasive cardiac output monitor. It will give you a continuous trend of the cardiac output It will tell you, you don't have to do the echo, continuous echo or repeated echo, because it will tell you what the contractility is. It will tell you about these CVP surrogates, like what is your fluid status, what is your stroke volume variation, and also if the viewer fluid overloaded or underhydrated. So this is how once you connect this device, this is how if you connect the device, it will just give you the trend of all the parameters, where the two dotted lines are the sort of they are based on the normogram. When you enter the weight and the length based on the body surface area, it automatically plots those normogram, two normal lines. Left of the line will be the low and right of the line will be high. Okay, so it will tell you stroke volume, cardiac output, thoracic fluid content, contractility, and stroke volume, and the SVR, systemic vascular resistance. You can continuously get all the parameters you need. Now, I'll tell you how it helps us to diagnose various disease state. So suppose you're hypovolemic shock. So what is the problem is the fluid is less, right? What is the main problem there? The less fluid, the tank is empty. So your cardiac output will be low. So these babies will have low stroke volume and low cardiac output, and the SVV is high. SVV high, more variation happens when you are fluid depleted. But your cart is functioning okay. There is no problem in the pump. So your icon, the index of contractility is normal. So it's very easy. This is a fluid depleted status, hypovolemic shock. In the primary problem, especially in the early septic shock, there is a drop in the SVR because the baby is fluid vasodilated. So the first thing it drops is the SVR. So SVR is low. And I already said the body's first response is compensating by increasing the cardiac output. So the cardiac output is high. But heart is functioning okay. So you don't need to give an inotrope here. You just need to give a vasoconstrictor. So that's how it tells you. Then if you have a cardiogenic shock, the primary problem is the contractility. The pump is not working. So your icon will be low here. Okay. And because of the contractility is low, the output, the fluid or the water content is low. That's why the stroke volume or the cardiac index or the cardiac output will be low here. So you just have to support the heart, give dobutamine or epinephrine like that, just to improve the cardiac output. And that's how the hemodynamic optimization chart we follow, that, 5 more minutes, that if your volume is less, as per the parameters, just give fluid. If your cardiac output is low, just give inotrope like dobutamine or epinephrine or sometimes milrinone. If your blood pressure is a problem, but contractility is good, just give vasoconstrictor, dopamine, norepinephrine, or even vasopressin for that matter. Sorry. Yeah. But issues not available in most of the centers. It's a little bit inaccurate sometimes if the baby's edematous, massive chest wall edema. We had lots of trouble detecting, but the trends are important. It has its limitation, but the trend is important. With PDA, sometimes it can have issues with high frequency when you're on EEG monitoring, when you're on higher, it can interfere. Your cooling, it can interfere with it. Also on ECMO, it doesn't work. But again, trend will be important. So it's a good device to have. The last thing I will talk about is cerebral oxygenation or the near infrared spectroscopy. It works on the principle that it uses the near infrared light, which is in this frequency. And the idea that various molecules in the subcut, like hemoglobin, etc., they absorb certain spectrum of light. So basically, the sensor has got a one is a light emitting sensor and one is light emitting detecting diode. So light goes inside the body. The subcut tissue will absorb the certain wavelength and the sensor will receive and it will give you a number. Now, this is how it looks. Basically, the saturation in the level of watershed area. So cerebral saturation is a surrogate of the cerebral saturation, and you don't have to put it in the midline. Ideally, you need to monitor for right and left. So two sort of probes you need, and it will give you an accurate sort of differential saturation also if there is a problem on one side or sort of a bleed on the other side, something like that. And this is how the principle, again, your saturation in the body or the heart is 90% and depends on how much is the organ extracting, where your brain extracts maximum. So brain extracts around 30-35% oxygen, and depends also on what is the level of perfusion in the brain. So if there is a ischemia or a hypoxia and how much is the extraction, depending on that, the number will change. So if your perfusion is less and extraction is more, this number will drop further. So that's how the numbers are displayed, and you will have like 60 to 70 in brain, and in the kidneys or this thing, it might be 5 to 10% higher. And these are the number we talk about. So basically in the middle, you see the normally is the normal saturation we know is 90 to 95. Then how much is the regional saturation, which that machine is telling you? That is called as RCO2, the regional cerebral oxygen saturation. And that comes by how much is the brain extracting. So suppose it's extracting 30 to 45%, you minus 90 of from that, you get a regional saturation. And if you just get product of that, that's your fractional tissue oxygen extraction. This is good for numbers for the research, but that's a concept we want to talk about. And you can have sites like cerebral monitoring, or where 60 to 80 is the range. You can have mesenteric. So you can look at the splanchnic circulation, which is monitoring. And that's varies again. It is about 5 to 10% higher than the cerebral. And you can have renal also, which is again 10 to 20% higher than the cerebral. But again, pickup is sometimes poor, but again, the trend is important. If you get a right spot, I mean, people are also doing ultrasound guided needs monitoring, which again, if you gives you a trend, that is again useful. And how it helps you with the decision making. Suppose your cerebral saturation is less, the top chamber, the kids are not getting the enough fluid, you have to correct it. So you have to do everything right. You have to improve on oxygenation, you have to improve on, that's probably alarm for me also. And cardiovascular status, you have to optimize the cardiovascular status, respiratory status, and then probably, it also includes sort of giving the transfusion, and then the saturation will increase. One other contrary side for this is, if you have a high cerebral saturation, I just need 2 minutes. I'm end of the day. It's okay. Nobody is ready to leave for namaz. I thought people will be. I can have 2-3 more minutes. Summarizing slide. Okay. So if you have a high cerebral saturations, if more than 85%, that also is concerning, because you might be having a brain which is not extracting. And we typically see in severe HI, where your saturations are 85, 90, 95, and that's really a matter of concern, that brain is not extracting at all. And that's a sign, could be a sign of a brain death. Again, this is, we were privileged in Sidra to have this kind of monitoring devices for almost 20 beds. And all these devices actually used to go on a computer where we could integrate. And Dr. Soni was actually leading one project, which was based on artificial intelligence, similar to a project called as Atiometry in Boston, where, you can have some prediction modeling where all early trends or the change of trends probably can be predicted. And that's something probably is a future. If you have more information, before the clinical science, we can actually predict the early deterioration and take the management. Now, just one case, if I can show. So how it practically approach, and this is a real case, Dr. Soni, you will remember, a 33-week post-op became hypotensive, 45 by 15, very low diastolic. And you can see there's a sort of stroke volume variation also happening, very low diastolic. And this baby was actually quite fluid edematous. And this baby also had a pulmonary stenosis, but basically underfilled heart. And how these devices help you, that this is actually, the icon contractility was good in this baby. And the issue was mainly the SVR was dropping, the systemic vascular resistance was dropping, and the cardiac output was dropping. So we had a trend where cardiac output dropped, and the SVV was going higher. So basically fluid depleted status with a low SVR. And then we put the, and the baby was edematous, but it was intravascularly fluid depleted. And we put the NIRS monitor on this baby. You can see these were the value. Sorry. It was just 17. It was just 17, so low. And sorry, this is playing up. And basically, we have to optimize this baby with we started norepinephrine, we gave fluid boluses, we gave blood transfusion. I mean, same thing what we all do, but because we were able to monitor the changes, the need started improving to 22, then went up to 45. And this baby was really sick. And we could actually monitor what's exactly going on. And I will skip this slide because this is what we correct for any baby for improving oxygen delivery and oxygen consumption. And I'll skip this. So transfusing, optimizing respiration, giving fluid dialysis, norepinephrine. Oh, sorry. This is again, Dr. Yasir, very good friend of mine. I think he talks about this integrated hemodynamic reporting, and this has been already published. So if we have all these devices, apart from echo, you can actually write down all these parameters which you have got, like in similar to the case we saw, and then actually you can take a more informed decision in the management, and that probably helps you to manage these babies better. So take home messages: clinical science have limitations, and focus on oxygen delivery, the flow, the tissue perfusion rather than just blood pressure number. And I think electrical cardiometry or the icon devices just gives you continuous non-invasive information of the hemodynamic status. It has its limitation, but trends are helpful. Same for the needs, has its limitations, but it will tell you what's happening with the tissue level oxygenation, especially the brain, which is your important organ. And I think integrating all this information can make you a better clinician. Thank you.
It's okay. Thanks, Kiran. Looks like it was a very interesting talk because the hall is still full. Thanks, everyone, for staying back. I know everyone's probably now impatient, hypoglycemic with full bladders, wanting to go for lunch. But we'll take just 2 questions. If anybody has anything pressing after that, we can discuss with the speakers at lunchtime. Dr. Saurabh, just a quick one, please.
The 3 things Dr. Mohit said very interesting. X-ray, cesarean, ECG. You know why it is called cesarean section? It is wrongly written in the dictionary. Caesar was born through this section. No. Before Julius Caesar, they used to cut and take the baby, dead or alive. But they used to bury the mother. After Julius Caesar, a law came, Law de Caesar. According to this law, when a mother died, they had to take out the baby, this section called cesarean section. X-ray, why it is called X-ray? In 1898, Roentgen discovered this. He didn't know what is that. He put X. He wanted to take X-ray. Everybody was afraid. His wife came. First X-ray was taken on his wife's left hand. So that is Roentgenogram. Now, who can tell me why it is called PQRST? Dr. Mohit said so many things about ECG. Why it is called PQRST? See, Roentgen, Eindhoven in 1923 discovered, he put ABCD. When he corrected, he couldn't put ABCD. He went to Descartes chart, P a starting point, PQRST. He put PQRST. It comes from Descartes. Dr. Mohit said machines. First ECG machine was so big and patient was so sick, 1,500-meter wire was taken from hospital to the ECG center. The first ECG was recorded in that way. Please remember. Thank you.
Thanks, Dr. Saurabh, with the wonderful history snippets. I think we've run out of time. Probably we can catch up with the speakers over lunch. That'll be the best to do. Unless anybody has a really pressing question. Yeah, one comment. Okay, last one.
Please empty the bladders before going for lunch.
Excellent talk by both the speakers. Mohit, as usual, I think whatever machines comes in, your clinical acumen has to be very, very important in the bedside treatment. Thanks very much for bringing all the equipments and demonstrating what can be achieved in future. We are probably still not there with the evidence base. I think somebody need to take it forward and do it evidence, and maybe in the coming decade, maybe with the AI and more better platforms, we will get this. These are very good concepts, but practical application is still, we are a bit far away from that.
Absolutely. With that, we'll conclude the morning session. I'll go over to our conference chair.
Thank you. Thank you, everyone. And thank you for the fantastic talks this morning and also some interesting perspectives. We have lunch now after prayers. Lunch will be, if you go out this way and turn to the right at the restaurant. Remind me the name of the restaurant. Well, just follow people and you'll find the place. Also, if you've parked with valet, then please get your tickets stamped by one of the PEMS team folks because it needs to be validated. Please come back by 2:15 because we've got some very, very interesting talks in the afternoon and some of them are online on a different time zone. So we want to stick to time if possible. Thank you very much.
Yeah.
Welcome back. I hope our brain cells got sugar enough to be awake and not too much to sleep back. So welcome back. And I would like to introduce our the chairperson, a good friend, Dr. Sharif. He's the consultant neonatologist and consultant pediatrician heading the Department of Neonatology in Zuleika Hospital. So he is going to be chairing the next session.
Good afternoon. Thank you, Dr. Monica, and for her kind invitation. By the way, Dr. Monica, she is my old friend, maybe more than 20 years with Dr. Monica. And she was also the former HOD also of the neonatology in Zuleika Hospital. So I take her place, but I don't want to take her place anywhere, only this time. Okay. So my pleasure and my honor to be the moderator on this elegant conference. And I hope a very successful conference. And it is the first, inshallah, to be the best, and it will be continue. So my pleasure to introduce the first speaker of this session. The first speaker is Professor Daniel De Luca, and he's a professor in the division, the chief of the neonatology in France, and the immediate past president of ISPNIC, and he is in the direct one of European largest in ICU, and has conducted groundbreaking research on SARS-CoV-2 in units. Professor De Luca has published over 300 scientific papers and was named Kings of Republic of Italy in the 2021 for his contribution to neonatal medicine. Dr. De Luca, he will speak to us today about the cardiopulmonary interaction, effect of different modes of ventilation on neonatology hemodynamics. So welcome, Professor De Luca. Online. Okay.
Hello everyone, thank you very much for being here, and particularly thank you for the kind invitation, which I am so very much sorry to have not been able to answer because of some important personal issues, as you probably know. So I'm at least happy to give you the talk this way, although I know it's not the same thing, and I do promise you to be physically present next year if you want, in such a beautiful city and such a very important occasion that you guys should be commended for having organized. So the interactions between mechanical ventilation and hemodynamics are indeed very complex and cannot be covered in just 20 minutes lecture, but I'll try my best to give you some clue about how to manage the most important situations. First of all, we're talking about the most critically ill neonates, because as you can imagine, those that are just on the CPAP with a simple RDS, they do not need very much, and that's not an issue over there. But when it comes to babies like those in the pictures, with a lot of machines all around, hemodynamic derangement at the basis, on top of the respiratory failure, and maybe also with renal failure and extracorporeal circulation and so on, the situation becomes critical. And the situation becomes critical, our job is to monitor even more in order to understand what is the physiology and to understand what is the interaction between mechanical ventilation and hemodynamics, and to intervene. Too often in neonatology we did not measure, we did not monitor it, and so we were blinded about what was happening, and this is why mechanical ventilation and hemodynamics do not go hand in hand, they do not go alone. So here you see the pyramid of vital monitoring, where you can see at the basis that are most of the babies that do not need any particular intervention or monitoring, and on the top, conversely, you have few babies very critical for whom you want to measure many things, and you see here a number of possible monitoring tools that we use. This is our protocol in Paris. But it's not the only one, because as you can see here, even the European Society for Pediatric and Neonatal Intensive Care Guidelines, published in 2017, but this is open access, you can download it. You see that going from the left towards the right of the presentation, the color is fading, and there are more monitoring to be considered as soon as the baby becomes more critical. But why actually a critical baby, a more critical baby, can have a bad interaction between hemodynamics and mechanical ventilation? For several reasons, but the first one is that you are not in a normal situation like number one here, but instead you may have alveoli with a high shunt fraction, meaning that there is closed alveoli, good perfusion, less aeration, or you may have alveoli in a sort of a dead space, or anyway a part of the lung in a sort of a dead space situation, meaning no perfusion at all, and a good ventilation. So those are the two main situations and some diseases that you may face here for each of them, but also there are some neonatal disorders with complicated and mixed situation like BPD or ARDS, particularly those triggered by aspiration or the mix of BPD and ARDS. And in those cases, we measure a lot of things, as you may see from our monitoring screen. We measure not only the classical parameters, but also, for example, entitled CO, sometimes, as you may see here, invasive arterial pressure, central venous pressure, Q saturations, EEG, and so on. It's very important to recall that it's unavoidable to use ultrasound because respiratory failures in neonates are not created equals. There are less severe, more severe, but even amongst them, there are the more heterogeneous and the less heterogeneous. Here you can clearly see from our papers just published in Anesthesiology 2024 that BPD and TTN are the most heterogeneous, the more difficult to ventilate, although with the different heterogeneous components, and ARDS is somewhere in the middle. This is something to be taken into account because we are ventilating patients as a whole and not only that particular area of the lung that unfortunately is closed. So coming back to the monitoring, there are many ways to monitor hemodynamics during neonatal ventilation. I cannot suggest you one. I can show you what we do. For example, one thing that you can do is just using electrical cardiometry. It's a beautiful tool, only requiring 4 electrodes. It's totally non-invasive and enough accurate, even at 500 grams. You see here in our historical paper, the normal values of cardiac output continuously measured by electrical cardiometry, as you may see here for every single gestational age and birth weight classes. But also now the electrical cardiometry is able to give you the systemic vascular resistances, which is something very much useful to titrate norepinephrine, for example. Otherwise, we will be blinded and we could blame mechanical ventilation and say, hey, it doesn't work. Not true, because we did not monitor hemodynamics, did not increase norepinephrine, we did not do enough volume to fill the heart, and so on. It's not the only way. There are others. Techniques to monitor hemodynamics. For example, you can clearly see here in that particular baby with multi-organ failure and whole body epithelial asphyxia, you can clearly see the transesophageal Doppler signal giving you exactly all the other parameters of the account tools and the appendix and the extravascular lung water that can be helpful to titrate the inotropic support and mechanical as well. The ESPNIC has issued a few years ago clear guidelines to use also point of care ultrasound. That's unavoidable as well. The paper is here, published in Critical Care, so it's open access. You can download it for free. We're not the only society suggesting that. Same applies on the other side of the ocean. You see the American guidelines, but we advocate for Pocus because it's a simple technique and it's giving you the most important thing at bedside of these babies, like all the aeration and all the possible use of lung ultrasound together with the possible use of point of care echocardiography. And in our paper you can only see the normal ranges, the normal values of the main echocardiography measurements that you want to do. Compared to transesophageal Doppler or electrical cardiometry, those are, let's say, punctual measurements, but are very, very much useful also because the ultrasound is giving you other parameters that are not available with the other continuously techniques. So all in all, as Professor Gratinoni said, I would say the more you measure, the more personalized is your care, and that is something you should never forget. What about the intervention? Once we have monitored, we have to decide what we're going to do. So again, the ESPNIC guidelines will tell you from the left to the right side that the assistance, the ventilator assistance should be increased as more complex techniques will come in but also more pressure is needed. Particularly, the high frequency ventilation can be needed for restrictive disorders like ARDS, but also for mixed ones like ARDS plus BPD. If you use high frequency ventilation, you should never fear to increase the pressure. This is exactly the way how high frequency works. For example, you see here, those are animal studies that I did a few years ago. You can clearly see in a cinematic way how the lung hysteresis works, and you can only achieve in that particular model a good lung aeration, a good lung opening with a minimum pressure of 20. There's no fear for 20. Okay, it's not a magical number. It's something that has been described for the first time by Anton van Kamp from Amsterdam, and you can see that just targeting an FiO2 lower or equal to 25%, at that time there was no lung ultrasound, no other, let's say, techniques to target minimum pressure, they achieved a good aeration, and they discovered and published that many years ago that the pressure needed to open up the lung of an extremely preterm baby with RDS, as you can see here, was around 20 before surfactant, 16 after surfactant. That means that before giving surfactant, you need more pressure. And there is no virginity phobia, as we said in Latin. It's absolutely possible to go beyond 20 for a few minutes. And if you have to stay there to achieve a good oxygenation, then you also have to take into account the hemodynamics and support the heart, the volume, and use the M in the inotropes, as I just mentioned, and I will tell you more details. If invasive ventilation is needed, do not fear HFOV and do not use it too late or shift between HFOV and conventional. For example, meta-analysis like this one have shown that the early the HFOV, the lower the mortality and the BPD, but this has been also replicated somehow in the PQ setting in bigger children, because when the HFOV has been used early, there will be less PQ stay, less length PQ stay, duration of ventilation, and mortality. And the other thing is that you will never switch from HFOV once you started to conventional. It makes no sense. It can injure the lung even more. There are several animal studies showing that. I just want you to show some reanalysis we did of a Brazilian trial some years ago. You see, those are the data coming from our reanalysis. The black line here with black squares shows that if you do not switch back to conventional once you started high frequency, the oxygenation is going up and up and up, is going better. Conversely, the bottom figure is showing you that if you do that, then there is a crossing, there are crossing lines and oxygenation is going down. So as we said in Latin, once you have chosen one strategy, you should never go back again. But then how to use it? To correctly use high frequency, you need to realize that it's just a pump pushing air and oxygen into the patient's lung, but that pump is not only connected to the lungs, it's also connected to another pump that is pushing the blood towards the alveoli, and this is as much as needed to oxygenate the body. So you cannot just work about one pump and forget the other one, because when you increase the pressure, when you increase the power on the ventilator, there may be consequences on the heart, and you need to support the heart as well, as you may see here. So in this case, remember to push the heart, and that means adequate monitoring with any of the tools that I showed you, adequate volume filling, and adequate use of inotropes like norepinephrine if there is vasoplegia, and dobutamine or adrenaline to increase heart rate and contractility if needed. I would say summarize this in these 8 suggestions you can see here, and we can obviously discuss about that anytime. You can drop me a line and I will be more than happy to assist you, discuss your clinical cases, or come visiting you at the bedside and discuss even more. You know, in Paris we are in love with ultrasound, so everything I said in my unit is not done by FiO2, but is done by ultrasound. For example, facing a critical case like that, first of all, here you see we identify the closest part of the lung, then we check hemodynamics, meaning contractility and volume filling. Otherwise we act on that, because otherwise increasing pressure cannot work, I can tell you. But once we did that, we do the alveolar recruitment by looking at the lung ultrasound, and we choose the optimal pressure, the same way Anton van Kamp did, but visualizing it, and it's much more useful and easy. The only thing you have to know is that the pressure, the mean wave pressure to open up the lung in a visual way with the lung ultrasound is always 2-3 centimeters of water higher than the mean wave pressure just needed to lower the FiO2 below 25%. And a final hint, if all this is not enough, remember you can pronate the babies. Prone positioning has been used and inefficacious in adult ARDS for decades, and we demonstrated with this study in Lancet Clinical Medicine a few months ago that the same applies for neonates. It doesn't matter if RDS, ARDS, or BPD. You can clearly see that CO2 is improving, oxygenation is improving, lung aeration is improving, and also that you get that after 6 hours of pronation, and when you shift the patient, you can lose the advantage that you just achieved. By the way, while you redistributing the lung aeration and you improve all these parameters, there is absolutely no clinically meaningful detrimental effect on hemodynamics, which is very much important for all neonates. Finally, again, thank you, and I'm sorry not to be present physically there, but I also would like to take the occasion to invite you at our conference, the Vault or Launch, the only international congress exclusively dedicated to NICU monitoring, a lot of point-of-care ultrasound, but not only point-of-care ultrasound, many other techniques with a lot of key opinion leaders coming from Canada, US, and Europe. They will be in Rome between 18 and 20 of November. You're more than welcome to come. Please come. Write me for anything and for any suggestion. Thank you very much again, and hope to see you soon.
Thank you very much, Professor Daniel. We will keep the question at the end of the session. So we will move to the next speaker. My pleasure to introduce the next speaker. Next speaker is Professor Valerie Shok. She is a professor of pediatric standards and leaders in neonatal neuroimaging. She developed Stanford's NIRS clinical programs and has driven research in the neonatal hemodynamics. Dr. Shok is a care member of neuro and ICU teams and has contributed significantly to advanced neonatal brain monitoring through her work with NIH and NIRS. So Professor Valerie, she will speak today about the cerebral autoregulation and hemodynamic change. So let's welcome you. Thank you.
Okay. First of all, thank you so much to the organizers of this conference, Dr. Rupali and others, and the sponsors. It's really my pleasure to be here and the invitation to speak today. So delightful to be here. I'm hoping that I can keep you all awake after lunch and also keep myself awake, being a little bit jet lagged coming from California. But it's really, again, my pleasure to speak about cerebral autoregulation and hemodynamic changes. I have no conflicts of interest or disclosures. Okay, so my focus has always been on brain injury and the relation of hemodynamics to brain injury. And as we know, hypotension and hypertension can cause injury to the brain. So for example, if you have poor cerebral perfusion, this can lead to ischemia and periventricular leukomalacia or white matter injury. Whereas if you have hyperperfusion to the brain, this can lead to intraventricular hemorrhage. And so if we think about the various causes of altered cerebral blood flow, we know that there are many contributions, and we'll focus primarily on impaired cerebral autoregulation. Prematurity, of course, is a huge risk factor for impaired autoregulation, but also hypoxic injury, growth restriction, and sepsis can contribute to impairment of autoregulation. Other factors that lead to altered cerebral blood flow include blood pressure instability and how we as clinicians address blood pressure instability. So are we causing more harm by doing volume expansion or initiating a pressor support? And we heard a little bit about the effects of a hemodynamically significant PDA, as changes in ductal shunting patterns, of course, can also alter cerebral blood flow. And And then impaired venous return or elevated central venous pressure, we can contribute to altered cerebral blood flow at the bedside by doing things like intubating a baby, placing umbilical lines, and administering surfactant. And in addition, there are ongoing changes in lung compliance related to changes in intrathoracic pressure and RDS itself and mechanical ventilation. So we're contributing to impaired venous return that can alter cerebral blood flow. And then finally, we cannot underestimate the effects of hypoxia, hypocarbia, and hypercarbia in the brain and how that can change vasoconstrict or vasodilate vessels. So all of these factors together can alter cerebral blood flow and lead to further hemodynamic instability. I'm going to try to walk around like some of our previous speakers. As we think about this, we need to think about different neuromonitoring tools that are available to assess hemodynamic changes to the brain. And tomorrow, some of us will be participating in the workshop looking at transcranial ultrasound. And through that technique, we can measure cerebral blood flow velocity and resistive indices. But again, this is a moment in time where we're interrogating the brain and we're limited by the angle of inclination where you're holding your probe. There are potentially probe fixation issues. So again, it's not something that you can continuously hold at the bedside very easily. And of course, there are some inconsistent correlates with adverse outcomes if we just look at ultrasound of the brain itself. What other kind of neuromonitoring do we have available? Well, of course, AEG and EEG, where we can look at cerebral electrical activity. And we know that cerebral hypoperfusion leads to decreased cerebral electrical activity because oxygen is required in order to maintain those transmembrane ion gradients. But in the preterm infant especially, sometimes it's difficult to interpret because the brain electrical activity is still immature and those patterns may be immature still. So I'm mainly going to focus on NIRS or near infrared spectroscopy that we heard a lot about earlier today. It is a trend monitor that can continuously be used at the bedside and allows the display of cerebral oxygenation. That's also abbreviated RSO2 or regional saturation. So how many here in their unit use NIRS either clinically or for research purposes? Show of hands. Okay, well, that's actually more than I expected. I know it's still kind of a growing technology, and I'm going to make believers out of all of you today, hopefully. So this is, again, a little bit of a review. But NIRS, or near-infrared spectroscopy, again, is a continuous real-time non-invasive bedside monitor of regional tissue oxygenation. And you have a little sensor on the forehead that measures the underlying oxygenation of the brain. You could look at a somatic site like the mesentery or the kidney to look at the underlying tissue perfusion there. Cerebral saturations have been validated with jugular venous sats and has been approved for use in babies, even those smallest babies, less than 2.5 kilos. In our unit at Stanford, we routinely monitor our 22, 23 weekers with NIRS for the first 7 days of life. Okay, again, similar in principle to a pulse oximeter. You have a light source that emits near infrared light. It passes through the underlying skin, bone, soft tissue. There is differentially absorbed by oxygenated and deoxygenated hemoglobin. And that near infrared light is then detected by detectors on that same sensor. A tissue oxygen saturation is then calculated, which reflects a ratio of the underlying arterial and venous blood. It's heavily venous weighted, so 70% venous, approximately 75%, 25% arterial. And it also demonstrates the balance between oxygen delivery and consumption, which I think is so physiologic and really fun to interpret. Okay, so here's a picture of NIRS sensors on one of our babies. We always do two-site NIRS monitoring because we know that circulatory impairment will tend to reduce the somatic saturation first. So that's going to be the earliest indication of hemodynamic compromise. You may not see it in the brain first, but you will see it possibly in your kidneys or your or in the splenic circulation. So here's a cerebral sensor ideally we would place it on the right or left side of the forehead for a baby. Sometimes in our preemies, we just don't have the real estate, so we take what we can get. And then here's the renal sensor on the posterior flank. Placement is below the costal margin and above the iliac crest. Okay, so as we heard, there are population-based norms for what's considered a normal cerebral saturation. And that can be shown there in the green zone, yes, which is between 55 to 85%. Now, I'll point out that the range in term babies tends to be higher than in preterm babies. Values also will differ by the type of sensor and the device type. And really, it's the trend over time that's most important for an individual baby, more so than the absolute value. And that being said, we do know that when you hit the zone of 50% or below, then your brain is not being adequately perfused. And we know there are some studies, contributed to one of them, where the percent of time when your cerebral saturation was less than 50% was associated with mortality and severe IVH, as can be shown in this graph. Okay, so this is why I love NIRS. It's very, very physiologic. You have to think about what affects your cerebral oxygenation. So number one, is the baby, oops, well, hang on. First of all, we call a provider to the bedside if the cerebral sat is less than 50%, just for those reasons I previously told you. So someone gets called and then they have to assess what's going on with the baby. Number one, is the baby overall systemically hypoxic? So maybe this is a kid whose systemic sats are low. You have to turn up the FiO2 on the ventilator. What else contributes to cerebral oxygenation? Cardiac output and blood pressure may be a surrogate for that. So maybe this is the baby that you might actually want to treat low blood pressure for if it's affecting their brain. Third, oxygen carrying capacity. So of course, if a baby is anemic, this is a child that may have low cerebral sats for that reason. And number four, people oftentimes forget the significant effect of hypocarbia on the brain, causing cerebral vasoconstriction. So perhaps this is a baby that's overventilated and we really need to wean the ventilator. So I tell people to think of these four main physiologic variables that affect cerebral oxygenation. And it's kind of fun to quiz the trainees at the bedside about what to do. A few other things to keep in mind: cerebral metabolic rate may have an effect, but I don't often see that. And there may also be underlying conditions such as severe IVH, a significant PDA, or congenital heart disease that can affect cerebral sats. Okay, so let's show you an example here. This is 25 me, 3 days old, and this is the NIRS monitor at the bedside. And what I'll point out, the cerebral sat here is reading 47%. It's in blue, but you'll see a downward trend over time. Renal sats in white. It's also downward trending. So you get called to the bedside and, what are the things that you want to know? Well, those four physiologic variables that I spoke about earlier would be important. So we talked about overall systemic sats. This baby is looking good, 90 to 95%. The mean arterial pressure also is appropriate. CO2 is okay. Hematocrit's okay. The baby's not overly agitated or hyperthermic. Could this kid have a PDA? Well, probably. It's only 3 days old. But what's more interesting to me is that the cerebral saturation is very low, and it's even lower than your renal sats. So something else is going on here that's affecting oxygenation to the brain. So what I didn't tell you is that this mom had choreo, and the baby is being treated for presumed sepsis. And we know that infection and inflammation is a significant risk factor for impaired autoregulation of the brain. So I'm telling you this because with the low cerebral sats, this influenced the team to get a cranial ultrasound. And unfortunately, a bilateral grade 3 bleed was detected. And while this was unfortunate for the baby, I'm making this point that it was the low cerebral NIRS values that was the first thing that tipped the team off to wanting to even evaluate this baby for IVH. So, of course, it's nice that we have this monitoring to be able to kind of prompt us to think about IVH, but wouldn't it be great if we're able to detect this problem before it even happened? This is something where it kind of brings us to autoregulation. But so again, low cerebral sats are found in babies with IVH, possibly because there's excess venous blood in the area of hemorrhage. There could also be a low cerebral blood flow state around the time of a bleed. But again, it's unclear if there's a period of hyperperfusion and impaired autoregulation just prior to the bleed happening. So again, this brings us to impaired cerebral autoregulation. Here's our typical graph of the cerebral autoregulation curve. As you can see in adults, there's a kind of a wide plateau where changes in the mean blood pressure really don't affect the cerebral blood flow that much. But in children, older children, it's a more narrow autoregulatory plateau. In neonates, even narrower, and in the premature newborn, almost non-existent. So really, changes in your mean blood pressure are going to be affecting your cerebral blood flow much more significantly because of impaired autoregulation. So how do we measure autoregulation? Well, aside from putting a catheter in the brain, a really nice way to do that is to look at tears or cerebral oxygenation as a surrogate for cerebral blood flow. And you can see there on the left, this is a baby with intact autoregulation. So the mean arterial pressure in red, even though that's fluctuating, the cerebral oxygenation is relatively constant. In contrast, this is a baby, I think this is a baby with a cardiac abnormality, but you can see that the fluctuations in mean arterial pressure here are transmitted directly to the brain by the correlation between the two tracings. Okay, so it's interesting because when we look at patterns of cerebral blood flow and cardiac output in babies that develop IVH compared to those that did not, what we found was that the left ventricular output, shown in the top two panels, and the RV and the right ventricular output, they increase in the first 48 hours. But there was no significant difference between those that developed IVH and those that did not. So that's a solid line versus the dashed line. But when you look at the cerebral oxygenation, so this lower panel here, you can see the main difference. Those that developed IVH by the dashed line had a much lower cerebral oxygenation compared to those that didn't. And other groups have also found the same thing. But what we don't know is the exact timing of IVH when it occurred in these babies. And this is what we're trying to look for. Is there a signal? Is there a time when there's increased cerebral blood flow right before the bleed happens? And in fact, a group did find this. This is a group out of the Netherlands, Frank van Del's group. And again, it's interesting that in babies that developed severe IVH, the cerebral oxygenation was elevated compared to those that did not, with minimal difference post-IVH. So to review the pressure passive state, again, if there is a correlation between your mean arterial pressure and your cerebral saturation as shown here, there is a correlation coefficient of 1. So this means that all of the mean arterial pressure that's transmitted directly to the brain, there's 100% correlation. This is a baby that's completely pressure passive and with completely impaired autoregulation, compared to, of course, the other circumstance where there is no correlation, and that's a baby whose autoregulation is intact. So the same group, when they looked at a pressure passive state, again found that this was more frequent before mild or moderate IVH and after severe IVH compared to those without IVH. And what's interesting also is that there's differences in the cardiac cycle. So in fact, in systole, there's the most robust autoregulation, whereas the mean and actually in diastole, there's more impaired autoregulation. Also, what's interesting is that you can see with increasing gestation, so across gestational age, there's improvement in autoregulation, especially in the systolic time period. Okay, so just to summarize this piece of it, autoregulation, you can find impairment in sick premature babies. There's more impairment of autoregulation with decreasing gestational age and birth weight. And impaired autoregulation is seen more frequently in those babies that developed IVH or PVL. So back to our autoregulatory curves. Again, how does this affect blood pressure? And I think this is alluded to in previous talks, right? Again, the preterm baby has a very, very narrow autoregulatory curve. And this, you can see, is affected, or it can affect how we're trying to manage a baby's blood pressure. So again, autoregulatory plateau narrows with lower gestational age, and the normal preterm blood pressure rests near the lower limit of autoregulation. So if you draw a line down here, that's about 25 to 30 millimeters of mercury. This is just where a normal baby's, a preterm baby's blood pressure may sit. And this is where trying to manage blood pressure comes into play. So we all know that blood pressure targets in preterm babies are controversial. But maybe NIRS monitoring or tissue oxygenation of end organs like the brain may be a better marker than blood pressure alone. And I'm a huge proponent of using NIRS to monitor brain oxygenation. This can help us to better determine the need for blood pressure support in babies. I think you saw this graph earlier in Dr. McNamara's talk, but I do appreciate it because the Amsterdam group again looked at predictors of neural development. Does hypotension predict neurodevelopment, or does low cerebral saturation predict neurodevelopment? And in fact, they found that there were no differences in outcome between hypotensive babies and controls. However, regardless of whether the babies were hypotensive, a cerebral saturation less than 50% was found to be associated with lower neurodevelopmental outcomes. So really, should we be managing brain oxygenation rather than blood pressure? Or at least, in my mind, at least include NIRS measures in hypotension treatment protocols. So our group looked at this in a different way. Here's like maybe the more common definitions of hypotension, right? Mean arterial pressure less than gestational age, or a mean arterial pressure less than 30 millimeters of mercury. And what's interesting is in those babies that met those definitions of hypotension, the majority of the time they had normal cerebral saturations. Only in this dark gray area, only in the small percentage of time did those babies actually have low cerebral saturations. So again, this begs the question, are we over-treating hypotension? And of course, most common drug that people use to treat hypotension is dopamine. And what's a little bit scary is the effects that dopamine can have on cerebral autoregulation. This is an interesting study where preterm babies less than 29 weeks were exposed to dopamine in the first 96 hours of life. And what was found is these babies that received dopamine spent more time with impaired cerebral autoregulation independent of their blood pressure. And this impaired autoregulation, which is shown here on the y-axis, increased, their dose response increased with the higher dopamine doses up to 15 mics per kilo per hour. So dopamine itself may lead to pressure passive blood flow despite restoration of blood pressure. And I think this is, again, a little bit scary and more kind of evidence to say that maybe we're overusing or overtreating babies. Okay, so this is an interesting study. It's called the HIP trial, where they looked at treatment of treatment of hypotension with either dopamine or placebo. And they found, as you can see in this graph here, dopamine itself had no effect on the cerebral saturation compared to placebo in hypotensive babies. However, hypotension together with cerebral hypoxia was associated with the adverse outcomes of early IVH or death. So if you're going to be treating hypotension, you should also be looking at that in a baby that has low cerebral saturations. And those are the kids potentially that could benefit. Incidentally, the findings of this HIP trial was that there was no major difference in clinical outcomes between standard or restrictive approaches to hypotension treatment. So again, bottom line is, I think we're over-treating hypotension. Okay, so I'm going to finish up with talking more about impaired autoregulation in the term population, since I concentrated primarily earlier on the preemies. And this includes babies with HIE, and I think Dr. Singh will be talking about this in the next session, but also babies with cardiac abnormalities, the surgical population, babies with sepsis, or really other conditions with acidosis or hypoxia. Okay, so cerebral autoregulation in HIE. So we know that babies with hypoxic ischemic encephalopathy, we really want to keep a constant blood flow to their brain to limit further injury. And studies have shown that babies with MRI injury or poor neurodevelopmental outcomes had impaired autoregulation, which is measured in different ways, again, using the mean arterial pressure as well as NIRS correlations. But what people are still trying to find is that optimal mean arterial pressure in real time to avoid hypoperfusion or hyperperfusion and secondary injury after asphyxia. This is what this study I found really interesting. There's also a regionality of hemodynamic changes in the brain. So in babies with mild HIE on the first day of life, cerebral autoregulation measures were markedly different in various brain regions. And there was a greater difference in anterior versus posterior measures compared to left to right measures. So looking at perfusion of the brain from the anterior region to the posterior region, they found more impaired autoregulation. So this kind of points to perhaps the temporal region of the brain is more vulnerable to hemodynamic changes. And maybe it's because there's higher perfusion in those regions, or there's a higher metabolism in those areas. So again, a really interesting area of future research. Okay, what about during surgery? This is a study we did a while ago. We looked at babies after a bidirectional Glenn. And we found that intraoperatively, 40% of the time, these babies are pressure passive. And it took up to 48 hours to normalize their cerebral blood flow. Similarly, another group found any kind of surgery, it was intraoperatively during the time of surgery itself that there was the greatest time of cerebral pressure passivity. So what is it about surgery that is influencing impaired autoregulation? Some people speculate it may be the anesthesia. Some people say it may be more of a hypoxic state during this time period. But regardless, I think it's important to kind of coach our anesthesia friends, our surgical friends, to pay attention to brain perfusion in our babies that are getting surgery. Okay, so finally, here's another case to close things out. This is a 25-week preterm baby with early onset sepsis who was intubated for respiratory distress syndrome. And this is a case from a friend of mine, Dr. Varian in Brazil. And they have a really nice multimodal monitoring system where they look at NIRS monitoring. So the renal saturation's in green, cerebral saturation in blue. They also have AEG tracings, and we're looking at blood pressure as well. And what was found was there's a decrease in both the renal saturation and then the cerebral saturation, even when the blood pressure remained adequate at 32 millimeters of mercury. We can see when there's a drop in the NIRS values, the AEG background activity changed to a pathologic tracing of burst suppression. So this is a baby that the team elected to treat the hypotension when the blood pressure also dropped to 20, because with low NIRS and low blood pressure, this is a kid you might want to consider treating. So they gave a fluid bolus as well as started the baby on inotropes. And after that, it was a really nice response to see both the cerebral and the renal sats improving to normal values and the electrical activity of the brain fully recovering to discontinuous tracing, which is appropriate for a preterm baby. So again, just a nice example of how restoring the oxygenation of the brain improves its electrical activity, and also kind of the use of multimodal monitoring to demonstrate that. Okay, so what's in the future? I think, as everyone said, precision medicine is going to be key, and predictive analytics. So we have so many multiple streams of data, baseline patient characteristics, and we can harness machine learning and AI techniques to really determine in real time impaired autoregulation and how babies respond to therapies for it. Okay, so I think that's all I have. So really thank you all for your attention.
Thank you very much, Professor Valerie, for very interesting lectures. And again, we will keep the question at the end of the session. And thanks for you for strict on time. And I stopped watching this excellent to the table. So my pleasure is to introduce the last speaker of this session, Professor Eugen Singh. He's an Professor of Pediatric at US Davis and a global leader in neonatal hemodynamics and echocardiography. He has authored over 100 peer-reviewed articles and developed groundbreaking guidelines for Pocus in neonatal care. Professor Singh's leadership in neonatal cardiology and his pioneering work on advanced imaging, making him a prominent figure in the fields. Professor Eugen, he will speak to us about hemodynamics in hypoxic ischemic encephalopathy. So welcome, Professor Eugen.
Good afternoon, everyone. First of all, thank you so much for the organizing committee for inviting me to talk on this important topic, hemodynamics in the HIE patients. And I'm so sorry that I could not be there in person today. And maybe next time I would love to be there. So no relevant conflict of interest. And in the background, definitely it's important to just recognize when I use the different imaging modalities that I do have the expertise in the echocardiography and the hemodynamics evaluation. So in the next 25-30 minutes, we'll cover 4 important things. One is the pathophysiology of the hemodynamics instability in the HIE patients. Second, why understanding the hemodynamics is critical in this group of infants, and how should we monitor the hemodynamics? What's the role of the echocardiography in understanding pathophysiology? And briefly, I touch on the physiology-based approach to cardiocentric management in the HIE infants. And when I was preparing the talk, I knew that Professor Valerie will cover most of the hemodynamics in the HIE and the preterm infants, and also mostly a lot on the nurse as well. And I'm very well aware that after me, and Professor Satan is going to talk on the pulmonary hypertension as well, and both are really important in this group of infants. So I'll focus more on the echocardiography related and the cardiac and the pulmonary hemodynamics. I'll make it more practical what you and I see in the real life and in the clinical practice. Let's start with this case very briefly. This baby was born at 36 weeks, born by emergency cesarean section. There was a history of fetal bradycardia, tachycardia up to 215 beats per minute, and suboptimal fetal monitoring on the CTG. There was a loss of fetal movements. Baby was born in poor condition, needing coding, and team did a great job, and they stabilized and started the management on the lines of the HIE, possibly secondary to the sepsis, and also baby developed a PPHN very, very obvious later on. So for this infant, therapeutic hypothermia was initiated, and cord blood gases were very poor, including the first blood gas. It showed a severe metabolic acidosis with a pH of 6.8, high base excess -19, and unrecordably high lactate. Baby is about 20 minutes old, less than 30 minutes, looked quite pale, capillary refill time was 3 to 4 seconds, and weak peripheral pulses. The mean blood pressure was 17 to 18, both systolic and diastolic were low. And question was really what they will do next. Maybe I'll let you think, what would you do next in your clinical practice? Will you give fluid bolus of 10 mils per kilogram? Or will you give fluid bolus of 20 mils per kilogram? Start some inotropes, correct the metabolic acidosis with sodium bicarbonate, or accept the low blood pressure, thinking it may improve with time, just like the preterm infants, we can accept in the beginning permissive hypertension, it is still like the borderline really. And most of you agree that this baby is compromised. It's not only the hypertension, which is non-invasive, but also has got a weak peripheral pulses, capillary refill time 3 to 4 seconds, and this baby has perinatal insult, which can be affecting multiple systems. And most of us in clinical practice may give a fluid bolus of 10 mils per kg. That's what the team decided to give there. And this resulted in further deterioration of the infant, further needing coding, and fluid bolus was stopped. And their policy was to start some inotropes starting the inotropes in dopamine. They started dopamine and followed by the D-vitamin was added. And before me, Patrick and Professor Valerie all must have already talked about how dopamine is not the great choice in drugs, but we'll discuss a little bit more in details as well. So, but first of all, let's discuss how did they make the decision that they should give fluid bolus, what inotropes they should start. It's based on their clinical experience or the guideline. based on assumption that this baby may have hypovolemia. But a lot of time, these babies are totally different pathophysiology. In the clinical decision making, there was no consideration of the underlying pathophysiology, no consideration of the impact of the hypoxia ischemia on the hemodynamics, no consideration of the preload, afterload, and the contractility. So you can see this clinical decision was based upon a total on the previous experience guideline, working the blind really without understanding the hemodynamics. But let's take a step back. As we know from the Frank-Starling law, curve really shear. If you give the fluid bolus to any patient who's got the good systolic functions, as you can see the green line, the stroke volume is increased and the cardiac output increases. As compared to in patients with the poor systolic functions, if you give the fluid bolus, there's no increase in the stroke volume, no increase in the cardiac output. And this was not considered in this infant as well, because in this case, they give the fluid bolus without knowing the systolic functions contractility. And that's why it's really important to look on the baseline systolic functions and the preload, whether this patient is going to respond to the fluid bolus or going to make it worse. What about the hypertension, the PPHN? And as my previous speakers already mentioned about the dopamine impairing the autoregulation, but also there's a good evidence from the animal studies, again from Professor Satya and from the UC Davis, that if you use the dopamine, especially the high doses, is not only increasing the systemic vascular resistance, but also increases the pulmonary vascular resistance. And this becomes more prominent when it's used in the setting of the pulmonary hypertension. So it may worsen the pulmonary hypertension. It does not increase in the cardiac output, or maybe less increase in the cardiac output. It impairs the autoregulation. What about if you use the high dose of dopamine in the setting of the poor contractility? Is increasing in systemic vascular resistance is a good option in the cardiogenic shock? Probably not. So these all considerations, again, when working the blind, are not taken into. As we know, cardiac output is a product of the heart rate and the stroke volume. And stroke volume depends on the three important things: preload, afterload, and the contractility. And all these three can be affected in the patients with the HIE, leading to hemodynamic instability. Let's look on this case slightly differently. Now, this baby is 4 hours old, was transferred from the community center to the tertiary unit. And somebody did a very limited echo or point of care echo, really. I'm showing only one image here. This is the apical 4-chamber view. As you can see here, this baby has very impaired cardiac contractility. And heart is not underfilled, it's look well-filled heart. If somebody just assess the cardiac contractility and the preloading in a setting of the emergency by limited echo, I'm sure most of us will say there's no need of the fluid bolus here, and possibly start some inotropes which can improve the contractility, improve the cardiac functions without increasing the systemic and the pulmonary vascular resistance. So choice of the inotropes and the choice of the intervention may be very different if you use the functional echocardiography or in the point of care echocardiography in emergency setting. So these cases highlights how important it is to understand the pathophysiology if you want to manage these patients optimally and to optimize the management. Let's discuss the hemodynamics in the HIE. We know it's very common. Both HIE and the therapeutic hypothermia both have the potential to negatively impact the hemodynamic status in this group of infants. And we know this hemodynamic instability may manifest as hypertension or the end organ impaired perfusion, hypoperfusion. Up to 2/3 cases, HIE cases, may have transient myocardial ischemia, and that varies, depends on the severity of the HIE. It may be mild myocardial ischemia to the cardiogenic shock. And as we know, HIE involves multiple organs, and sometimes even they can be only one organ can be affected. Like the case I showed you, that baby later on had completely normal EEG and normal MRI, but that baby had a cardiogenic shock with a troponin levels of more than 20,000, severely impaired cardiac functions, and needing multiple inotropes for a good few days. This highlights the cardiovascular physiology in the HIE setting is very complex and it's very dynamic. It changes minute by minute, not only from the disease process itself, but also from the interventions what we do, medications what we use, like cardiac medications, dopamine or other inotropes. And also therapeutic hypothermia affects the systemic and the pulmonary vascular resistance. It increased the systemic, the pulmonary vascular resistance. The traditional tools for the cardiovascular well-being are indirect proxy parameters. If you use the heart rate, blood pressure, urine output, all those are good good tools to monitor the hemodynamics continually, but they are the indirect proxy parameters. NIRS is fantastic. This tells about the end organ perfusion, as well we discussed really, but that will not tell about the contractility, about the cardiac output, stroke volume. Where is the problem is? It tell about the end organ perfusion, but not how we can optimize the blood flow from the cardiac side. How we can increase the cardiac output. So this cardiovascular physiology is complex, and we'll discuss in the coming slide in more detail. And also, this work done by Reagan again showed the RV dysfunction is independently associated with increased death and increased risk of the abnormal MRI and the poorer neurodevelopmental outcome. Similarly, dopamine used in these group of infants had a greater risk of as a composite risk of the death or abnormal MRI and more severe pattern of the brain injury. And the mechanisms can be very, very complex as well. Not only the loss of cerebral autoregulation, which can increase the risk, but also the increasing the systemic vascular resistance, decreasing the cardiac output as well, especially in this setting with the therapeutic hypothermia. So let's look on this pathophysiology. How is so complex? If any infant has got the perinatal insult, it can affect the hemodynamics in multiple ways. In the center is the myocardial ischemia. With perinatal insult can be from the different pathophysiology, and it can be from the various underlying causes. What are the causes? That perinatal insult itself can lead to endocardial ischemia, myocardial ischemia, and can lead to poor contractility, poor cardiac functions, and decreased cardiac output. And we know this group of infants have got a much higher risk of developing the pulmonary hypertension, higher pulmonary vascular resistance, and acute hypoxic respiratory failure. That itself will lead to the decreased pulmonary blood flow, decreased preload, hence the decreased cardiac output. On the third mechanism, which is the adrenal insufficiency and the increased catecholamines, as this insult happens, body tries to optimize the blood flow to the vital organs. And that also leads to the increased catecholamines, epinephrine, norepinephrine. That also lead to abnormal vasoregulation and leading to the decreased cardiac output. Once there's a decreased cardiac output, leads to end organ injury, including the hypoxic ischemic injury in the brain and the other organs like the kidneys and the lungs itself, and also liver as well. And that will lead to hypoxia and acidosis. And we know this hypoxia and acidosis will lead to the further increase in the pulmonary vascular resistance. And in the next coming talk, we'll discuss more details about this one. Next one, with the perinatal insult, as we discussed previously, that it lead to the loss of cerebral autoregulation, which itself will lead to increase the risk of the ischemic injury. Once we start the therapeutic hypothermia, which increase the systemic the pulmonary vascular resistance, hence worsening the pulmonary hypertension, but also decrease the heart rate, which can decrease the cardiac output, and this cycle continues. What about the rewarming phase? Rewarming, although we do slowly, but still there can be increase in the cerebral blood flow, sudden increase in the cerebral blood flow, and also drop in the systemic and the pulmonary vascular resistance. That also can lead to the reperfusion injury during the rewarming phase. And we know that from the clinical setting that the high risk of the reperfusion injury during rewarming, including the seizures, including the presentations as well. Let's look on this one a slightly different way. If you've got a patient with the HIE and PPHN, which is very common in this setting, because increased pulmonary vascular resistance, and right ventricle not designed for the continue to work against the very high pulmonary vascular resistance long time. So it will lead to the RV hypertrophy, RV dilatation. That will lead to the flattening of the interventricular septum. So two things happens. Once from the higher pulmonary vascular resistance, poor RV functions, there's a decreased pulmonary blood flow, hence the decreased pulmonary venous return, leading to the decreased RV preload and the decreased LV cardiac output, hence the systemic hypoperfusion or the end organ acidosis and increased lactate. But also this flattening of the septum lead to the LV dysfunction directly because of the ventricular interdependence as well. So that will lead to the biventricular dysfunctions. On the other hand, this perinatal insult, as we're discussing, leading to the myocardial ischemia, which is not only from the insult itself, but this hypoxia and acidosis, which is the ongoing in this setting, the pulmonary hypertension and the insult, that itself will also affect the myocardial ischemia. And that lead to the poor LV and RV functions, decreased cardiac output, and lead to the cardiogenic shock. Once there is setting of the cardiogenic shock, that lead to hypertension and the poor coronary perfusion. Hence, it's really critical to understand what's happening with the LV and RV functions, what's happening with the cardiac output, system with the pulmonary vascular resistance, and how we can optimize individually with the precision medicine in this group of infants. Beyond the perinatal insult itself, the therapeutic hypothermia impacts the hemodynamics significantly as well. As in this study, they looked onto the blood flow in the upper part of the body and the lower part of the body, and the ratio between the upper body blood flow to the LV cardiac output. When these ratios increased more than 55%, they demonstrated there's a high risk of the hypoxic ischemic lesions on the brain MRI, and you can see odd ratios more than 13. So this is clearly it's showing that there's a upper part of the body blood flow doesn't change, but the lower is decreased, in that lead to the sudden increase in the ratio. And also they demonstrated, like other animal studies from the sheep lab, and clearly they increased the systemic and the pulmonary vascular resistance. So what are the hemodynamic impacts if you look on the more hemodynamic impacts of the therapeutic hypothermia from the cardiac echo perspective or from the hemodynamics perspective? There's a decreased cardiac output, decreased heart rate. We know with the therapeutic hypothermia, there's a decreased heart rate, which may lead to the decreased cardiac output. It may be needed less because metabolic needs may be less, but still we do not know how low will be optimal and how low will be causing more injury as well. Secondly, decreased descending aorta blood flow and normal upper body flow, that will lead to high risk as well. It's increased the systemic vascular resistance, and it worsens the pulmonary hypertension. Clinically, these will be very hard, almost impossible to monitor clinically or from the routine traditional tools to monitor the hemodynamics. But good news is, if you use the point-of-care echocardiography or echocardiography in the bedside, you can monitor all these directly, and so that we can target our intervention based upon what is deranged. Serial echo assessments can help in not only understand the pathophysiology itself, but also the impact of the disease process and also impact of the interventions what baby receives. So echocardiography in the HI infants, I briefly discussed this one and towards the end really. There are 3 levels you can discuss here. One is the comprehensive structured or the functional assessment, which is mandatory in this group of infants because some patients may have underlying critical CSDs. The first echocardiography should be, when possible, should be comprehensive to rule out the critical CSDs. Then there are 2 I put really. One is the cardiac Pocus assessment. One is the TNE or the NP, which is the more detailed assessment of the heart and the hemodynamics. Cardiac Pocus can be used for the rapid assessment, like in these shock patients, for the contractility, for the whether we should give fluid bolus or not. Very rapid, but very limited assessment really. Secondly, on the TNE, where the functional echocardiography, you can look at the hemodynamic evaluation by trained neonatologists in the TNE. In this case, we can be more protocol-based really. And I have to highlight here, the hemodynamic evaluation, if you want to, a comprehensive hemodynamic evaluation is completely out of the scope of the Pocus. For that one is TNE or comprehensive functional assessment should be done. Equally, person who is not trained into the ruling of the critical CSDs, it's really important to the first echo should be very comprehensive or should be reviewed soon by the peds cardiologist as well. So with the hemodynamic evaluation, there are 3 important aspects we can discuss here. One is the assessment of the cardiac function. Second is the cardiac filling and also the assessment of the afterload. So you have the cardiac contractility, cardiac functions, preload assessment, and the afterload assessment. Once there's a setting of the pulmonary hypertension, then we can have a comprehensive assessment of the pulmonary hypertension. Again, that will be discussed in the coming talk. As I was saying, really, limited echo can be useful in the setting of the shock for the very rapid assessment. Like in this case, here, like the same case really shows very poor contractility. There's a tricuspid and mitral regurgitation. There was aortic and pulmonary regurgitation. This baby has definitely got a myocardial ischemia, endocardial ischemia leading to all the valvular regurgitation and poor contractility. But this will not tell you a lot about the cardiac output, about the assisted pulmonary vascular assistance. If we want to assess the cardiac functions, then we need to look at more details, and the various tools are there to look at the details cardiac function assessment. With the limited time, I'll not go a lot of details on the full echocardiography, but with the more advanced imaging, it can be tissue Doppler imaging or speckle tracking, or even the basic, really important, like Simpson's biplane method, we can look at the ejection fraction. Once this person is trained for the advanced functional assessment, those can be really helpful to look on the not only systolic function assessment, but also diastolic function assessment. It's important to look at both LV and the RV cardiac function assessment. As we discussed previously, it's well reported that poor RV function is associated with the poor outcomes in this group of infants. So RV function, if you look on the eyeballing, which can be okay in the emergency, but can be very subjective, may not be very accurate. But if you want to look at more advanced imaging, including the tissue Doppler imaging, or looking on the TAPSE, or even or the fraction area chains. In practice, TAPSE and tissue Doppler are commonly used, at least in my practice here. Then we can look on the cardiac output, both LV and the RV cardiac output. As you can see in the same patient, really, you've got a very low cardiac output here. LV cardiac output was less than 50 mils per kg per minute, where optimal should be around at least 150 mils per kg per minute. RV cardiac output can be measured similarly, and in this case, it's a very low cardiac output in the setting of the HIE. And then once we know there's a poor cardiac output and how this can be optimized, how the myocardium can be supported with the appropriate medications. And once baby improves during the cooling as well, we can monitor the cardiac output, and accordingly we can change our intervention. I will not go a lot of details, but once there's a pulmonary hypertension, we should have comprehensive evaluation of the pulmonary hypertension. And we know this is very common in this setting, really, the poor RV functions as well and early failure. just to highlight one more important thing to highlight here, if you got a baby with the RV which is failing and you got the tiny constricted PDA, to help the RV, just like a pop-up valve really, sometimes starting the prostaglandins can be very helpful, especially in this group of infants. So hemodynamic instability in the HIE, the 4 important things as we discussed really is important to look on the cardiac functions, afterload, SVR and PVR, preload, which is rarely affected, but it can be hypertension, hypovolemia as well, and optimize the pulmonary hypertension. And also put here, which is the respiratory management, although I'm focusing mostly on the cardiac, but these cardiorespiratory management going hand in hand. All this will work only when we optimize the respiratory management. And as we know with the pulmonary hypertension management, INO and all other what we'll discuss in the coming talk. Once we know the cardiovascular physiology, then our aim should be to improve the cardiac functions, improve the cardiac output without increasing the systemic the pulmonary vascular resistance, ideally to decrease the systemic the pulmonary vascular resistance, which are increased by the therapeutic hypothermia as well. So I talked a lot of the pathophysiology here. I'll let you think about what should be your first drug of choice in this setting, in the patient with the HIE and with the cardiac decompensation. Previously, people traditionally use dopamine, but I think here the choice should be dobutamine. Again, we already discussed that dopamine is not the really good choice in this setting, really. I mean, most like with the pulmonary hypertension itself as well. But dobutamine will increase the cardiac output, support the myocardium, you got the mild myocardial ischemia. But you can also consider adding the low dose of epinephrine, especially when there is a moderate to severe LV or RV dysfunction is there. Or maybe low dose of dobutamine and low dose of epinephrine combination of both can be a good choice as well. So choice of vasoactive medications should depend upon the underlying physiology and what target goals are. Is your goal is to improve the cardiac output, improve the cardiac functions? What about goal on the system, the pulmonary vascular resistance? As in the pulmonary hypertension, I know maybe the first choice on one side, and the second side supporting the myocardium with the appropriate medications. Also, in this group, we should avoid the use of milrinone, especially if there is a kidney impairment, or use for a very short time, because that's cleared by the kidneys as well. Otherwise, it may lead to the accumulation of the dose milrinone and may lead to more hypertension. Given there's a high systemic and pulmonary vascular resistance, we should avoid increasing these systemic vascular resistance further, and high dose of dopamine, norepinephrine, vasopressor therapy should be avoided. But we got other better drugs as the first and second line. And they just summarize this cardiocentric management, the HIE really here. You can see if baby has got a cardiovascular instability, whether baby is hypertension or not, and baby has got a hypoxia or not. If you got the hypoxia, we know in that case, really important to optimize respiratory management, optimize the sedation, minimize the weak mismatch. As we know from this on the side here, the graph, again, good evidence from the animal studies as well here, that if you got a low functional residual volume or the high functional residual volume, there's an increase in the pulmonary vascular resistance. The lowest pulmonary vascular resistance is where you achieve the functional residual volume. And similarly, this is affected by the acidosis and the hypoxia. So it's really critical to minimize the weak mismatch, optimize the respiratory management, and then based upon the echocardiography, based on the cardiac function, we can use the first and the second line medications or what to optimize the hemodynamics. To summarize, cardiovascular compromise is very common in the infants with the HIE. Cardiac dysfunction varies from the mild to the severe to the cardiogenic shock, as in the case we discussed. And infants with the cardiac dysfunction and with the hypoxic ischemic hit, really, they are associated with the poor outcomes, both short-term outcomes and the long-term outcomes. Understanding the pathophysiology of the hemodynamic instability is the key to provide timely and targeted specific intervention. Echocardiography plays a really important role in the understanding pathophysiology and also changing the pathophysiology, because it's very dynamic, it's complex, it changes with the disease process, and also from the interventions what we do. I'll stop here, but I'll stop with this quotation really. Seeing is believing. Really important to look on the echocardiography, but it's really important to understand the process and pathophysiology, because your eyes will know what your brain knows. So you need a good understanding of the pathophysiology from the knowledge, experience, and then only echocardiography imaging focus or the comprehensive echocardiography will help in understanding and putting all in the clinical context. I'll be happy to take any question during the discussion. Thank you so much again for inviting me. I'm sorry I could not be there in person.
Managed to at least speak. Can you hear us, Yogin?
Yes, I can hear now. Yes.
Okay, we were muted. Please.
Yes,
I couldn't hear, so it's very silent. I don't know what happened, so that's why I'm trying something else.
Okay, thank you very much, Professor Jürgen, for very interesting and informative lecture. And we are all pray for you for rapid recovery. Thank you very much that you are coming. And what time in California now? It is early morning, yeah?
It's very early morning. It's 4:30 now. So
yeah, 4:30 a.m. Yeah. So thank you very much for your really.
It's my pleasure. Like it's always good to
really, we are all pray for you for rapid recovery. Thank you very much, Professor Singh, that you are.
Thank you so much. I appreciate that.
Most welcome. We have two questions. If you okay, one question here.
My question,
absolutely, please,
Professor Valerie. Sorry. Oh. Yeah. Thank you. Nice talk. I think I have. So, what's your experience? What do you think the gestational age, the younger babies have impaired autoregulation? Is it something related with the neuroendocrine control maturity? Is it like something related with the HPA axis that they are not? Do you do any cortisol levels on these babies regularly? When you do, because sicker babies also do lose the impaired autoregulation. So, is there any kind of connections between these two? That's my first question. I think second question, I think in UK, I think university, I think Dr. Nikki Robertson's in it, and Stanford. You are doing the multimodal probe NIRS. As you mentioned in mild HE, the different part of brain has a different perfusion. So what's your update on that? Thank you.
Both very good questions. I think your question about cerebral autoregulation and gestational age thresholds, if you will, I think it's quite variable. I don't think there's one gestational age cutoff. I think it's an interesting idea, the HPA axis. We do not typically measure cortisol levels in our babies, but I think that may have something to do with it. It's just so individualized based on the degree of hypoxia, acidosis, et cetera, for each baby. So I think, we set up protocols where we measure. We have NIRS monitoring in all babies less than 29 weeks gestation, not necessarily because of a higher risk of impaired autoregulation, but more because of the risk of IVH in general in that population. So I think we just, it's good to start somewhere when you're first, implementing a NIRS monitoring program, but keeping in mind we need to be flexible depending on the situation of the baby. And then second question about multimodal monitoring. I love it. And regionality of the brain. Yes, I do think there are differences. I think we also have to be cautious because when you think about NIRS monitoring, it's measures the oxygenation more of the superficial brain, right? So that's like 1.5 to 2 centimeters below, right? And so sometimes what we wonder is, what about the deeper structures of the brain? And that's something where I know commercially people are working on new sensors to also look at interrogate the deeper regions in the brain. I do think there are going to be really prominent left to right differences. In the preemie, it's a little harder until we can get that sensor size small enough to be able to differentiate left versus right, but all really great research questions.
I'm Dr. Adham Badib. I'm from Egypt. My question is Dr. Yugun. So by far, do you find any sort of echocardiographic findings or hemodynamic findings that makes you want to stop the therapeutic hypothermia? That maybe it's deteriorating his condition, the baby's condition, and then it's a must to stop because we face this a lot. Babies are not doing well, and then at some time we feel that the therapeutic hypothermia is aggravating the condition, and we need those sort of solid things that make us stop the therapeutic hypothermia.
Thank you. That's a great question. And in my experience, I've been only once where we had to stop the hypothermia. And that's a typical case which I presented really. So normally, as you know, it's really important. It's critical to protect the brain with the therapeutic hypothermia. It's really balance. If the baby is so hypertensive that baby is going to die, only have to consider, do you need to do something here? Intractable hypertension. This baby, despite the 5 anatopes, had really bad cardiogenic shock with the troponin levels of more than 22,000 and very high lactate. Personally, I will say rather than stopping the hypothermia, we can consider increasing the temperature by 0.5 degree and then see what happens. You can do the repeat echo, increasing another by 0.5 degree. You still can get benefit of the hypothermia and still can improve the hemodynamics. By increasing the temperature by 1 degree, 0.5 or 1 or 1.5 degree gradually, that can decrease the systemic vascular resistance and improve the cardiac functions. The key point is really right from the beginning. If you use the right drugs, if you use the right medications, possibly we will not be in a situation you need to consider stopping the hypothermia. Problem more comes really, already this baby has got the cardiogenic shock or the perinatal insult, and you start the high dose of the epinephrine or high dose of dopamine. And in those situations, we further increase systemic vascular resistance, and that has a negative impact on the cardiac output, negative impact on the cardiac contractility. So I think with better understanding of the cardiovascular physiology and the hemodynamics, we are not seeing this very often really. In my last 15 years, I can say I've been only once in this situation. We increase the temperature, but also we recooled very soon once we saw the baby was improving as well. And that will be normal neurodevelopmental outcome.
Hi, this is Dr. Rupali. I'm consultant neonatologist at Mediclinic Parkview here. Thank you for both your talks, and really a personal thank you to Dr. Yogin for his amazing talk at this time of the hour. And we will definitely want to see you here next year, and I hope you feel better soon. My question is for Professor Valerie. You mentioned about post-surgical babies. Are there any trials and studies on the use of NIRS during surgery, and would that help these babies?
I know there's a lot of, I shouldn't say a lot, but a fair amount of literature in the cardiac surgical population, especially cardiac anesthesia. They have used NIRS quite a bit in trying to kind of maximize cerebral perfusion. There's maybe more limited data in just surgical procedures in general. So I do think that would be a wonderful frontier to look at a little bit in more detail, because like I alluded to, we don't know exactly what's the cause. Are there types of anesthesia that can affect cerebral perfusion more than others? and how do we like maximize blood flow to the brain in those periods of time.
And Rupali, first, can I give a comment here? First of all, thank you so much for wishes and also inviting me again for this conference. And I agree with Valerie completely. They even before the therapeutic hypothermia, before the cooling in the neonates, in the cardiac surgical patients, we have been using NIRS for a very long time, really. And that had been a standard practice from early 2000s. I think it is a very standard practice to look on the NIRS as soon as these patients go in the ICU. And if the NIRS changes, it's not only the monitoring, there, a lot of management goes based on the on the NIRS values. And that's why repeat echoes there can be very helpful, improving the cardiac output, improving the cardiac functions if there's a change in the NIRS in that setting there.
Thank you very much. Dr. Yugan, allow me, now you said dopamine is not recommended right now because most of the pediatrician and neonatologists, they are using the first line for, in the case of the hypotension, dopamine. So now you are recommended dobutamine in the first choice, not dopamine, yeah? So what is the side effect of dopamine because you are choosing dobutamine in favor of dopamine?
Thank you. So thank you. This is a really important question, really. And normally it's a full talk on the inotropes, what we should use, what we should not use. And thus I did not go in a lot of details. Dopamine itself, if I had to choose any inotropes, will not win my unit at all. This is really not a good inotrope. First off, it increase your blood pressure by increasing the systemic vascular resistance. It's not a good inotrope. It does not support the myocardium very well. Typically, especially in the setting of the pulmonary hypertension, it may worsen the pulmonary hypertension. It increases your systemic vascular resistance. In the setting of the HIE, it impairs the autoregulation. Like even in the other settings, like preterm infants, in the first 48, 72 hours with extreme preterms, who's with the diastolic dysfunction, cardiac dysfunction, it's just not a good drug to support the myocardium with as not being a good inotrope. Traditionally, we use this dopamine as the first choice because just what we use really without understanding pathophysiology. But most of the centers where the functional echo is becoming integral to the clinical practice, we are going away from the use of dopamine in most of the settings, really. Yes, if it's the septic shock, still the norepi and we got the better drug vasopressors. I will say, I know still commonly used, still about 75, 90% units still using dopamine first choice, but we have the better drugs which understand their mechanism better, they work on the myocardium as an inotrope better. So we should be looking at the physiology rather than blindly choosing one drug. Like even the preterm infants or the HI patients, where the goal is to increase the cardiac output. And we know dopamine is not good in increasing the cardiac output. It increases the number, like by increasing systemic vascular resistance, increase the blood pressure, but not the cardiac output. Our aim should be improve the endorenal perfusion, support the myocardium.
Thank you very much. Yeah, one more question.
Hi, again, Sony here. Good to see you and
Sony, how are you?
Speedy recovery. I'm fine, thank you. I just wanted to reiterate just for the wider audience about the same question. Is there any clinical situation where you can justify the use of dopamine as the first line inotrope? So that there's no confusion among the people, whether it's a physiology based or a protocol based. Is there any situation where if we get completely rid of it, can we still live with it?
That's a great question, Sony. There's no strong hard evidence of any of the inotropes. You ask me evidence of the papers, there's no strong evidence, and probably it will not come. These are the really hard group of patients to enroll in the NERCT. As a first line, answer is no, I will not use. As a second or third line, when you tried the other one, like septic shock, you already using norepi, still baby has got hypertension. If you want to use in those babies, I don't mind as a second or third line really, but first choice, I normally look divide into 4 categories: preterm infants with the extreme preterms, HI, PPHN, and you get the septic shock. In these cases, HI almost we should not use, we discussed with therapeutic hypothermia. Extreme preterm friends, first 48 72 hours will be now. Probably I will say, if I give my choice, I know still in my unit will be used, maybe come from the different community centers. I will not stop it, but I will preferably not use it. I got the better drugs really.
Just adding to that, I think we haven't covered this section, the drug of choice for various scenarios, but because now we're discussing and everyone seems interested, let's take like poll and maybe one take home from each situation. So I think Yogan clearly said HI, probably dobutamine, first choice, and low dose epinephrine.
First choice dobutamine and maybe low dose epinephrine. If they're moderate to severe functions, I will add both. So based on the echocardiography, blindly, I'll start dobutamine first, get a first echo. You got this impaired function, like in this patient I showed you. There's a poor contractility. I'll use combination of both very soon, early on as well.
Yeah, we're just taking take home, HI, dobutamine.
Okay.
Preterm myocardial dysfunction or preterm with hypotension, drug of choice. Low dose epinephrine. Anyone else has any choices? Dobutamine, anyone's? No functional echo, then dobutamine. Just preterm, no echo available, dobutamine. And dopamine, anyone for preterm? Yes.
No.
Not necessary. So again, dopamine also has concerns regarding coronary perfusion, increasing myocardial intake, uptake, and all those things. So again, dopamine has concerns with preterm. So for one drug of choice or two we can take away is low dose epinephrine and maybe dobutamine, right?
Absolutely. Again, same thing, Kiran. Like if you the first 48 72 hours, we should be really careful about the first line really, because in those cases, if you use the dobutamine first 48 72 hours, increase the cardiac output. But if you see the systolic functions, moderate to severe dysfunction, add the epinephrine there as well.
Right. Sepsis, warm septic shock, first choice. Norepi, very good. Everyone is like Norepi. Fantastic.
That's good.
Dopamine, any takers for dopamine?
See, in shock, especially in newborns and preterms, so blindly we cannot tell it is norepi, because if you previously we used to call it cold shock, warm shock, but now we say it is high output shock or low output shock. If it is a low output shock, then your first choice of drug will not be norepi, especially in the preterms and newborns. So we have to be careful about that. We cannot extrapolate whatever studies have been done in the adult and the pediatric age group in the neonatology, because myocardium is weak in the newborns.
So corollary, before starting norepi or dopa also, make sure your cardiac function is normal. That's why again we warrant the AP. You cannot increase the afterload just to increase the blood pressure if the heart is already weak. So that's again, certain caution. PPHN, I think Dr. Soni will be covering. Should I leave the discussion for PPHN with you? The inotrope of choice? Acha, Satyan will cover. So I'll leave PPHN discussion out now, because there also it's little complex which inotropes in which situation. I think that should cover more.
And don't forget to look at the perfusion of the brain.
Don't forget about
because-
yeah.
Absolutely.
Absolutely. We don't need to even actually. That's what.
Yeah, very importantly, the brain is the super important organ of the body. So we're doing everything to prevent any brain damage, really. I just wanted to say your last slide was really, really important. You know, your eyes don't see what your brain doesn't know and doesn't look for. And on that note, I just want to say that, we were talking about less members of teams having been functionally echocardiographically trained, but also there is another issue of general acceptance of functional echocardiography. So, even at Sidra, when we started, there were a lot of people who were non-believers. And I think that's a big barrier that we have to overcome. So, basically getting people to believe that functional echocardiography is important and actually makes a difference in a baby's care. And just with the example of choice of inotropes, so important to know what the heart is actually doing before you chip in with one inotrope after another. And we've had so many babies who've been put on multiple inotropes, but landing into trouble because it's all the wrong choice of drugs.
Absolutely, Rupali. I think it cannot be summarized any better, really. I agree. I think in the beginning, there's always resistance to the any new intervention, echo is no different. And in the beginning, they'll be, okay, fine, we have been managing without the functional echo for so long. But once you demonstrate a different pathophysiology, it's really after that, people start believing in that one. And one other one we discussed, like cardiac effusion, tamponade. There are so many are there now in today's practice. I wonder, like some people, like if you practice without echocardiography, how hard it is and how difficult it is, because in that case you're working just blindly guessing game. And I think in most centers, especially where the echo is being adopted, people are going away from the blind practice really.
And be aware of not becoming a Superman.
Knowing your limitations is the critical, especially I put in the red one line there. Point of like a lot goes in this one, like Pocus is not for the hemodynamic evaluation. So very limited echo, limited assessment, limited indications. So don't be superhuman. Definitely do not ask too much from the limited skills as well, because you burn your fingers otherwise. So always look on the 3 levels of the training, 3 levels of the indications as well. So it's really critical to know your limitations.
Thank you, Dr. Yogen. I'm Dr. Monica. Thank you for accepting our invite, and I'm sure we'll see you next year in person. Thank you. And
thank you so much, Monica. It was my pleasure to talk to you guys.
Dr. Yogan, I think Dr. Monica, she will give you a certificate that you are awake in all the night, so you can take tomorrow off. Yeah, inshallah. You will.
I appreciate that. Thank you so much. Enjoy the rest of the conference.
Enjoy. Thank you very much. Thank you. So we have coffee break for 10 minutes. Then we'll come back to the next session, please.
Someone in tech support, can I see if I can share my screen?
Hi, doctor. Yeah, you can override the screen so you can test it from your side.
Thanks. My phone.
Yeah, you can override the screen so you can test it from your side. We're currently on a break, doctor, so we'll start in 15 minutes, okay? Or 10 minutes.
Okay, sounds good.
Okay, thank you.
Hi, Amy. Thanks for joining. Morning.
Good morning.
Hope you're doing well.
I'm doing all right. How about you?
It's a little early, but otherwise I'm okay.
Yeah, I know. I felt bad for me, and then I was like, oh wait, you have to get up even earlier.
I decided to drive to work. It's much easier. Otherwise, my son is off today. They have a teacher day, so I didn't want to wake him up.
Yeah, yeah. Something always goes wrong when you try to do these things at home.
Uh, Prior to this one, Yogan and his team had a really lively discussion on vasopressors and hypertension. So yeah, and they conveniently pushed all the questions on PPHN for us. So we'll see.
Okay.
You're working on a paper on defining CFTE for neonatologists at 7 a.m. today. So it's a robust, lively discussion, very entertaining. So
I'm sure. I'm sure. Yes. I forget, what did you talk about? I can't remember now. You spoke at the AAP, the Midwest AAP conference. What was your topic?
should provider compensation be based on patient weight?
Welcome back. So, start. So I'll introduce our next chairperson, Dr. Alok, a good friend, and he's a consultant neonatologist in Cornish Hospital, and he is the president of MPROV. If everyone, most of us will be knowing the good simulation program, which is run by him. So welcome, Dr.
So very kind words from Dr. Monica. So first of all, save the goal for last. That's what we always say. So whilst we're coming to the kind of last session of the day, I'd say it's a topic that is very near to my heart. We'll be talking a lot about recent advances in management for pulmonary hypertension. And, you know, we've got an eminent group of speakers who grace this occasion. I'm going to start by introducing Professor Satyan Lakshminarishma, who is the Chair of Pediatrics and Division Chief at UC Davis. Not only is he a very learned neonatologist who has published and researched neonatal resuscitation and pulmonary hypertension in a big way, for those of you who don't know, he's an amazing artist. And his photographs on physiology of the newborn grace a number of different books. They were actually part of the presentation that was done this morning on delayed cord clamping. Above all, he's just recently been given an AAP Education Award for his contribution to neonatal education. Along with him, we'll be presenting Dr. Amy Stanford, who is a clinical assistant professor who specializes in neonatology and is currently working at the University of Iowa. Now, Amy has done a huge amount of work on the use of functional neonatal echo in neonatology, specifically looking at pulmonary hypertension and neonatal hemodynamics. She obviously works along with Patrick, and I'm going to let them take the floor to give us what is a really good update on the recent advances in pulmonary hypertension.
Thank you so much for the introduction. Let me share my slides. Good morning, everyone. Can you hear me okay?
Yes, we can hear you.
Great. Okay. Can you see my screen? Okay. So Amy and I are going to walk you through some new concepts in the pathophysiology and management of PPHN. As many of you know, I am a pure clinician. I have absolutely no expertise in echocardiography. So please refrain from asking me any questions on echocardiography. And Amy is the expert in that area. So we will tag team and then cover this topic. Before I start, I want to emphasize the fact that we don't have any conflicts of interest to disclose. And as many of you know, use of inhaled nitric oxide is not approved in preterm infants less than 34 weeks of gestation. And in fact, many of the drugs we talk about today are not approved in neonates, including vasopressin and milrinone. And when I started managing PPHN almost 30 years ago as a fellow in neonatology, I was very keen on using a lot of oxygen, and I had a hard time understanding as to why using oxygen would be bad. And over the years, I have learned to balance myself. But nowadays, we are facing a similar situation with nitric oxide, where figuring out when to use nitric oxide and when not to use nitric oxide has also become a very controversial topic, and we will address those as well. So most of what I will talk to you today comes from many of these guidelines. These are the European guidelines on management of pulmonary hypertension in pediatrics. It has a really nice table, table 9, that talks about management of PPH, and I strongly urge that you look at that table. We also have updated Canadian guidelines on management of diaphragmatic hernia. And more recently, earlier this year, Steve Abman and I edited a book on clinics in perinatology. And many of the figures and things that I show you today are from this particular book. So when we talk about pulmonary hypertension, there are obviously clinically, we can look at acute pulmonary hypertension and chronic pulmonary hypertension. And when we look at acute pulmonary hypertension, there is the typical classic one that we come across in term babies and post-term babies. Typically, example including hypoxic ischemic encephalopathy, birth asphyxia with either pneumonia or meconium aspiration syndrome. And this is a typical thing that we see, and we will cover this particular topic here. We also see a very similar acute early pulmonary hypertension in extremely preterm infants. The more preterm you go, the higher is the incidence of this pulmonary hypertension. And in fact, when you look at data from many countries, babies as young as 22 and 23 weeks have anywhere from 8 to 14% use of inhaled nitric oxide. So this is another controversial area. We will not be addressing this today, but we can talk about this during our discussion. Of course, there is late onset infection, hypothermia, or cardiac disease that can cause acute pulmonary hypertension as well. As we move along, diaphragmatic hernia is a really important component of PPHN. It can cause both acute and chronic pulmonary hypertension. And then there is chronic late pulmonary hypertension in BPD, which we will discuss in the subsequent talk. We are starting to see more and more patients present with pulmonary vein stenosis, and this is a unique area where recognizing this and treating it very differently is very important, especially when you have BPD with pulmonary hypertension. We'll address this with a couple of echoes and talk about that. But although we are used to dealing with pulmonary hypertension based on the timing and the disease pathology, it's much more beneficial to classify PPHN in a different way, and I'll come to that in the next slide. Before we go there, a bit of physiology. How does a fetus manage pulmonary hypertension? Because as many of you know, if you catheterize a fetus, the fetus has fairly high pulmonary vascular resistance and pulmonary blood pressure. In fact, in lambs, fetal lambs have pulmonary blood pressures as high as 60 to 70 millimeters of mercury, and they do perfectly fine, they grow perfectly fine. And the reason for this is that fetuses are very smart. They know how to maintain and live with pulmonary hypertension. Lungs are maintained at functional residual capacity with lung liquid. This results in optimal lung inflation, which is a really good thing that we need to learn as neonatologists, because if you don't inflate the lung to FRC optimally, management of PPHN becomes very difficult. The second clever thing that fetuses do is that they maintain systemic blood pressure in normal range, in fact, slightly on the lower side, and they maintain low afterload. As we were discussing in the previous session, Dr. Singh and Dr. Mohit Sani were talking about the fact that the ventricles are very sensitive in newborn, especially preterm. And so avoiding excessive systemic hypertension is really important while managing PPHN as well. The presence of an open ductus reduces right ventricular afterload, and this is where the use of PGE1 comes in, and we will show you some echoes on this topic. And use of oxygen. If we should focus on delivery of oxygen to the tissues rather than focusing on a fixed number for PaO2 or SpO2. And then the fetus maintains fairly high hemoglobin, so maintaining a decent crit is really important. And especially having high fetal hemoglobin levels through delayed cord clamping. I know you had a talk on this topic earlier. So any baby that's not vigorous and is not looking good, it's probably worthwhile making sure that some type of placental transfusion happens. And I hope you talked about MINVI, the new MINVI trial by Dr. Anup Katheria, where milking the umbilical cord in term babies and late preterm babies was shown to be beneficial from the perspective of reducing HIE, etc. And you also need to remember that fetuses are really parasites. They know exactly how to get most out of the mother, and I'm sure Amy agrees with me on this topic. So this is the only time in life when somebody kicks you and you still feel happy. So that's the beauty of being a fetus. The important thing to know is that it extracts every single bit of nutrition, including oxygen and iron and etc. from the mother, and survives quite well. So it's not uncommon for us to come across mothers who have really low hemoglobin levels, but the fetuses tend to maintain that quite well. And that's the beauty of being a fetus. It looks after its own well-being at the cost of everything else, and that's how a fetus survives. Getting back to the different types of phenotypes, it's better to classify PPHN into 3 different phenotypes. As many of you are aware, if you assume this to be the normal heart, here is the left atrium, right ventricle, and left ventricle. And typically you have a left to right shunt across the PFO, a left to right shunt across the PDA, and the interventricular septum is bowing towards the right so that the LV is shaped like a circle and the RV is shaped like a crescent. If you have resistance-driven pulmonary hypertension where the pulmonary vascular resistance is high, this is typically what you see in pneumonia or meconium aspiration syndrome, etc. In these conditions, the PVR is high, and for that reason, most of these patients, as long as you inflate their lungs appropriately, are effective, and inhaled nitric oxide is quite effective. So these are conditions where the vascular resistance is high and pulmonary vasodilators are the right approach in this particular condition. The second entity is flow-driven pulmonary hypertension, where, for example, if you have a vein of Galen malformation, there is excessive flow through the pulmonary circuit, and this increased flow causes pulmonary hypertension. And in this condition, if you used a pulmonary vasodilator, this will increase pulmonary flow further, and this is not really very helpful. So that's not the right way to go in this situation. The third condition is where you have post-capillary pulmonary hypertension. This could be due to either pulmonic vein stenosis or due to LV dysfunction, which is fairly common. And in these conditions, the LA pressure is very high. And so causing pulmonary vasodilation with inhaled nitric oxide can increase pulmonary capillary wedge pressure and cause pulmonary edema and cause problems as well. So when you think of the formula for pulmonary arterial pressure, mean pulmonary arterial pressure is equal to pulmonary vascular resistance times cardiac output plus pulmonary capillary wedge pressure. And inhaled nitric oxide and pulmonary vasodilators only work effectively in conditions that increase pulmonary vascular resistance and not so much in conditions that cause increased flow or increased pulmonary capillary wedge pressure. So one of the conditions that typically predisposes to pulmonary hypertension is asphyxia. We see it very commonly throughout the world. And one thing to remember when you go to the delivery room and you bring a baby with severe asphyxia to the NICU is to look for four things. One, what is the severity of asphyxia? Because the more severe the asphyxia is, the further deprived is the lung from blood flow, because as the body wants to maintain blood flow to the brain, the heart, and the adrenals, it does it at the cost of every single other organ, including the pulmonary circulation. The second is how much of resuscitation was needed. If the patient needed chest compressions and epinephrine, especially if the baby got multiple doses of endotracheal epinephrine, that can put the baby at higher risk for pulmonary hypertension because epinephrine is a vasoconstrictor and it does constrict pulmonary vessels quite effectively. The third entity is presence of a predisposing parenchymal lung disease, especially meconium aspiration and pneumonia. If you have predisposing pulmonary parenchymal disease, these babies are at much higher risk for developing pulmonary hypertension following an asphyxial event. So the combination of asphyxia with meconium aspiration is a really deadly combination that can result in high risk of pulmonary hypertension. And finally, when you bring the baby to the NICU from the delivery following birth asphyxia, if the baby is requiring more than 50% of oxygen at the get-go, in the immediate postnatal period, especially before the onset of cooling, these babies are also at high risk for pulmonary hypertension. So keep an eye for these four factors, because if you have these four factors, the risk of PPHN in these babies with perinatal acidosis and distress is very high. Once you bring the baby to the NICU, you should also be very careful about how much oxygen you give these patients. Most often, we are so focused on putting lines and tubes in these babies that we don't pay attention to weaning oxygen or weaning FiO2. Vishal Kapadia in the past has shown that when he looked at the first post-resuscitation blood gas, in other words, you bring the baby to the NICU, you put an umbilical arterial line, and then you pull out a gas and see what the PaO2 is. If this PaO2 is pretty high, then the risk of this baby developing HIE is much, much higher. So remember that whatever is good to the lung, for example, high oxygen, is bad to the brain. And so a combination of perinatal asphyxia with postnatal hyperoxia is not good and can increase the risk of hypoxic ischemic encephalopathy. This is most likely an association and not a causation, but still it's important to make sure that the PaO2 postnatally after you bring these babies to the NICU is not very high and you wean them appropriately and avoid very high levels of oxygen. Same thing applies to carbon dioxide as well. I'm really worried about the period when we cover this baby up and are putting lines, and sometimes the lines take an hour or so. And during these times, it's important to avoid hyperoxia. It's also important to avoid hypocarbia. So they have shown that if a baby spends considerable amount of time with PaCO2 less than 35 millimeters of mercury, the risk of death or disability in these infants at 2 years of age, especially those that were subject to hypothermia, was much higher. So it's very important that having high CO2 levels causes normal perfusion of the brain, but having low CO2 levels tends to cause hypoperfusion. So avoid low PaCO2, especially less than 35 millimeters of mercury corrected for temperature in these babies. Gone are the days when we were managing these patients with very low CO2s. During my fellowship, when we did not have inhaled nitric oxide, we transported babies with CO2s in the teens just to keep them alive, but those days are gone. maintaining a reasonably normal pH and a normal PaCO2 is really important while managing PPHN as well. So the guidelines from the European Association suggest that we maintain PaCO2 between 45 and 50 millimeters of mercury, and that's where we should be. And pH should be above 7.25 with low lactate levels while managing PPHN. So one word of caution for those of you who use a lot of hypothermia. As you know, hypothermia is controversial in various countries. It works really amazingly well in the US, but it does not work so well in India. And so there are various circumstances where hypothermia might work differently. But one thing again to remember is that while hypothermia is very effective for the brain in helping reduce the risk of disability and mortality in patients with HIE, it seems to be associated with a fairly high incidence of ECMO. These are latest data from California, where we observed that among patients that undergo ECMO in California, around 680 patients, the highest association was therapeutic hypothermia. Close to 148 of these patients had therapeutic hypothermia. So when you're subjecting a patient to hypothermia, beware of the fact that low temperature causes pulmonary vasoconstriction, and that's something that's important to know as well. So getting back to the three phenotypes of pulmonary hypertension, let's focus a bit on the phenotype that is resistance driven or with high PVR. And with this, we will go to a case, and Amy will walk us through this patient. Amy, let me know when you wanted me to click.
Okay. So this is a term infant who was born at home with no prenatal care. And they presented to the tertiary NICU from a referral center on day of life 1 with acute hypoxemic respiratory failure that was not responsive to intubation. The patient was on 100% oxygen, and they tried increasing the ventilator settings. So the team got an echo, and it showed, go ahead, that we had a dilated a dilated RV. So you can see there that the RV is much bigger than the LV on the apical 4-chamber. The next picture over is a picture of the septum. So we're seeing a paradoxical intraventricular septum. So the RV is on top, septum in the middle, and then the LV on the bottom. And you can see that the RV is bowing into the LV. So we have that D-shaped left ventricle. Baby was also shown to have a TR jet with an RVSP of 65 plus the right atrial pressure, so markedly elevated. And then when we looked at the pulmonary artery Doppler, looking at the pulmonary or the PVRI, the pulmonary vascular resistance index, we can see it's notched, that flying W. So in summary, click, the baby has acute suprasystemic resistance-mediated pulmonary arterial hypertension, actually in the setting of GBS sepsis.
Thanks, Amy. So as I talked about earlier, when you have resistance-induced pulmonary hypertension, the way to treat these patients is optimal ventilation, recruitment of the lung, and then inhaled nitric oxide. Inhaled nitric oxide, as you know, is a gas that causes pulmonary vasodilation. It has two really important properties. One is that when you use inhaled nitric oxide, it selectively dilates the pulmonary circulation without dilating the systemic circulation. So the risk of systemic hypotension is fairly low with inhaled nitric oxide. So that effect of inhaled nitric oxide is called as the selective effect. The second effect of inhaled nitric oxide is that it only goes to ventilated alveoli and not to non-ventilated alveoli, and so opens up the blood vessels only adjacent to the ventilated alveolus so that ventilation perfusion matching occurs. This is really important, and this effect of inhaled nitric oxide is called as the microselective effect. And for this reason, even when you don't have resistance-driven pulmonary hypertension, you can see a transient increase in oxygenation in babies with hypoxic respiratory failure, including preterm infants with inhaled nitric oxide. And that transient effect is because of improvement of VQ matching. It's also important to realize that since it's not opening up the blood vessels adjacent to a non-ventilated alveolus, if you have diffuse lung disease, for example, as a preterm or with BPD with pulmonary hypertension, using inhaled nitric oxide, while effective in increasing oxygenation, might not be very effective in reducing pulmonary arterial pressure in some of these patients. And this is where drugs such as sildenafil are much more useful. So Just because you see a bit of improvement in PaO2, don't assume that the baby has PPHN, because just increasing BQ matching in patients with parenchymal lung disease without PPHN can be an effect of inhaled nitric oxide. So to the next, it's the same patient, right?
Yeah, so back to our case. So for the reasons that Satyam just described, the clinical team decided to start the baby on inhaled nitric oxide of 20 parts per million and saw an improvement that continued. And over the course of the day, the oxygen was able to be weaned from 100% down to 40%. And because pulmonary blood flow also drives ventilation, the team was also able to wean the ventilator because the baby now had acceptable PCO2s. And a follow-up echo showed that we now have normal biventricular function. You can see the RV is no longer dilated. And then with the next image over, when we're looking at the septum, no longer is it paradoxical. When you slow it down, it is still a little bit flat, so mildly flat, but markedly improved from before. Our RVSP has dropped from the 60s down to the mid-30s, so a drastic improvement. And our PVRI is no longer notched, and it's now normal because it's less than 4. So we had a very good improvement and a good echo and clinical response to treating this resistance-mediated pulmonary hypertension with inhaled nitric oxide.
Very nice images, Amy. Do you want to briefly talk about the eccentricity index here?
So with neonatal hemodynamics and with targeted neonatal echo, rather than using subjective markers of what the intraventricular septum looks like, we'll actually measure the systolic eccentricity index to see just how flat the septum is. So at the end of systole, we will measure perpendicular to the septum and parallel to the septum, and then that ratio tells us what the eccentricity index is. So more than 1.3 is considered abnormal, that it's flat, but less than 1.3 would be normal, so no evidence of pulmonary hypertension. So it's a way to objectively assess what the pulmonary pressures are, especially when you don't have other signs like a TR jet or a bidirectional or a PDA.
Great, really nice images, Amy. Thank you. So once you give inhaled nitric oxide, Amy showed us really nice images on how a good response might look like. And a response can also be defined as an increase in PaO2 or SpO2, both preductal and postductal. Many times you see postductal go up first and then the preductal starts going up. That's because of the reversal of the ductal shunt. The second improvement you see is reduction in inhaled nitric oxide. As we saw in this patient, FiO2 came down from 100% to around 40%, and that decrease in FiO2 is also a really good mark of improvement in these patients. And finally, increase in SpO2 to FiO2 ratio or PaO2 to FiO2 ratio is also seen in many of these patients. And then the really important thing to notice is that these changes are not transient and that they are sustained. And there should also be hemodynamic improvement. If you see slight improvement in oxygenation without change in echocardiography changes, that's not good. So you should see a sustained improvement in oxygenation associated with hemodynamic improvement, and that could be considered as an effective response to inhaled nitric oxide. And of course, our whole goal is to improve survival and reduce the need for ECMO in these patients. So if inhaled nitric oxide does not work, what do we do next? And here are some common reasons as to why inhaled nitric oxide does not work. Number one, the most important cause is that when you give inhaled nitric oxide, it has to go into the alveolus, reach the alveolus, and then reach the pulmonary arteriole. If it's not reaching the pulmonary arteriole, for example, if the lung is completely collapsed, and if you haven't recruited the lung, the nitric oxide does not reach the target organ. And for this reason, lung recruitment with optimal mean airway pressure and use of surfactant before the use of inhaled nitric oxide, especially when there is parenchymal lung disease, is really important. And we will talk about hemodynamic optimization in the subsequent portion of the talk. You already heard about management of systemic blood pressure. That's really important while managing PPHN as well, and we will briefly address this. In some cases, there is biochemical inactivation of inhaled nitric oxide with superoxide anions, and in these patients, there might be a role for medications such as sildenafil or riociguat, which is a selective activator of soluble guanyl cyclase that's being looked into in experimental situations in babies with PPHN. But there are some patients where instead of having nice pliable pulmonary arteries, the pulmonary arteries are like plastic tubes that don't really respond at all. And these patients have fixed resistance, and no matter how much of inhaled nitric oxide you use, these patients may not work, and that might require further investigation. There are some conditions such as alveolar-capillary dysplasia that you can diagnose by genetic testing or by a lung biopsy, where you don't see a response to inhaled nitric oxide, or you don't see a sustained response to inhaled nitric oxide as well. So let's focus on each of these topics. So as I previously mentioned, if you have a graph X-ray like this, where the lung is not open at all, blindly using inhaled nitric oxide in this particular situation will not take the inhaled nitric oxide to the target organ. It doesn't even get to the alveolus. So opening up the lung first with either increased PEEP or increased mean airway pressure, or with the use of surfactant is really important. And a really nice study by Dr. Gonzalez and colleagues in Chile showed the importance of using surfactant in these situations. What happens if you don't use surfactant or adequate recruitment is that we have heterogeneous lung disease. You have some over-distended alveoli and some collapsed alveoli. And when you used inhaled nitric oxide in this situation, inhaled nitric oxide cannot go into this collapsed alveolus, so all these blood vessels remain constricted. Inhaled nitric oxide goes to the distended alveolus and tries to open up these vessels, but since the alveolus is already so distended, it starts compressing on adjacent pulmonary vessels and limits the ability to increase pulmonary vasodilation, and for that reason, the PVR tends to remain high. On the other hand, if you use optimal PEEP, recruit the lung, and then give some surfactant, then there is much more uniform opening up of alveoli, and you see much better response to inhaled nitric oxide with vasodilation throughout the lung. And this was clearly shown in this cohort of patients where OIs were pretty high in these patients. Half of these patients got randomized to receiving surfactant followed by inhaled nitric oxide. And in those patients, the oxygenation index dropped very effectively. In those patients that did not get inhaled nitric surfactant and just received inhaled nitric oxide, there was response, but the degree of drop in OI was not as dramatic. So if you have a baby with any kind of parenchymal lung disease, it's really prudent to use inhaled nitric oxide surfactant first and then use inhaled nitric oxide. There are exceptions to this rule, especially congenital diaphragmatic hernia. If you don't have evidence of RDS, there is no point in using surfactant. And there are some retrospective studies that show that use of surfactant may not be good in CDH. So, especially in meconium aspiration syndrome and pneumonia, consider more frequent administration of surfactant with prior tracheal suctioning. And you don't have to really wait for 6 hours after you give surfactant. After 2 or 3 hours, you can lavage and suction out, because that helps you get many chunks of meconium out from deeper portions of the lung. And then you can repeat a dose of surfactant. So surfactant is not only effective for improving lung function and opening up the lungs, but also might be effective in lavaging and removing meconium from these patients. So another patient here, a preterm infant who was on 81% oxygen on very high settings, and there was a really nasty mucus plug here blocking this whole lung, and giving inhaled nitric oxide really didn't make a difference. Once some suction was done with some surfactant, etc., and the lung was opened up, then the baby's oxygen came down from 81% to 41%. The baby did much better. So opening up the lung is the crucial first step while managing patients with PPHN. Next, let's talk briefly about oxygen. My goal while managing these patients is to maintain a preductal SAT of around 90 to 97% and a postductal SAT of at least around 80 to 85%. These numbers are slightly higher than what you see in many recommendations, but I feel that these numbers really reflect what happens in term infants and reduces the need for further therapy. The reason why we focus on preductal oxygen is because throughout fetal life, the really important organs in the body, the brain, the heart, they receive preductal blood flow. And for this reason, it's important to focus on preductal blood flow. And as long as your lactate is normal, and if the urine output is adequate, these numbers really work. On the other hand, if your lactate is going up and you have oliguria, and if you're monitoring NIRS to monitor regional saturation, if these numbers are dropping, then obviously these saturation guidelines are not adequate, and you should improve perfusion check echocardiography and increase oxygenation of the tissue in these circumstances. So for many years, we have been using very high FiO2s while managing these patients, as not only during resuscitation, but also in postnatal management. And that was leading to a big disaster. And one of our legends of neonatology, Dr. Ola Saugstad, really helped us understand this by using more of room air for resuscitation and being much more judicious in the use of oxygenation. That has steered us away from the iceberg of hyperoxia and has improved our outcomes. So loving oxygen is great, but giving too much oxygen may not be beneficial in babies with PPHN. And the optimal range of 90 to 97% is mainly from animal studies, which show that using preductal pulse oximeter in this range results in low PVR in different models of PPHN, as shown in this particular graph. Unfortunately, there is not a single study evaluating optimal oxygen saturations in babies with PPHN. We are doing a couple of studies now, but the results will take 2 or 3 years for them to come. But in the meantime, using animal data, stats between 90 to 97 are probably adequate. So why can't we just use 100% O2 in many of these patients? The main problem here is that the moment you use 100% oxygen, you increase oxidative stress. These are pulmonary arteries from lambs that have been ventilated with either 21% oxygen or 100% oxygen just for a period of 30 minutes. Within 30 minutes, there is so much of oxidative stress damage to the lung that you see that the PA lights up. All the red stain that you see here is superoxide anions. You can see the PA lights up with superoxide anions, and it's not really good for these patients. So the guidelines recommend that in term or preterm newborn, they recommend the use of, recommend preductal sats between 91 to 95%. It's very difficult to maintain SpO2 in such a narrow range. And for that reason, I tend to use a slightly wide range between 90 and 97%. It's also important to realize that one number doesn't fit all patients. Professor Rudolph, many, many years ago, more than 60 years ago, has shown us that if the pH is lower, you need much higher O2. The change point when pulmonary vascular resistance goes up changes. And for this reason, when you have acidosis or hypothermia, or when the FiO2 is low, in these situations, it's better to target slightly higher numbers, maybe 92 or 93 to 98%. And that might be beneficial in these babies. And acidosis is a big deal. If you have a pH that's less than 725, these babies are at much higher risk for hypoxic pulmonary vasoconstriction, and you should try to avoid it. The second issue is hypothermia. And what we know from the hemoglobin oxygen dissociation curve is that when you cool patients, the low temperature shifts the hemoglobin oxygen dissociation curve to the left. And in these patients, maintaining a slightly higher SpO2 is important. For example, if you are targeting a PaO2 of 50 to 75 millimeters of mercury, then maintaining SpO2 in the low 90s is adequate when you have normothermia. But when you have hypothermia, you need slightly higher saturation targets. So hypothermia shifts the oxygen hemoglobin dissociation curve to the left. And for this reason, maintaining SpO2 slightly in the mid to high 90s is really important during this particular instance. And having saturation range between 90 to 98% is helpful in this particular instance. So to summarize the use of oxygen, typically in a baby with PPHN, you tend to maintain sats between 90 and 97. In a baby with hypothermia, acidosis, and in some cases with dark skin pigmentation, which is something we come across a lot, in these instances, you may need to target slightly higher numbers. And in those instances, you tend to look at more for around 92 to 98% in these patients. And I won't talk about preterm shown in this figure. It's important to remember that any patient who is on supplemental oxygen, it's prudent to avoid 100% oxygen sats because you never know what the PaO2 is in this situation. So individualized or precision medicine-based approach is needed for patients while maintaining SpO2. You can't really come up with one guideline for all patients. Each patient is unique and each patient is different. So moving along, let's next focus on hemodynamic optimization in patients with PPHN. And I am not an echocardiographer, and Amy, Yogan, and everybody is coming up with more and more guidelines and more new things for us to do. So here is, as a simpleton who can't understand these things, I've come up with some simple rules. I call it the rule of 3 for echo changes in PPHN. So as we were talking about earlier, One thing here is looking at the tricuspid regurgitation velocity, and here it's anything above 36 millimeters of mercury plus the right atrial pressure is considered abnormal. So this is based on the formula delta P is equal to 4V square, the modified Bernoulli equation. So in other words, if the velocity of tricuspid regurgitation jet exceeds 3 meters per second, then you should be really cautious in these babies, and that's one of the three. The second is if the right to left shunt across the PDA lasts more than 30% of the cardiac cycle, that's not normal either. Amy talked earlier about the eccentricity index during systole. This is basically the fact that normally the left ventricle should be like a circle and the right ventricle should be like a crescent. So the AP and cross-sectional diameter of the LV should be roughly 1. This is what Amy was talking about earlier. On the other hand, if the LV is squished because of the RV pressure and the septal deviation, and if this measurement is more than 1.3, then this is abnormal and indicates pulmonary hypertension. And we will talk more about the pulmonary arterial acceleration time and the right ventricular ejection time. So if the pulmonary arterial acceleration time is less than 90 milliseconds, or if the PAAT by RV-ET ratio is less than a third, these are all signs that things are not going well. And we'll also address TAPC in subsequent slides, which is the annular motion of the tricuspid valve. If that number is less than 9 millimeters, that's an abnormal sign, especially if it goes below 6 or less than 3, that indicates moderate to severe pulmonary hypertension. So for people like me who can't really understand everything in echocardiography, there's a simple rule of 3 for you to remember some numbers. Okay, back to Amy with a new case.
That was a great slide to really break it all down. So another case, very similar presentation, term infant with hypoxemic respiratory failure, and the clinical team was concerned for acute pulmonary hypertension. They performed a cardiac Pocus, and again, we see on an apical floor chamber on the left there that the right atrium in particular is very dilated. You can see the septum is bowing over into the LA. The RV is also dilated. When we're looking at the intraventricular septum, again, in the middle, it's flat with the RV kind of bowing into the LV there again. Because it's cardiac Pocus, we don't have a systolic eccentricity index though. And then we looked at the aortic arch, and you can see in the middle that we have a large PDA that when they Dopplered it was mostly right to left. And so the clinical team was concerned that this baby has acute pulmonary hypertension. So you can click, they started the baby on inhaled nitric oxide. Unfortunately, we click one more time, the baby actually got worse after the team started inhaled nitric oxide with clinical decompensation, worsening oxygenation, decreased perfusion, and worsening lactic acidosis. So what's going on in this case? Go ahead, click.
So this is a case where inhaled nitric oxide was used and the patient did not have resistance-driven pulmonary hypertension, but something else was going on. So we will let Amy explain what happened here.
So actually in this case, this baby has a vein of Galen or an AVM with flow-induced pulmonary hypertension. And so some evidence of that when the team got a cardiac echo instead of getting a cardiac Pocus, so more detailed assessment, is that there was actually flow reversal throughout the entire arch. So you can see there that there's a lot of red. That should all be blue. And then it has a really large brachiocephalic trunk. That first branch off the aorta is actually bigger than the aorta. So that was the first clue that this was not your typical straightforward pulmonary hypertension. And then other clues on echoes for babies who have flow mediated due to like large AVMs, in particular brain AVMs, is when we look at the SVC flow, that there's really robust SVC flow. And so that all kind of leads us to think that this baby had a vein of Galen malformation. So if you want to go ahead and click to the next slide. This was confirmed with a head ultrasound, and you can see through that sweep that large conglomeration of blood vessels. So vein of Galen's who have flow-induced pulmonary hypertension are really tricky to manage. They have various different phenotypes. And in this case, this baby had a pseudocoarctation physiology. So because of that really low resistant circuit in the brain, blood was getting sucked back up from the aorta. And so we were dependent on a right to left shunt at the PDA in order to provide systemic blood flow. So when we started inhaled nitric oxide and we decreased our pulmonary pressures, we then had an increased left to right shunt at the PDA. So we weren't able to perfuse the rest of the body. And we were just sending more blood to the lungs, which was not our problem. So in this case, the infant, we stopped inhaled nitric oxide, started low dose PGE because we didn't want that PDA to close since we were dependent on ductal patency to promote that right to left shunt at the ductus in order to perfuse the rest of the body.
Very nice images again, Yumi. Very nice case as well. This happens once in a while, but when it happens, you look really bad because the cardiologist comes in, puts a stethoscope on the baby's head, and then listens to a bruit. And many times they've already done the echo. They won't tell us what the echo shows and then act as though they're hearing the bruit for the first time and make you look bad. So be careful about these patients. So this is a totally different case. So this is an important thing for you to remember when baby is not responding to nitric oxide. Look at other areas, examine the baby as a whole as well.
So another kind of similar case you're noticing is they're all fairly similar presentations. This baby, though, in addition to the hypoxemic respiratory failure, also was noted to have systemic hypertension. And the baby ended up being intubated and really didn't get better with intubation. Because they weren't able to get an echo right away, they started the baby on 20 parts of inhaled nitric oxide because they were worried the baby had acute resistance-mediated pulmonary hypertension. And again, we actually had a clinical worsening. We had acute lactic acidosis and actually worsening in our oxygenation. So then the team was able to obtain an echo. And this time, rather than it being a right heart problem, we actually have a left heart problem. So you can see on that apical floor chamber, that left ventricle is not moving whatsoever. One of the tricks I always do when you're trying to look at this is if you cover up the right side of the heart and look and see, is the left side moving and vice versa? Because what can happen is the ventricle that's working can kind of be pulling. And so it can sometimes you get fooled. So if you isolate one ventricle to the other, you can really see that the LV is not moving whatsoever. Same thing we see in the levels, that LV it's just the septum that's moving there. We actually did advanced measurements. So some other measurements other than just doing ejection fraction, we can look at the strain. And so we're looking to see how much the muscle is moving. And actually the more negative number, the better. So negative 20% is normal. So this baby had abnormal strains of -10, which is getting into the moderate to severe dysfunction based on advanced measurements. And the baby has a large bidirectional PDA. So in this case, if you want to click, we have severe left ventricular dysfunction with a large bidirectional PDA that once again is supplying our systemic circulation.
Nice images again. So in this particular case, we are talking about this scenario where you have high pulmonary capillary wedge pressure. And for that reason, you see dysfunction in this patient. And here is the next, same case.
Yep. Same case. So what did we do to treat this? So because this baby had left ventricular dysfunction and we were systemically hypertensive, so we were worried that that increased afterload to the LV was actually worsening our LV function, we chose to start the baby on milrinone, which we'll talk about very soon. And so we started initially on a lower dose of milrinone, and then that was gradually escalated up after making sure that we had adequate kidney function. And again, we saw a clinical improvement. We also stopped the nitric. I should mention that. The nitric was stopped. But we had a clinical improvement. We were now normotensive, no longer hypertensive. Oxygenation improved, and you can see that that heart looks much happier. Both ventricles are moving nicely, and we had normal biventricular function.
A great point here is after ensuring adequate kidney function, because milrinone is secreted by the kidneys, so renal dysfunction is a big problem here. So what is happening in this particular situation? In fact, we had a baby with very similar features. And I went ahead and gave inhaled nitric oxide to the kid, and the baby literally crashed. So the issue here, as Amy was pointing out, is that you have significant LV dysfunction. This is an upside down heart, right atrium, left atrium, right ventricle, left ventricle. And here there was significant LV dysfunction in this patient. As it turned out, this was a patient with herpes simplex infection with LV dysfunction and had a bit of pleural effusion as well. And because of LV dysfunction, there is high elevated left atrial pressure in these patients. And that in turn results in a left to right shunt across the PFO, although there is a right to left shunt across the PDA. This results in pulmonary venous hypertension and pulmonary edema. And in this case, if you open up the faucet and pour more blood by using inhaled nitric oxide, one, you cause worsening pulmonary edema, as Amy was mentioning, resulting in worsening oxygenation. The second thing is that the systemic circulation here is ductal dependent. This portion of the lower half of the body is highly dependent on this right to left shunt across the PDA. And if you reduce pulmonary vascular resistance with inhaled nitric oxide and stop this shunt, this part will become hypoxemic and start developing lactic acidosis. And so it's a double fold in change here, and we should be careful with that. And the other thing to remember, shown from Amy and her colleagues in Iowa, is that one of the common effects of milrinone is systemic hypotension. And in babies with HIE, especially if their renal function is not good, there is a much higher risk of systemic hypotension with milrinone compared to babies with normal renal function. For example, in this particular cohort, babies that developed hypotension had a creatinine of 1.18, whereas the normal babies had a normal creatinine. So having a high creatinine, you should be really careful when you use milrinone. And if you have to use it, use fairly low doses, because we really can't monitor levels of milrinone in these patients. So moving along, so this was a case of resistance-induced pulmonary hypertension where LV dysfunction was present, and we will go to the next case.
So the next case, a little bit different though. Former 25-week premature infant, history of a hemodynamically significant PDA. He's corrected now to 42 weeks post-menstrual age, but unfortunately has severe BPD. The team's noticed he's had a gradual worsening of oxygenation and ventilation that's really been unresponsive to ventilator changes or steroids. Cardiology did an echo and showed that the intraventricular septum was flat. So the team decided to try sildenafil, and they think the baby actually got worse with sildenafil. So what's going on here? When we looked a little bit further, because it's odd, baby not getting better with sildenafil when we thought we had resistance-mediated pulmonary hypertension, we can see that this intraventricular septum is flat. So a systolic eccentricity index of 1.44, so abnormal because it's more than 1.3. But when we look a little further and we assess the pulmonary veins, we actually saw that there was increased flow velocity in the left upper pulmonary vein and had a peak gradient in that vein of around 3 meters per second. So this baby, if we click, has left upper pulmonary vein stenosis that's leading to that flat septum. So they don't have pulmonary arterial hypertension. They will get worse with sildenafil. So this baby ended up undergoing a diagnostic and therapeutic intervention in the cath lab, and they stented the left upper pulmonary vein. And after that, the baby's oxygenation and ventilation were able to improve.
Really great case, Amy. So sometimes you can diagnose this with echo, and you may need to take the patient for a cath, but that's both diagnostic and therapeutic in cases. Some of these patients require other therapies as well. Okay. So moving along, let's talk about how to optimize using medications. Sildenafil is a very common drug that's used everywhere. All of us use it quite a bit, and as Amy was pointing out earlier, in some cases it works, some cases it doesn't. But it's a very effective drug. It acts by blocking PDE5, and so there are studies where IV sildenafil has been shown to reduce oxygenation index quite effectively. But the risk of systemic hypertension is pretty high with sildenafil, especially if there is associated sepsis or something else is going on. So you should be really careful. This table shows you the various doses that you can use both for IV and also oral sildenafil. We will talk about a slightly different approach here. One thing to remember is that the right ventricle is a very sensitive organ, as we were talking earlier. It doesn't deal very well with high afterload. Initially, when the afterload starts going up with the right ventricle tries to adapt hypertrophy and pump more. And that approach is called as where there is coupling. In other words, if the PA pressure goes up, the RV pressure also goes up and the function of the RV enhances. And that's the homeometric adaptation that you see with the right ventricle. But when things start getting really bad, if the right ventricular afterload increases quite a bit, and the nice pop-off that you see with the PDA starts narrowing, in these situations, the RV starts to dilate and fail and becomes dysfunctional. And this is called uncoupling or heterotopic maladaptation. And we'll talk about as to how to manage these patients next. And as Dr. Mohit Sani was mentioning previously, the ventricles are very sensitive organs, especially in babies, and they can't really deal with very high pressure, especially the right ventricle. So when the afterload is very high on the right ventricular side, reducing the afterload and reducing right ventricular stress should be the main focus of management in these patients. Back to another case to illustrate this point.
So term infant who, as we spoke about earlier, has meconium aspiration syndrome. So is a setup for resistance-mediated pulmonary hypertension. Really had minimal response to inhaled nitric oxide despite trying to optimize the lungs. Still on 100% oxygen. Our saturations our pre-ductal saturations are well below our targets, so they're in the low 80s, and we're having hemodynamic instability. We have a combined systolic and diastolic hypotension. The team is trying to treat that with an epinephrine drip that's at 0.08 mics per kilo per minute. And so an echo was performed, and what we saw was that we have an uncoupled RV. It's dilated. It's massively dilated when compared to the LV over there. We also have dysfunction. So that TAPSE that we talked about earlier is around 5.6. Normal for a term baby, like we mentioned earlier, that rule of 3 times 3 should be around 9. So it's markedly decreased. And we see in the middle, we have what is now becoming a restrictive PDA. You can see that little narrowing there and that flow acceleration with that PDA coming in. So while it's still bidirectional and still present, it's starting to restrict and get smaller. So in summary, we have severe pulmonary arterial hypertension with dysfunctional and dilated RV that's uncoupled in the setting of a restrictive PDA. So what should we do? So we started prostaglandins in order to open the ductus. We need that pop-off back for that RV to not have to pump against such high pressures. And hopefully when we open that PDA back up, we're going to reverse that RV uncoupling. And so the RV is going to be able to function better. In addition, though, we have combined systolic and diastolic hypotension that's not better just on epinephrine. So we need to start a medication. We choose, and we'll hear why soon, vasopressin in order to support coronary artery perfusion pressure so that both the RV and the LV can actually function and pump better.
Great case. Going along.
So with those therapies, we started prostaglandins, vasopressin. We still have on nitric, still on the epi. But we still have high oxygen requirements, but we are having an improvement. We're now normotensive. And the repeat echo shows that we're having improved RV function. Is not as dilated anymore. Sorry, I don't know why they're not working. You can see our TAPSE there in the middle, or with the red and blue, is normal now, so it's above 9. And we have a large PDA that is no longer restrictive. But we still have evidence of pulmonary arterial hypertension because we have a TR jet that's in the 70s. You might ask, why did we not have a TR jet earlier? When you have a really dysfunctional and dilated RV, you might not see a elevated TR jet because there's just not as much forward blood flow in that RV. So we still have continued severe pulmonary arterial hypertension, but now normal biventricular function in the setting of a large bidirectional PDA. So how do we further treat our pulmonary hypertension? Since we now have adequate blood pressures, we chose to start milrinone, low dose again, ensuring good kidney function, and then escalated up as able in order to continue to treat our pulmonary arterial hypertension. So this approach we like to term the MVP approach. And really the first time I ever heard anyone mention this approach was Dr. Reagan Giesinger. And so combination of milrinone plus vasopressin plus prostaglandins using to treat babies who have a dilated dysfunctional RV with a restrictive PDA and continued severe pulmonary arterial hypertension. So in this case, this combination of therapies, we are able to have normal biventricular function, RV is no longer dilated, we have no evidence of pulmonary hypertension on our echo, and our PDA is now unrestricted and pulsatile left to right.
So Regan, who many of us heard earlier, she really promoted this MVP approach, which is quite effective in some of these patients. So just to summarize what Amy was talking about, if you have very high afterload and there is poor RV function, you tend to develop this uncoupling, and especially with the closing ductors. So in these situations, you use PGE1 to open up the ductors, reduce RV afterload, you use inhaled nitric oxide, of course, and then you use milrinone to improve the function of the right ventricle, and then you add a selective systemic vasoconstrictor such as vasopressin. So this is the MVP approach that we use here. And one thing to remember with PGE1 is that you need to know when you want to stop. So when you're using this MVP approach, you should be cautious as to when you stop prostaglandin infusion. So let me walk you through this. When do you start PGE1? As Amy said, start PGE1 to reduce RV afterload with suprasystemic pulmonary hypertension. So if you have a baby like this, you have a dilated RV, you have a restrictive ductus, which is shunting right to left. You have evidence of systemic hypoperfusion. So this is a baby with a restrictive PDA with a high RV afterload, where you have systemic hypoperfusion due to LV dysfunction and low LV preload because the RV is compressing on the LV. There is not much blood that can go into the LV. And with this combination, you start PGE1. And once you start PGE1, the response you expect is like this. The PDA gets opened up, the RV afterload comes down, and the systemic perfusion increases. So here you see improved PDA opening, the RV afterload is lower, and then there is more blood going to the lower half of the body. Remember, even blue blood is better than no blood. And so getting some perfusion is really important, and that's what this right to left shunt does. It's also important to remember as to when you stop PGE1, but because once you start shunting left to right, and the lung improves, in these conditions, you should no longer continue PGE1 because at this particular instance, having a high left to right shunt tends to cause systemic steal. And so once the shunt becomes left to right and the baby starts improving, it's important to wean PGE1 because if you don't wean PGE1, you tend to cause ductal steal and systemic hypoperfusion. So once the preductal postductal SAT difference goes away and the echo shows a predominantly left to right shunt across the ductors, you should wean down PGE1. You can probably leave a bit for maintenance just to keep the ductors open, but you don't use very high doses of PGE1 at that instance. Okay, so I really don't want to get into blood pressure management since we already talked about it, except that we really hate using dopamine in PPHN, and I'm sure we'll discuss it. I'm glad Yogan is staying back to help us out with this discussion. And well, I will just show you one slide just to emphasize this fact. This is a study that we did in lambs, not human patients. So in control normal lambs, if you use high doses of dopamine, what you see is that there is a little bit of elevation of pulmonary arterial pressure, but a nice huge elevation in systemic blood pressure. This is what you want to see with dopamine. And see how much difference the pulmonary arterial pressure is from the systemic blood pressure. The pulmonary arterial pressure is really low, systemic pressure is fairly high. And so you have this nice differential in normal patients. But we are not dealing with normal patients here. In PPHN, the problem is that the systemic blood pressures are low and the pulmonary arterial pressures are high. There's not a huge difference between these two. And what's even more interesting is that these remodeled pulmonary arteries also constrict in response to dopamine. So every increase in dopamine, not only does the systemic pressure go up, but the pulmonary pressure also goes up. So if you're using dopamine, it's really important to do frequent echoes on these patients or avoid dopamine altogether. So again, in PPHN, try not to use dopamine. So my general rule here is if you have systemic hypertension in PPHN, check the blood pressure, check the cardiac function. If both are normal, you have normal cardiac function and normal blood pressure, then you typically use inhaled nitric oxide, sildenafil, or whatever you want to use. If you have a low blood pressure or normal cardiac function, then you can use selective vasopressors such as norepinephrine or vasopressin. If you have poor cardiac function and normal blood pressure, you use milrinone with inhaled nitric oxide, as we showed you earlier. This is a bad combination when you have low blood pressure and poor cardiac function. In these cases, we prefer to use epinephrine because it's a much more inotropic agent. And in some of these cases, you may have to use hydrocortisone as well. So vasopressin is a drug that we are starting to use more often, as we showed in the previous case. There's a wide range of dose for this one. It's helpful in refractory pulmonary hypertension and systemic hypotension. However, we don't have a lot of literature on this. Two things to remember: it can cause hyponatremia and it can cause mesenteric hypoperfusion. And one should be careful about feeding in these circumstances. And so monitor urine output, monitor serum sodium levels. Recently, a paper came out from Chile again, where they looked at selective improvement in systemic arterial pressure with vasopressin, with a reduction in vasoactive inotropic score, and improvement in urine output because the blood pressure is getting better, and so the kidney is able to perfuse better, and a decrease in oxygenation index with the use of vasopressin. So it's a fairly useful drug in select circumstances. I want to briefly end by talking about hydrocortisone. Many of us use hydrocortisone in such situations, but be careful that you rule out all infections. I recently had a case that I showed you earlier of herpes simplex, where without knowing, we use a fairly high dose steroid. It's not really good. So occult fungal and viral infection should also be ruled out before you start using hydrocortisone. So hydrocortisone is an effective drug, but you should be careful when you use it. So to conclude, what would a fetus do with PPHN? Avoid hyperoxemia. Blue blood is better than no blood. Cyanosis with good perfusion is better than ischemia. Maintain ductal patency if the RV is suprasystemic. Avoid high systemic blood pressures. And your therapy should be based on hemodynamic physiology and echo findings. So having a trained person in echo helping you out with management is always very beneficial. And here is a simple algorithm that I use. You start off with hypoxemic respiratory failure. First, recruit the lung. Without recruiting the lung, nothing happens. So recruit the lung first, and then check your blood pressure and echocardiography. If there is evidence of pulmonary hypertension, typically we start off with inhaled nitric oxide, but make sure that there is no primary or severe LV dysfunction. Once you use inhaled nitric oxide, I typically use a small dose of hydrocortisone as long as there is no evidence of infection. And if you have systemic improvement, great, you're all set. If you don't have a good response, again, rule out LV dysfunction. If you have LV dysfunction, look at the blood pressure and consider using the drugs that we talked about. Look at RV function as well. If the RV function, there's no RV dysfunction, you can either use sildenafil or PGE1. If the blood pressure is low, consider using hydrocortisone with norepinephrine or vasopressin. If you have dysfunction, then the drugs to use are milrinone and PGE1. And if you have low blood pressure, consider using epinephrine or a combination of drugs. If nothing works, obviously you should be prepared for ECMO. So I will end by suggesting what Mohit was saying earlier. Babies don't read physiology textbooks. They do what they want to do. And especially preemies are aliens. They don't follow any principles of physiology. So we should be really careful while managing these patients. And every patient is unique, and close observation, listening to all your colleagues, especially nurses, is a really critical part of management. We will stop here. Sorry, we took a little longer, and we will discuss cases after the next talk. And if Dr. Yogan Singh can join us for the discussion later on, that would be great if he's still awake. I'm sure he woke up really early in the morning.
Thank you, Satan. I'm very much here. Great talk. Really enjoyed. I'll wait for the discussion.
That was an absolutely fantastic talk covering, PPHN and the kind of term neonate with the different phenotypes. We're going to now move on to the next talk, and it gives me great pleasure to introduce Dr. Nehamal Soni. We go long back. He is my senior. I've learned a lot from him, but most importantly, he's a consultant who's extremely humble and currently works as a senior consultant in Sidra. He has a special interest in delivery of simulation as well as management of the difficult neonatal airway. Has done a lot of work in neonatal education, in the UK. He's going to talk to us today about BPD-associated pulmonary hypertension. So we want to look at the other end of the spectrum. Thank you, sir.
Is there a pointer or slide? Thank you. Thank you, Dr. Rupali, Dr. Monica, and the other organizing team members, Mohit and Kiran and others. This is the last talk of the day. Now, when we go to any T20 cricket match, and when you see the opening batsmen like Rohit Sharma or Virat Kohli batting like Professor Satyan, it's very difficult when somebody like me, like Rahul Dravid, comes and try and bat. It's not fair, but I'll try my best what I can do out of it. Professor Samir and Professor Satyan covered some aspect of the BPD aspects, which will make my things easier because I may exceed the time by 5 minutes because it was too big a topic to be covered in 15 minutes. I'll try my best. So BPD, bronchopulmonary dysplasia, evolution over the last 50 years, is basically a heterogeneous developmental chronic lung disease which continues to develop. And it has got a major cardiopulmonary complications in the surviving preterm infants. Now, we have been missing, in the afternoon section of this conference, we are missing somebody. Okay, do you know who is being missing? Dr. Shorab, with various dates and things. So I thought I'll put one next to it with variety of dates. So BPD's evolution has moved over and with a variety of some landmark things that the very first described in 1967 by Northway et al. And that classification was based on radiological and pathological evidence of the disease. Subsequently, in 1988, 2001, and 2019, various different classifications have evolved based on the needing of the oxygen at 36 weeks or 28 days and 36 weeks, or of late based on the respiratory support, because babies may not need oxygen, but they are still dependent on the respiratory support. We will just focus on the last current definition. There's no point going back. So the current definition of classification of the BPD is based on Jensen's classification. And they have divided into 3 categories: mild, moderate, and severe, which is based on the amount of respiratory support they need. So either is a nasal cannula oxygen, which is a low flow nasal cannula less than 2 liters. That's the mild. If it's a moderate, it's either a high flow nasal cannula oxygen more than 2 liters, or if they are needing any non-invasive positive pressure support, irrespective of the amount of oxygen they need. So even if they are on, say, high flow oxygen of 4 liters, but in 21% oxygen, that is still classified as a moderate BPD. And the severe BPD is something the baby is still dependent on the mechanical respiratory support at 36 weeks. Now, the current trend is everything is being given phenotypes of different diseases. So is for the BPD. BPD is not a disease of just lungs kind of thing. It has got a combination of it. It's a disease of the parenchymal lung, the airway disease, pulmonary vascular disease, which is developing. It's a combination of all. So we need to discuss the different aspects of it and how that evolves. This is from Professor Satyan's paper, very nicely described here, that the BPD and the pulmonary hypertension pathophysiology has got not just the 3 components, but including the effect the heart disease has on the heart. So where in the airway disease, you have got these babies are prone for reflux, obstructive apneas, tracheobronchomalicias, subglottic stenosis because long-term ventilated, and the reactivity of the small airways. They contribute to the lung disease. In the lung disease, obviously, they are more ventilated, more respiratory support. They develop a variety of hyperinflation, atelectasis, high resistance, and they go through a variety of episodes of the hyperoxia and hypoxemia, which leads to the lung disease. The pulmonary vascular disease, obviously, because the baby's pulmonary vascular disease can develop as high as in the first 2 weeks of age. The remodeling of the vessels lead to the high tone and reactivity, and that further leads to the hypertensive modeling. And in fact, what Samir described about the remodeling leading to the proliferative changes, which can subsequently cause the pulmonary venous stenosis as well. And the effect all these have on the heart in form of a right ventricular dysfunction, left ventricular dysfunction, and what about the PDAs which do not close and which continues to remain, or the patients who have got ASDs, what impact it has. Because if the lung has not, it's a very preterm babies we're talking about, the lung has not grown, there have been the arrest and the development of the alveoli, and you've got more blood flow going through the high flow, these shunts, and that causes the development of the pulmonary hypertension disease as well. So again, when Professor Satyan has very nicely described in his paper about the pathophysiology leading to the pulmonary vascular disease, with variety of risk factors in the prenatal problems, what happens prenatally, any genetic factors associated, antenatal various stress factors, postnatal injury which happens in these babies based on the long ventilation, intermittent hypoxia, the effects of them. And that eventually leads to the developing lung circulation problem, leading to the abnormal structure, abnormal cardiac function, and the decreased growth of the decreased growth of the alveoli gets affected because of that as well. So having gone into very briefly about the pathophysiology, I just need to say what is the current definition of the pulmonary hypertension. We talk about pulmonary hypertension, but what is the pulmonary hypertension current definition? So in the 2018 World Symposium on Pulmonary Hypertension and the 2019 European Pediatric Pulmonary Vascular Disease Network, they came up with the definition, which was summarized very vividly in the 2022 publication of the European Society of Cardiology and the European Respiratory Society. And they defined the pulmonary hypertension as the more than 20 millimeters of mean pulmonary artery pressure. So pulmonary hypertension classification here is 5 different types, clinical classifications. So pulmonary arterial hypertension, pulmonary hypertension associated with the left heart disease, the pulmonary hypertension associated with the lung disease, pulmonary hypertension associated with pulmonary artery obstructions, and the pulmonary hypertension with unclear or multifactorial mechanisms. Hemodynamic definition is based on the 3 different types: the pre-capillary, the classical acute pulmonary hypertension, what we see; the isolated post-capillary, which is the pulmonary venous hypertension, which may see because of the pulmonary venous stenosis or the decreased left heart function, or a combination of the both, which might be seen in a condition like the BPD. Among the one which is the pulmonary hypertension associated with lung disease, there are a variety of lung diseases, and one of them is the developmental lung disorders. And within that comes the pulmonary BPD dysplasia. This is how where the BPD fits into the pulmonary hypertension classification. So why are we worried about it? Why are we worried about the BPD associated pulmonary hypertension? What is the magnitude of the problem? The pulmonary hypertension occurs in about up to 1/4 of the infants less than 32 weeks gestation, when you assess at 36 weeks of postmenstrual age. In the severe BPD group, it can affect up to 1/3 to almost up to 2/3 of the infants, and that leads to an increased mortality as high as almost 30 to 47% and increased morbidity. This is the most common cause of pediatric pulmonary hypertension, the BPD. And 25% of the cases in the multicenter pediatric pulmonary registry, if you look at it, it comes from the BPD associated pulmonary hypertension. Hence, it's a big problem. And compared to the babies who do not have pulmonary hypertension, the patients who do have a pulmonary hypertension BPD, they have got increased mortality, increased length of stay, increased need for the tracheostomy, increased need for a supplemental oxygen and the gastrostomy tubes on discharge, readmissions, increased readmission rate after discharge, and subsequently the decreased somatic growth as well as long-term cognitive and learning difficulties. So it's a huge problem which we all need to address it. As Professor Satyan described, the pulmonary hypertension can be based on the increased PVR, or it could be based on the increased flow, or it can be based on the increased left atrial pressure. And hence, we need to dissect which one is contributing and how much is contributing to the BPD pulmonary hypertension based on that. So when do we screen for the pulmonary hypertension in BPD? What is the time period we need to screen for them? So echocardiography is the best available tool we have for the screening. And the pediatric pulmonary hypertension networks recommend the following risk factors where we should be starting to screen. So either a baby with a severe hypoxic respiratory failure just after birth, secondary to PPH and physiology, despite the optimal treatment. So if baby has gone through that, then we should be screening subsequently those babies. Or a baby requiring a continued ventilator support beyond 7 days of age. Or if the baby has got a recurrent episodes of the bradycardias and desaturations, or any baby who is stuck on the respiratory support at 36 weeks, we should be screening all of them for the pulmonary hypertension. Levi et al. Said that the babies who are born less than 28 weeks of gestation and they're needing more than 30% oxygen, they should be screened when they're about 32 weeks. So ideally, we start screening our small premature babies from 32 weeks onwards, and definitely at 36 weeks to classify whether they've got a BPD-associated pulmonary hypertension or not. Apart from the echocardiography, pro-BNP monitoring can also be used as a blood test. Not much data is available. It's in a small pediatric studies, and they found that not a single value, but a longitudinal monitoring value is a prognostication of the pulmonary hypertension to response as well as to the whether to see worsening. It's got a high individual variance, but as I said, the longitudinal values are more important. Now, this is the most important slide because my rest presentation will be based on slide. So this is what is the recommendations, a nice flow chart by the Pediatric Pulmonary Hypertension Network Guideline on the management of BPD pulmonary hypertension. And this came from the recommendations of the American Heart Association and the American Thoracic Society. So it's a very busy slide. I'm going to take you through stepwise approach on this one. So we know at 36 weeks, we are going to be doing the echocardiogram. We're starting from 32 weeks. We would have defined whether the baby has got the pulmonary hypertension or not, mild or moderate or severe BPD based on the Jensen's classification. And subsequent to that, you will be then performing the echocardiogram. Now, based on the echocardiogram, you might end up with the pulmonary hypertension not there, then we don't have to worry about, or there's a pulmonary hypertension mild to moderate or the severe. So echo-wise, I'm not going to go into more detail because Dr. Amy has nicely described what are the different parameters we need to look into the for the pulmonary hypertension definition. That remains the same. Having said that, there are some low risk factors and there are high risk factors based on the various measurements which we do, and that can define where our babies falls as far as echocardiographic screening is concerned. So having defined that the baby has got a BPD pulmonary hypertension, how do we go on to manage those babies from this point onwards? So the management of the overall BPD-associated pulmonary hypertension has to be related to the contribution of how much the different component is adding to the disease. And therefore, we need to look at the different aspects of it. It can't be just one single drug or one single point of management. So further down in the algorithm, so we need to look at optimize the gas exchange and accepting the target saturation, which is more than 92 to 94%. So when we go to the ventilator strategies, if the babies are still stuck on the ventilator, we need to change our way of thinking, because in the beginning, when we are ventilating the babies of RDS, we are looking at a different, they have got a low resistance, but here the resistance become higher, the compliance become variable. So the ventilator settings has to be the BPD ventilator settings, which is longer I time, larger tidal volume because more dead space has happened over a period of time as well, lower respiratory rate and higher PEEP. So this is the standard dictum for a management of the BPD ventilation settings to allow the gas emptying and a better gas exchange. Thus, in short, I can talk about the ventilation. We need to manage the lung congestion, and this is where the diuretics may come to play. Yeah, so trial of a diuretic to see if the babies will be helped or not. Controlling the inflammation with the use of steroids to try and get the babies off the ventilator, so that we can prevent at least aortogenic ongoing lung disease from the ventilator itself and appropriate treatment of the infections. Occasionally, babies who are already extubated but stuck on the non-invasive ventilation, if their pulmonary hypertension is worsening, then we might have to actually consider a tracheostomy as a long-term ventilation to halt the pulmonary hypertension, because we don't want it to be continuously worsening. As far as the oxygen is concerned, oxygen is like a drug. Everybody has mentioned here. And the saturations here, these babies are outside the ROP range. So here our saturation should be more liberal, and we should make sure that they get a saturation more than 92 to 94%. Because depending on the amount of the baseline pulmonary hypertension, so in this graph, if you look at the pulmonary arterial hypertension baseline from 0 to, so this is normal, anything more than that is a pulmonary hypertension. So if you have the saturation in the higher range, yeah, depending on the when the babies desaturate, depending on what the pulmonary hypertension level is, the pulmonary hypertension go really worse in those episodes of intermittent hypoxia. So it's a key that we maintain the saturations and minimize the intermittent hypoxic episodes. Having looked at the respiratory management, you go into the other aspects of the management of the BPD to support. So these babies can have either RV dysfunction or LV dysfunction. So for the RV dysfunction, we need to make sure that we have the appropriate volume optimization. If the volume is too much, then we might need to use the diuretics. Decrease the afterload with the judicious use of pulmonary vasodilator here, after ruling out some of the things like the pulmonary vein stenosis on the echocardiogram at that stage. Contractility, so these babies might have the contractility issues, so you might have to use appropriate inotrope or inodilator depending on the sickness of the baby, and make sure the ductal patency, assessment of the duct here is important from both point of view, either to close the duct or to use it as the critical pop-off valve. So that judicious assessment need to happen here. Similarly, LV diastolic dysfunction can happen because this is a combination of pre-capillary and post-capillary pulmonary hypertension in the BPD. And hence we need to address the careful pulmonary vasodilatation, enhanced lucitropy with the milrinone, LV afterload reduction, and the use of the diuresis. Sorry, I'm not able to go into details of each one of them because in 15 minutes it's difficult to cover all of them. So I'm just giving the salient features here. Now, these babies can have the shunts as well. So if the PDA is persisting here, what we call as a moderate to large PDA beyond 36 weeks, some people have recommended that the closure here will prevent the progression of the BPD, but the relation is not very straightforward and it needs to be addressed. Is that PDA required for the right heart support or not, need to be considered. Similarly, the babies who have got the ASD, they are at a higher 2.4-fold increase risk of pulmonary hypertension. And a lot of small studies have shown that if you were to close these ASDs with the device closed earlier, the pulmonary hypertension will improve. Some of the other general neonatology causes, the risk factors which need to improve is rule out the gastroesophageal reflux because these babies are very agitated. They can have a reflux and aspirations. So doing pH metry, impedance study, or video fluoroscopy. Rule out the obstetric apneas because again, obstetric apneas are going to cause the intermittent hypoxia and that will further cause the increased pulmonary hypertension. So sleep study may be recommended. And for the pulmonary hypertensive spells, use the adequate sedation to be important. As I said before, in the phenotypes of the BPD, they can have associated airway abnormalities and therefore a flexible bronchoscopy to rule out the subglottic stenosis from a long-term ventilation or a vocal cord palsy or a dynamic obstruction like laryngotracheobronchomalacia need to be ruled out. And for a lower airway disease, sometimes you will have to do an air bronchogram to look at how much is the lower airway disease component. And CT angio to rule out the pulmonary vein stenosis or any other vascular ring which may be present, which we have not looked at it in the babies. Having looked at all this comes the pharmacotherapy. Currently, every single drug used in BPD, pulmonary vasodilators, are off-label. There's no evidence. Everything is based on the expert opinion and consensus based. The RCTs are required for the evidence-based medicine. But we still need to do something about it. Yeah. So the pulmonary hypertension target therapy currently focuses on the 3 common pathways: the nitric oxide pathway, the endothelin pathway, and the prostanoid pathway, the prostacyclin pathway. So these are the 3 different pathways as Sachin showed earlier. Now, when you looked at the various drugs, including INO, in the preterm babies, again, it's not haven't given the FDA approval. So none of the drugs have got the approval. But the top 2 are more commonly used, and the bottom 1 are less often used. So among the pulmonary vasodilator, as I said, oxygen is the initial one. So keep your saturations. And when we say keep saturation, we only do water on for 5 minutes and we walk away. What do we tell our nurses? How can they improve keeping the oxygen in a normal range? Use of histograms, oxygen index, if they are having arterial line, or oxygen saturation index, which is very easily they can monitor. Nitric oxide, again, for a short-term use in acute exacerbation of the pulmonary hypertension, BPD can be used. And as Satyan explained, it may not be, the response is variable, and sometimes it may just be a response because of the improving of the VQ mismatching. Sildenafil, now again, cardiac catheterization has its own risk as well. So we need to decide what can we do empirically to help this baby. So sildenafil is the only one which is currently recommended that we can use without cardiac catheterization as a single drug. We all know the mechanism of action. Moronian et al. Showed that out of the 25 patients they studied, they had about 18 patients with BPD, and 88% showed echocardiographic response to the pulmonary hypertension improvement with the use of sildenafil alone. Tadalafil is just a sister or brother of sildenafil, just with longer half-life, but we do not have enough data on its use. Cardiac catheterizations, when to do it, is very important thing if your babies are not getting better. So it is before using any second pulmonary hypertension drug, like before considering the bosentan or anything else. If the pulmonary hypertension is worsening on starting the sildenafil, again, you need cardiac catheterization. Again, if you have started some medication, but there's no response, and baby is more than 3 months of corrected gestational age, that needs the cardiac catheterization. Or if you are on echo, you're concerned about the pulmonary vein stenosis or any collaterals, to quantify them. Or if there's an atypical response to your therapy, or baby is having a failure to thrive, or any major interventions like tracheostomy, if you're planning for the baby, best to do a cardiac catheterization before that. And it will give you a more definitive answers on the pulmonary hemodynamics, determining disease severity, any associated cardiac lesions, quantifying the shunt, whether to do the ASD closure or not, whether to do PDA closure or not, what is the heart function. It can give a variety of information, which is important before the interventions. So just in summary, once you have had your screening echocardiogram defining the severity of the pulmonary hypertension, optimizing the respiratory ventilation strategy, cardiovascular strategy, starting the sildenafil, and then going through the monitoring with the serial echocardiograms or pro-BNP, and then considering the first-line drug, and then going on to the second-line drugs. So just a very basic one slide on bosentan is the most commonly used the second drug, which acts via the endothelin pathway. There have been 2 randomized controlled trials in the use in the PPHN, one showing benefit, the other one isn't. So most of the reports are from the case series, and we still need the RCTs on these BPD babies as yet. These are the brothers and sisters of the bosentan. Prostanoids, the most experience is with the use of the inhaled prostacyclin that is usually used as the third-line agent in the BPDs. It's more expensive. So again, the resource limiting country, we may not be able to use that. Subcutaneous treprostinil can be used as well. It is safe, but it needs more studies, more numbers to quantify that. And the very recent study on the BPD, they said the monotherapy with the sildenafil is the first, and use of the other things is add-on therapies as required. pulmonary vein stenosis, very vividly described earlier, but that needs quantifying and the treatment subsequently. Once you find pulmonary vein stenosis, it's not easy to treat such babies. So stenting, dilatation, maybe even the medical therapy like sirolimus to halt the prognosis. But these babies do badly. Again, if there's a large collaterals have developed over a period of time, occasionally they may need embolization of them to help with the pulmonary hypertension. Having gone through the pathway, these babies on the BPD, they do develop systemic hypertension, but usually they resolve over a period of time. There is a lymphatic dysfunction as was described as Samir earlier. Again, there is no easy solutions to that. Long-term outcomes, it clearly depends on the associated comorbidities. But usually the pulmonary hypertension BPD resolve over a period of 1 to 3 years. However, infants who required a prolonged invasive ventilation therapies and those who had the right heart dilatation at discharge, they do take a much longer time to come off the pulmonary hypertension therapies. These are the various future areas of research because, as I said, there's no RCTs for the treatment. So these are the various different areas of research. Thank you very much. Any questions? Thank you. Sorry, I had to rush through my slides. I don't know how much time I took, but thank you. Any questions?
So I'm going to open the floor to questions. Just wanted to confirm that we've got Satyan and Amy and Yogen as well with Dr. Soni. So any questions? I have one question that I'm very keen to ask Satyan. So we talked about the different phenotypes for management of pulmonary hypertension. One of the phenotypes that we face, and which is quite common because of high NSAID use, is the in utero closure of the duct with the failing right ventricle. And naturally, both diagnosis, if you have a dysfunctional right ventricle with a duct that's closed for pulmonary hypertension, is incredibly difficult. In reverse limited settings, nitric, may be difficult to kind of use. How and what would you advise in terms of management of that?
Yeah, that's a great question. First of all, Dr. Soni, that was a phenomenal talk. You have summarized so much of really important information very briefly. So great talk. Thank you so much for providing us. Yogan, Amy, and Dr. Soni, please chip in for these answers because these are complex questions. And anybody in the audience, if you have strong opinions on how to manage these patients, please chip in as well. So the question you ask about antenatal ductal constriction resulting in PPHN is a common one. What is being referred to is instances where mothers unknowingly take cough and cold medications that have ibuprofen or something similar in them, resulting in prenatal ductal closure. And ductal closure prenatally tends to force blood into the pulmonary circulation, causing endothelial dysfunction. And many of these patients are born with significant right ventricular hypertrophy and completely remodeled pulmonary circulation. So interestingly, quite a few of them, what is being recognized, although it's not much written in the literature, is that these are not just patients on echo who have a completely closed ductus. Many of them may have a transient constriction antenatally causing this problem. Unfortunately, it might still be opening periodically, but you find these changes on echo. We recently had a patient with very similar findings where when we went back and asked mom, she had taken a cold medication at around 35 weeks of gestation for a couple of weeks, and then we suspect that's what caused this issue. Thankfully, most of them respond fairly well to inhaled nitric oxide. And so because it's a resistance-driven condition and RV is not functioning, reducing PVR is the goal here, and many of them respond to inhaled nitric oxide. And if they don't, a combination of inhaled nitric oxide and sildenafil works reasonably well in them. In areas where you don't have access to inhaled nitric oxide, a decent dose of sildenafil should be the first-line approach to these patients. But the issue here is that the vasculature, unlike acute vasoconstriction, here the vasculature is quite a bit remodeled and may not respond well to just the use of sildenafil in these patients. So my second-line drug in these patients, as long as the patient is tolerating something orally, is to go to bosentan a bit sooner rather than later, because both bosentan and sildenafil act through different pathways, as Dr. Soni showed us. And they both have the capacity to remodel and reduce the attenuate the vascular media and cause less pulmonary arterial hypertrophy in these patients. So I tend to, as soon as the patient is feeding even like 20 to 40 ml per kg orally, I jump on bosentan as long as the liver functions are good and continue that for a period of time to remodel the pulmonary circulation. But I'm eager to hear thoughts from others on management of this condition.
Satan, I completely agree with you. That's a great plan and it works most of the time. One thought really, most of these babies in utero, they normally go into early onset of labor and ducts should be still openable. What it means really, duct does not close functionally like anatomically until good, it takes up to 2 weeks. At least 4 or 5 days, it will be still patent, although we will not see even in the echo. So in those cases, I definitely try some prostaglandin as well. Like prostin, in that case, a small dose, really 10, 15, 10 to 20 nanogram or 0.01, 0.02 microgram. That it can open up the duct. Again, same principles what closing duct in a PPG setting, that might help as well. Of course, in certain situations where duct is completely closed and fibrosed, it will not work. And strategy what you opted in, that's completely agree with that.
That's a great suggestion. In fact, in this patient, we tried it and it was completely closed. I think, as you rightly pointed, it was probably fibrous and didn't really help.
Yeah, agree with Yogen. I think sometimes we have tried, sometimes it responds, and if it's going to respond, probably in first 12 hours, it will open up. If it doesn't, probably then you better stop prostate. Otherwise, it causes hypotension and then worsens your right to left shunt. So that's worth trying. Yeah.
One good thing, as Kiran and Yogan are pointing out, is that this is a drug that has most children's hospitals, most hospitals carry PGE1, at least to keep the maintain patients with CHD. So access is not an issue, and it's a really wonderful. It's a very powerful pulmonary vasodilator too. So it's definitely beneficial.
Any questions from the
Maybe
audience?
I can ask.
Go for it,
Alex,
Yogen.
sorry.
Yeah, that's right.
Maybe I can ask one question as well there. First of all, absolutely great talks, Sata and Amy. That was absolutely fantastic talk, and same Dr. Sonia as well. I think really enjoyed both the talks. One question to Dr. Sonia, maybe a question and comment as well. What about the use of diuretics? You said like obviously that's recommended as well and using the BPD. How do we decide? Like we said, we can try. How long you try for? 7 days, longer? Or is it a better way to decide on these patients, which will respond, who will not respond?
I think when I said the diuretic use, obviously not in the early part of the PPHN or the PD element there, but I was more about the babies who might have the congestion in the lungs as well because it's in the BPD, it's a combination of pre and the post capillary pulmonary hypertension could have some component of the lung dysfunction, could be early development of the pulmonary vein stenosis. Those babies may improve with some diuretics use. Certainly, if I don't see an improvement within a week, then I wouldn't be continuing any further on that. But again, your cardiac assessment of the RV dysfunction, the right atrial load getting more on that and reflecting on the liver congestion. So clinically, you may be able to make a decision whether to continue the diuretics or not, but don't keep on increasing the dose, because keep on increasing the dose means something what you have done previously, like maybe you have used a sildenafil, which was not required to be used. Maybe this baby has got something else like pulmonary vein stenosis need to be ruled out. So I think a small dose of over a week, if things improves, well and good. If it doesn't improve, don't keep on increasing and investigate further with a serial echo.
No, thank you, Dr. Sonia. I think that's a great answer, and like that's what we do in practice. One thing which is changing in the last few years, and a lot of people in the audience, they do lung ultrasound, and tomorrow, I know there's a workshop on the lung ultrasound as well. Like there's some evidence and papers are out there as well, but when we do in practice, the two phenotypes are there, two profiles in the BPD patients. One do have the pulmonary edema, one they don't have significant pulmonary edema. So previously we, just like any other management, we worked blindly, and now I think we can look on these two profiles and look at the early ultrasound along with the echo. And if there's a good going pulmonary edema, and then those you can start, they're likely to respond to diuretics, and there's no pulmonary edema, there's no point of wasting time on that one, and they're unlikely to respond as well. And this we learned from the CVIC and the adult CVIC ICU care as well. They used even the lung ultrasound like even 10, 15 years back to guide the therapy for the pulmonary edema there.
I think I support your Bain's contention on that. Al Medina, who's a close colleague of ours, has done work on actually looking at pulmonary edema post-PDA, treatment with diuretics and improvement. And it's a very valid kind of an observation that often starting diuretics, it takes about 48 hours for you to start seeing those lung changes. So you might not see them immediately, but doing serial lung ultrasound can actually help. We've got one question from Dr. Gunda.
Hello, thank you everyone. This is Ranjit, one of the neonatal consultants from Abu Dhabi, Ahlia. Fantastic talks by everyone. My question to Professor Satyan, I just want to see your experience and opinion about use of milrinone in extreme premise.
I think the question is how efficacious we think it is based on the fact that we don't have a lot of literature and studies, but this is a group of babies who also have pulmonary hypertension.
Yeah, actually, we do have studies. There is this trial called the Paradises trial that was done like 15 years ago from, I believe, Australia, where they looked at milrinone for transitional hypotension in premature infants. And there are some papers from Patrick's group that have looked at use of milrinone in preterm babies with pulmonary hypertension as well. It's very effective. It's because preterm pulmonary hypertension definitely has a component of RV dysfunction associated with it, and sometimes LV dysfunction as well. So many of us tend to jump on to milrinone as the second line of drug after inhaled nitric oxide while managing pulmonary hypertension in preterm infants. The catch with preterm infants is that their pulmonary hypertension is so multifactorial, and predominantly it's due to parenchymal lung disease itself. So no matter what drugs you use, the outcome doesn't change. So there are more and more database-based research coming on preterm infants, especially the 22, 23-week ones, where whether they get exposed to inhaled nitric oxide or milrinone, their long-term outcomes are very similar. But short-term, definitely it's beneficial. The key is to get an echo prior to starting these drugs, because looking for echo evidence of pulmonary hypertension and echo evidence of RV dysfunction or LV dysfunction prior to starting these drugs will really give you a baseline, and you will be able to fine-tune therapy with that. So I use a lot of milrinone in premature pulmonary hypertension, especially if the echo shows evidence of dysfunction. And Amy Yogan and Kiran and other people, Mohit, you can comment on this as well.
So in Southampton, where I've worked, we use it quite commonly, especially post-PDA ligation. It's something that's bailed us out on numerous occasions. But yeah, I'm keen to hear from the other experts. Amy, Yogan.
We use it a lot at Iowa in our preterms with pulmonary hypertension. I feel like it's particularly helpful in those preterms with pulmonary hypertension who might have had some sort of asphyxia. The caveats to using it is, one, always making sure that you're treating the right physiology with it. And then two, we tend to start with a lower dose because we are worried about the hypotension that can occur. So we'd rather start lower and go up rather than be too aggressive. The one thing that we've noticed and have a case report that's being published is actually the use of muscle relaxant while on milrinone in our preterm babies. And we think it probably has to do with just lack of metabolism with the renal excretion. So just even more caution in our preterms who might be muscle relaxed using milrinone because it can cause hypotension. Pretty profound hypotension. I witnessed that myself as a hemodynamics fellow.
Yeah, just a comment, and just in line with Sathan and Amy, really. Yes, it's a great drug. It's a really good, great drug, lucitropic effect to improve the cardiac functions and also drop the PVR. Still, I think probably very underused, really. And the two important points here with the use of milrinone, obviously, one is start at the low dose, what Amy said. I normally start 0.25 and gradually build up slowly. If you need to 0.5 or 0.75, gradually go really 6 to 12 hours afterwards. Second, do not give the loading dose. If you speak to a cardiologist, you do not have experience in using milrinone, after you'll ask a cardiologist, and they usually on the bigger children, they're mostly on the patient with the myopathies, and they tolerate the loading dose. But our babies, either extended preterms or those with the sick babies, the PPHN, they will not tolerate the loading dose, and people burn their fingers with the hypertension. So normally, get it on early on. Takes 3 hours to build up in the system, educate blood levels, but that's okay to wait. You do other things in the meantime. The second, Satyan already mentioned, really, echo is really important. Vasopressin, milrinone, they're really fantastic drugs, but all those should be guided by the echo. Typically, vasopressin, again, I can tell many times is bailed out pre-ECMO, and we avoided the ECMO with the vasopressin as well in this group of patients. But once you go away, and like in the year unit also, people will see, oh, it's a fantastic, great drug, a great response. The next time somebody used without the echo. And that's where the problem comes. You got this setting with the real poor cardiac functions, and they use the vasopressin where they moderate to severe cardiac dysfunction, especially LV, and then that's cause problem. And then say, oh, I'm never going to use this drug in my NIC after that. So really need to learn how to use these drugs effectively to our benefit.
Thank you, Dr. Satyan, Amy, Yogen, and Dr. Soni for great talks. I second what Dr. Yogen just told, but the only thing is, like, one is bolus of the milrinone, that is one thing, but even with the lesser doses over the last few years, what we have seen, the hypotension is a predominant feature we have been seeing. I don't know why, but this is what we have been seeing. So what we started using is, along with the milrinone, we start with some pressor also, or inotrope. So that maintains the balance. This is what we have seen. I don't know it is particularly with us or it is happening everywhere.
No, Dr. Sani, I think that's a great point, and almost exclusively I will start with epinephrine or always, because you stabilize that part, because that's bound to happen. So most of the time where they say PPHN, there'll be these patients will go on the epi, as Dr. Satyan was talking about, depends on the cardiac function. So most of the patient will start epi, stabilize the blood pressure, introduce low dose, and then we do not see the hypertension at all. So I think even the background, the maintenance of low dose will never, it's not going to cause any significant adverse effects. I'll definitely support that.
Great talks, Prof. Satyan and Amy. I have a question for all three of you online. That at one point, adenosine was being used for the acute pulmonary hypertension because it acts through a different adenosine receptors. And I remember clearly in my training days having sent about 10 babies, out of which 4 came back without ECMO. We all referred to the ECMO, and all 4 of them had adenosine infusion. There have been some case series reports, publications as well, but somehow it has completely gone out of fashion. Nobody's focused on it. Any particular reason why?
So that's a great question. Before the advent of nitric oxide, there were so many drugs being investigated for PPHN. I mean, you remember tolazolin, which many of us with gray hair in the audience probably used, and causing significant hypertension. Adenosine was another agent. As you rightly pointed out, it targets through adenosine receptors, and it's a slightly different mechanism of action. It has quite a few side effects as well. Plus, the effect of adenosine is fairly transient. And so it slowly fell out of favor. And of course, we use it for other indications in the NICU right now. Once nitric oxide became available, the focus moved into INO-resistant hypertension for the most part in the US and other countries. So we do not know how effective adenosine is in that particular situation. And so for that reason, we haven't used as much of it. But you are right, it is effective. So is, there are lots of other drugs that act through different mechanisms that are quite effective. But nobody's studying adenosine that I'm aware of, even in animal models. It was pretty widespread in the late 90s, and then it stopped.
Also, just a follow-up question on that. If the baby has not adequately responded to the initial management of the nitric oxide low-dose epi with milrinone, and echo has been done, and baby has got a normal left ventricular function, as another add-on, but slightly lower blood pressure. Yeah. So how do you decide whether you will add a vasopressin or will you add as norepinephrine? Because they both increase the systemic vascular resistance. They both have, in animal models, at least been shown to have the receptors in the pulmonary vasculature, which will cause the pulmonary vasodilation. Why some people are favoring vasopressin and why epinephrine is not being favored as much in the last 1 decade?
Yeah, I would love to hear other thoughts as well. In fact, I was asking Dr. Pradeep Suryavamshi if you could do a trial in India. Recruiting patients to these trials has become impossible in the US because many of them are sick and we can't do much without consent. So I think the future is in your hands to come up with new randomized trials to evaluate these things. Our hands are tied due to regulatory restrictions. But
in India too.
but it's very difficult to get consents and studies. So we actually have a lamb study going on right now that one of my colleagues, Dr. Deepika Sankaran, is evaluating NAREP versus vasopressin. Practically speaking, the benefits of NAREP are that it's pretty effective. It's a very powerful afterload increasing agent. The side effect, the negative aspect, obviously, is that it doesn't support cardiac contractility. So even if you have a bit of dysfunction, that tends to get really worse. The other side effect of norepinephrine is that it's not as selective to systemic circulation as vasopressin is. Among all the drugs that we know of, when you evaluate the relative effect of systemic versus pulmonary reactivity, we assume that vasopressin has the best ratio there. So if you don't have renal dysfunction, if you don't have hyponatremia in such situations, I would probably go with vasopressin first. And if that doesn't work, then go to norepinephrine. On the other hand, if you have renal dysfunction or other issues, then norepinephrine might be the best drug to use. But we really need a head-to-head trial evaluating these. And we were just talking about it. So Dr. Suryavamshi recently published a paper on bosentan versus sildenafil. And then we were wondering if the next study that should be done in India is vaso versus NAREP, especially given the high prevalence of infection that you see as the etiology of PPHN and hypertension in many countries. Thoughts, Yogan, Amy?
I think I think you mentioned Pardeep. I think we just published a small trial from their epi, nor-epi, but definitely I think nor-epi versus vasopressin is needed. I cannot agree more with you. Definitely, we need more evidence, more trial, and also that's great advice from you. Only small advice in addition, really. Just what are the unit approach as well? Some units never use vasopressin. Nurses take a long time. These are very powerful drugs, and drug errors are one of the things as well. So I think if you want to introduce vasopressin more in your unit, I think it'll be good to train nurses and all of the staff who could be using. Like if I'm on call in the daytime, my colleagues are if somebody's on call at night, I think that's the education part really. And then come the physiology, what you beautifully explained that time.
Amy?
Just real quick, we typically, we started, great advice, making sure that everyone knows the side effects, all of the nurses know the doses. We introduced vasopressin when Patrick came several years ago, and it was a learning curve. Now we use it very well. Typically, I think for us, if a patient is on less than 60% oxygen, we feel that it's probably safe to try norepinephrine. The concern in animal models, 100% oxygen and norepinephrine leading to the creation of reactive oxygen species. The one caveat to that, though, is every patient is different, and every patient will respond differently. We had a patient who was on 50% oxygen. Their echo was improving, but so we actually transitioned them from vasopressin to norepinephrine just for lower side effect profile. The only thing we did was change from vasopressin to norepinephrine, and our echo went from half to 2/3 systemic to the next day the baby's back in 80% oxygen and had suprasystemic pulmonary hypertension. So every baby and every baby's pulmonary vascular bed is going to react differently to medication. So even if it follows your general rule, you do have to think that every patient might react differently.
I'm going to take this opportunity to bring this session to a close. I think I'd like to express a vote of thanks to Satyan, Amy, and Yogen for their time today. For Dr. Soni for talking to us about BPD. You know, it's been a fantastic discussion. Guys, give everybody a hand. And now for all of you who are here, give yourselves a hand. Go for it. Yeah. Thank you so much.
Thanks, everyone. That was a great session. Learned a lot. Thank you. Have a great day. Bye.
Thank you so much. Thank you. Bye.
I just need all of you to stay for 2 minutes, please. Working? Yes. Okay. Thank you all very much. And thank you for staying till the end, really. It's a fantastic day with some really fantastic talks. I hope you're all going to join us tomorrow as well. We've got the workshops starting in the morning till the evening, the Pocus and Echo workshops. I just want to take 2 minutes to give certificates of appreciation for our amazing speakers that were able to join us today. So we will start with the certificate for Dr. Valerie. Dr. Mohit, can I ask you to just give the certificate for Dr. Valerie, please? And then Dr. Arvanan, Dr. Kiran, can I ask you to please hand over the certificate? Thank you. Thank you very much for your talk. Dr. Naharmal Sponi, Dr. Monica, can I ask you to? Yeah, just a minute, just a minute. No, we can't. Certificate for Dr. Kiran. Dr. Kiran More, thank you very much. And for Dr. Mohit Sani.
Can I request the delegates to just hold on for 2-3 more minutes? We'll have a group photo at the end.
Thank you, everybody, for being here. And thank you for staying till the end. Let's have a group photo.